Gurubhyo Namaha. A very good morning to all our distinguished faculty, respected delegates, and invited guests. I am Kalayarasi Kannan, and I'm going to be a host for today's conference. On behalf of organizing committee, it is our great pleasure to extend a warm welcome to each one of you to DCCON 2026, our annual conference. We are delighted to have you with us and look forward to a day of enriching scientific discussions, knowledge sharing, and professional collaboration. Your presence truly adds value to this conference, and we hope today's sessions inspire meaningful discussions and valuable learning. To formally welcome you all, I now have the honor of inviting Dr. A. Natarajan, Organizing Secretary of DCCON 2026, to deliver the welcome address. Ladies and gentlemen, please join me in welcoming Dr. A. Natarajan. Please put your hands together and welcome him. Thank you.
Thank you so much. It's a great pleasure, and good morning to everybody, and respected senior professor and distinguished faculty, esteemed colleagues, and dear friends. It gives me an immense pleasure on behalf of Deep Club to extend a warm welcome to all at our annual conference, medical conference, that is DCCON 2026. As many of you know, D Club is committed to promoting continuous medical education. Throughout the year, in addition to the DCCON, we proudly organize D Mantra conference every November during World Diabetic Day, bringing together experts to share the latest advancement in the diabetic care. Medicine is an evolving and in an unprecedented pace, and new evidences, updated guidelines, and emerging therapeutics continuously reshape the way we care our patients. And as clinicians, learning is not an option, it is a lifelong responsibility to all of us. And conference like DCCON provide us the opportunity to learn and enhance ideas and translate knowledge into better patient care. Today's scientific program has been carefully designed to focus on conditions we encounter every day in our clinical practice: anaphylaxis, cough, osteoporosis, thyroid disorders, abdominal pain, with practical evidence based on approach to the diagnosis and management. One of the highlights of today's conference is panel discussion on hypertension with various comorbidities, where experienced experts will discuss real-world challenges and practical solutions for one of the most common and complex conditions which we manage every day in our day-to-day practice. We also have an important section by our infectious disease specialist, who will update us on the latest recommendation on HIV, hepatitis B, and dog bite management, the topics that remain very highly relevant to everyday medical practice. We are truly privileged to have with us an outstanding faculty and eminent speaker, each an authority in their respective fields, and I sincerely thank them for sharing their valuable time, knowledge, and expertise with us. I am confident that every section today will offer practical insights, stimulate meaningful discussion, and equip us with the knowledge that we can apply in our clinic from tomorrow onwards. Once again, I extend a heartfelt welcome to each and every one of you in this Scientific Week DCCON 2026. May today's conference be enriching, interactive, and intellectually rewarding to all of us. Thank you, and I wish you all a wonderful conference. Thank you so much.
Thank you very much, Dr. Natarajan, for that warm welcome. Your words have beautifully set the tone for what promises to be an enriching and memorable conference. I am looking forward as well, because I'm generally intrigued by all scientific discussions. So yes, now to take us through the scientific sessions of the morning and introduce our distinguished speakers. Now I invite Dr. M. Swamikannu Murugan, Director of Internal Medicine, MGM Healthcare, and chairperson for the session, and Dr. A. Natarajan, Senior Consultant Diabetologist at his own center in Anna Nagar, Chennai, and chairperson for the session. May I request Dr. Swamikannu Murugan to please come forward and introduce the speakers. Please put your hands together and welcome Dr. Swami Kannamurugan. Thank you.
I think at the outset, I would like to thank the D Club for organizing DCCON 2026. And we are in the pursuit of empowering, elevating, and excelling in our field, in the field of medicine. Like Dr. Natarajan said, learning is a responsibility. So very nicely he said. And we'll start the session with none other than Dr. Parandaman. Parandaman is a very close friend of mine, and any conference in Chennai, it will not be without Parandaman. And he has got such a it is very difficult to find people who shine in both academics as well as in clinical practice. He is one of those rare species. We are very lucky to have for the DCCON conference. He'll be our opening batsman. He's going to deal with the subject cough. Cough is a very common problem for which people approach us. It can be from it's a very vital symptom because it can clear the secretions from the respiratory tract, effectively preventing further infections. The one symptom and many diseases we have different types of cough: wet cough, dry cough, brassy cough, post-tussive cough. So I can go on telling, but I'll leave it to Dr. Parandaman. I'm sure he will make it very interesting, the cough subject. Thank you for the opportunity. Dr. Parandaman will take over from here.
Thank you very much, sir, for your kind words of introducing me with a pleasant introduction. At the outset, I'd like to thank the organizers, Dr. Natarajan sir, who is the secretary, and founder president Dr. Dhanabhadan sir, and our team for having given me this wonderful opportunity to talk on the common symptom, the cough, types of cough and management of cough. I think everyone know a cough, everyone know to treat a cough. I just highlight about what are the common symptoms and how to approach the cough. We all know the cough is the number one symptom in our clinical practice, in a day-to-day clinical practice. And it was estimated that 10% of the adults across the globe are suffering from chronic cough. Then what is cough? Cough is a forcible expiration against a partially closed glottis following stimulation of the cough receptor in the respiratory tract. Why the cough? Is cough is good or bad? If you get more full cough is bad. Good cough is good. How cough is good? Cough is a protective response. If there is no cough reflex, you develop pneumonia, you develop all complications, all aspiration pneumonia, and then of course the lung flooded with the fluid. So they succumb to any complications or disease following respiratory illness. So it forcibly excretes out the secretions, and foreign body expels out the foreign body. So, but mediator is a vagus nerve. So vagus nerve is which stimulates a cough reflex and expels the foreign body inside the respiratory tract so that the inspiration and expiration is normal. And what the disturbance due to? If you have persistent cough, you have sleep disturbance, social embarrassment, sometimes urinary incontinence, and musculoskeletal pain and fatigue. All these are the simple complications of the cough. What are common types of cough? We have several types, we will discuss it later. What are the common types of cough and how to approach it? The first most common is a viral infection, following cold, running nose, cold cough, and which is the most common is acute onset. Till yesterday patient all right, suddenly durable cough, running nose, cold cough. and it might be initially it's a dry cough and progresses to the productive cough, and self-resolution occurs in 1 to 3 weeks. That's why most of the time we don't give much importance to cough, because the self-resolution occurs, because the viral cough, it subsides by itself, and we sometimes, most of the time, we may not take medicine at all. There are certain types of cough following viral infection. It damages the respiratory epithelium, exposes the nerve endings to the environment, and even the simple allergens like a dust, smoke or cold, it stimulates now, puts a persistent cough, it's a prolonged cough. So what initially a short duration become longer duration, and usually associated with the sneezing, running nose, cold, this allergic cough. So anyone who having a running nose, sneezing, allergic cough, anyone acute onset cough is a viral cough, and those who are asthmatic cough, where paroxysms of cough and nocturnal exacerbation, and the cough is associated with slightly wheeze. Again, they respond only to the bronchodilator. The first one, no treatment; second one, anti-inflammatory; third one is bronchodilator. See the different type of cough management in all the states. And fourthly, the GRD. GRD in those days when we studied, we never focused on GRD at all. In 20 years ago. Now the GRD cough is more common because of the lifestyle changes, obesity, and all other less inactivity, and this adds reflux into the esophagus, stimulates the cough. Even if you give whatever the bronchodilator, anti-inflammatory, nothing will work out except the acid suppression. Then third thing is the whooping cough, pertussis. Some that now pertussis no more is very common, but rare do occur, and that is again you can prevent by vaccination. And at another problem is the drug-induced cough, ACE inhibitor cough. Nowadays, people are using ACE inhibitors for hypertension. 1/3 of the population of the world are hypertensive. They are taking ACE inhibitors that can have cough, so you have to load that cough. Apart from that, what is more interesting is the ear is often the first diagnostic instrument in cough. Like a stethoscope, ear is an instrument for cough. How does? See, just listen to the cough sound. You make the diagnosis. Where is the problem? What is the problem? You can treat all. So what is that? Barking cough. Barking like a dog. So it's a barking like a dog. That cough is a laryngitis. You just make a diagnosis of laryngitis. Sound, you make a diagnosis of laryngitis. Husky cough. Laryngeal environment inflammation. Again, we associate with hoarse voice. That is called laryngitis. So laryngeal edema, laryngitis. Brassy cough, as our chairperson already mentioned, is a metallic, high metallic sound, persistent, harsh cough, is a sign of tracheal compression. It is not a viral cough, it is a sign of tracheal compression, it is a tracheal tumor, retrosternal tumor, suprarenal tumor, and sometimes aortic aneurysm. See that the tone of the cough will tell you what is the diagnosis. Then bitonal cough, the two tones in a one cough, that is called bitonal cough, that is getting partial paralysis of the vocal cord. So one side good sound, other side low sound, so that's called bitonal cough, and that's bovine cough, low tone. I think most of you have heard the bovine cough, low tone and long duration. That's a particular cough is very sign of recurrent laryngeal palsy. So you can feel, you can tell the recurrent laryngeal palsy just listening to the cough. It's very difficult to diagnose clinically other than that. And whooping cough, repeated cough, and pertussis, hacking cough. Hacking cough is typically in the smokers and those who are in GRD, persistent dry cough, hacking cough, that's irritating cough. And staccato cough. Staccato cough is one, is a machine gun-like cough. It's a rapid repeated cough. It's in chlamydia. Chlamydial respiratory infection is very less common, but still, if you get a staccato cough, you can make it. Paroxysmal cough. In paroxysmal cough. It's non-stopping cough, bronchial asthma. Then wheezy cough, bronchial asthma, COPD, foreign body. Then nocturnal cough, asthma. Morning cough, COPD. Positional cough, bronchitis. So many diseases can be diagnosed just listening to the cough. Friends, recognition of these characteristics of the cough can rapidly narrow the diagnosis, narrow down, guide the investigation to a limited extent, and it diagnose, prognosticate, and treat if you listen to the cough. Then all the clinical assessment, of course, you know that history, examination, and the history, duration of the cough, timing of the cough, triggering factors. Triggering factors is very, very important, and sputum color, medications, was there any medication, especially ACE inhibitors, beta blockers, and smoking history is a very important history to analyze the, localize the cough pathology, and the vital signs. So you see SpO2 is low, cough, pulmonary edema, or pneumonia. Then ENT, you have to post-nasal drip, ENT, you have to load, and chest bilateral auscultate for a wheeze, rolls, and it is a reduced breath sound. And then abdomen, you have abdomen, epigastric pain, cough, epigastric pain, GRD, and clubbing. If you have persistent cough with the clubbing, think of malignancy. You can just make a diagnosis of malignancy looking at the cough and looking at the clubbing, and of course, red flag sign, hemoptysis, weight loss, and signs for a malignancy. And see that now the question is that GRD is a GI problem, esophageal problem, gastroesophageal problem. How does it produce cough? What ways connect to a lung to produce a cough? It can produce abdominal pain, it can produce abdominal distension, it can produce discomfort. How can it produce cough? Yes, there are two mechanisms. One, the direct connection and indirect connection. Direct connection is the refluction of acid, damaged, and it goes micro aspiration to the throat and goes to trachea and produces a cough receptor. That's one can produce. Second thing is indirect vagal reflux. There is nociceptive reflux on the esophagus. If acid reflux is there, damage the nociceptive reflector, it triggers the vagus nerve, go to the brain, vagal center, produce a cough. So the different types of mechanisms of cough is there. So how the acid reflux to cough? This is that one, as I already told. If acid is reflux into the esophagus, it relaxes the lower esophageal sphincter. Again, further reflux, nociceptive receptor stimulation, damages the neuron endings, and stimulation through the vagal nerve. That's what I already alluded to. And of course, chronic inflammation of the nerve. This is called hypersensitivity. So you see the bronchial asthmatics are having more and more because of the hypersensitivity, hyperreactive bronchus. Similar to that, GRD also hypersensitive, hyperreactive because of the inflammation in the esophagus connected to the bronchus. That is the cause. So these are the areas we work at. Then if such a case is there, how to approach cough? The approach is 4-step approach. First step, you identify and determine whether acute cough, subacute cough, chronic cough. If it anything less than 3 weeks is acute cough, it fit into the viral infection or self-limited, and disease, a post-nasal drip, all these things, sometimes maybe allergic bronchitis also. If anything between 3 weeks to 8 weeks is a post-infectious cough, especially viral infections, and whooping cough may be very common. Sometimes resolving pneumonia, it may be there, and it warrants investigation. So any cough more than 3 weeks warrants investigation. And chronic cough, very common with asthmatic, COPD, upper GI, the respiratory tract infections, and ACE inhibitor. So don't forget to ask the history of drug, especially ACE inhibitors, this enalapril or ramipril with, and again beta blocker, and sometimes it may be a cough due to lung tuberculosis or malignancy. The second step is that step 2 is a productive cough or dry cough. If it's a productive cough, that means there is a secretions are more and is associated with the bacterial viral infection, and the secretions are more with the pneumonia, bronchitis, bronchiectasis, COPD. So you need to evaluate, need to investigate and treat the patient. Then if it is a dry cough, again there is no mucus produced, only irritation, again very common with viral infections, bronchial asthmatic, COPD, allergies, drug-induced ACE inhibitors, GRD, dry cough, interstitial lung disease, dry cough. If you have severe violent extensive extensive rods, but auscultate, but only dry, no secretion at all, is interstitial lung disease. You can make a diagnosis of interstitial lung disease, just auscultate, violent extensive rods, but no secretion, ILD. So that's the thing. Step 3, look for warning signs. Let us not imagine or take it that is a viral infection, simple infection, don't neglect it. So look for the warning signs. What are the warning signs? Anyone comes with the blood in the sputum, anyone comes with difficulty in breathing, anyone comes with the chest pain, then high grade fever, rapid progression, breathlessness, of course you think of the voice change, you think of the warning sign of underlying severe disease. So according to that symptoms, you can localize the disease, what's the pattern. The step 4, having diagnosed is something, warning signs are there, is maybe something organic, you go for an evaluation of the patient with the cough. Step, there is a level 1 investigation. Basic, straight away don't go for a CT chest. Take X-ray, chest, CBC, ESR, CRP, and of course sputum examination. Flowmetry you can do, peak flowmetry, but asthmatic you can do it OP. This is the first line investigation. Then if it does not give clue, you go to the second line investigation. If the cough is persistent, it is especially more than 3 weeks, you get CT chest, HRCT to rule out bronchiectasis and malignancy, and CT paranasal sinus, and sometimes 24 hours urinary pH of the stomach that might give a clue whether it is a GRD. Third step is a specialized investigation like bronchoscopy, bronchial provocation test for bronchial asthma. Of course, you can do the laryngoscopy and reflex sensitivity. So you specify or go by the levels of investigation as per the symptomatology and severity and the duration. Step 4, treat the underlying cause. Cough therapy is not important. Giving antisuppressant of the cough and giving antiprotective or mucolytic, no use. What is the best treatment for cough? Treat the cause. That's the best treatment. What are the cause? If a bronchial asthmatic is there, don't give cough suppressant, give inhaled steroid and bronchodilator. That's all. That is the solution for it. Then if you have COPD, again bronchodilator, smoking. If you smoker, smoke cessation is very important. Pulmonary rehabilitation you have to do. GRD, acid suppression. Don't give cough suppressant, don't give anti-inflammatory, don't give bronchodilator, give acid suppression. That's the treatment for cough. And of course, infections, you have to give antibiotics. ACE inhibitor, stop the ACE inhibitor. That is the treatment. No need for antidepressive, antitussive drugs and bronchodilators. Of course, bronchiectasis, you need to give bronchodilators and antibiotics. And see, cough has got its own complications. There are 5 B's complication. Just cough complication. What are complications? B is, first B, it will break the ribs. If a cough is forcible, it can compression of the chest, it is to fracture of the ribs. 9th, 10th rib very commonly affected, and sometimes 5th rib also. It will break the rib, sometimes break the vertebra. In already this really frail patients, it is possible. Then bleed. See, most of the time I have seen younger individuals comes with persistent cough with the subconjunctival bleed. That's bleed, not only subconjunctival, retinal bleed, rectal sheath bleed, hematoma, sometimes forcible cough, then produce hemoptysis. The third B is blackout, cough syncope. They cough, suddenly lose consciousness. Then all the patient, attenders, everyone rush into the hospital, so unconscious, some fits like this. It is only a cough syncope, just treat the cough, and some urinary incontinence there. Bulging, not only thus, it will bulging, that means you can have hernia, persistent cough for longer duration, they have hernia, pelvic organ prolapse, and stress incontinence will be there. Then burst. So persistent cough, especially chronic asthmatic and COPD, so forcible cough can have pneumothorax, pneumomediastinum, a rare diaphragmatic, and rarely esophageal rupture can occur. So such a forcible cough can do anything. So be careful with the cough. Then management principles are simple. Is general measures. Then is a productive cough, dry cough. What are general measures? Any cough, sometimes commonly is the irritation, and mucus. The secretion is mucus thick. So hydrate the patient. Then give some honey, not less than 1 year of age, and adults and children more than 1 year you can give. This is a low engine effect. There is a soothing effect will be there. And the humidified air, you can give steam inhalation. And of course, you give elevate the bed. A person, especially who is having cough, when a persistent cough is there, it reflects into the esophagus, it produces a GRD cough, so you elevate the bed end. See that these are the general measures for all cough. Then, if it is a productive cough, you give expectorant, guaifenesin is a mucolytic, and steam inhalation is useful, plus chest physiotherapy, and treat the underlying cause and avoid cough suppressant. If the productive cough is there, avoid cough suppressant, like dextromethorphan, it is centrally suppressing. And if it's a dry cough, give cough suppressant. See, one area you give cough suppressant, other area don't give cough suppressant. Dry cough, give suppress a cough, give dextromethorphan. Productive cough, don't give that. It is contraindicated. Not contraindicated, but it's not advised. So, antihistaminics for allergic cough, then GRD, of course, you have to do acid suppression. Especially you ask a patient for only drug is ACE inhibitors, ERBs, so that it will prevent the cough. What are treatment strategies? Again, treatment strategy depends on the cause. So, if you have upper respiratory infection, you give antihistaminic. There is the first generation antihistaminic like chlorpheniramine we can give, and inhaled corticosteroid can give if it is upper respiratory tract infection causing the problem. If it is asthmatics, inhaled corticosteroid mainstay, and give bronchodilator, short-acting, long-acting bronchodilator, and muscarinic receptor, and then leukotriene receptor antagonist also can give. If it is GRD, you give acid suppression, but in GRD, the acid, there is anti-suppression should be a higher dose. Like you give for acid suppression for peptic ulcer disease, you don't give that, you give twice the dose. two times the dose, 40 milligram BID, like that. So not the ordinary conventional dose. You increase the dose, especially CRD, for 8 to 12 weeks. Only then everything, the inflammation will settle. So if it is a chronic bronchitis, then the COPD, stop smoking, give antibiotic, give LABA, and the short-acting bronchodilators. Antitussives. Most of the time, cough syrups will have antitussives. It's basically centrally acting dextromethorphan. It is centrally acting medicine. It acts on inhibiting the NMDA receptors, and thereby it suppresses the cough. That can be given, but caution should be the serotonin syndrome is very common, so be careful with that. Codeine again is an opioid antitussive. It is sedative, and it can produce constipation. Be careful in elderly. And the one important drug, what I realized is that there is gabapentin and pregabalin. These are the neuromodulators. I never had before preparing for this lecture. I did not know that the pregabalin, used for the cough, it is acts as a neuromodulator center. So it is very useful. That can be given. And amitriptyline. Yes, most of the time chronic cough, especially in female, amitriptyline neuromodulator acts on the cough center, and of course speech therapy you can give. So special situations, children, elderly, pregnancy. Children, be careful, but certain things are not should not be given. And risk elderly, aspiration is very common, ACE inhibitors. Pregnancy, be careful. Avoid codeine. Codeine, it will cause neonatal withdrawal risk, so better avoid codeine in pregnancy. And safer is honey, steam inhalation, saline irrigation, and of course budesonide is safe in pregnancy. GRD, alginate. That is like Gaviscon, like this thing you can give, and PPI if necessary, if severe you can give. So pregnancy you ought to be very careful. And friends, the take home messages are, they determine the duration of cough. Is acute cough, subacute cough, chronic cough. If acute cough, no problem. Subacute cough, investigate. Chronic cough, be alert. Screen for the red flag sign at every visit. Suppose a patient comes to the cough for 1 week, you look for a red flag sign. Like what red flag sign? Is there hemoptysis, chest pain, breathlessness, or clubbing, incidental or associated? Yes, look for it. Then, is there history of weight loss? Yeah, weight loss, elderly man, weight loss comes to the cough. Be careful, that is malignancy. The day one you make a diagnosis of malignancy. Then, acute pressure, presumed viral. If it's acute, presumed viral infection, just treat with antibiotics and supportive measures. Chronic, maybe the bronchodilators you can give for asthmatic and acid suppression. Review medications. You ask the patient what are the medications you are taking. Yes, ACE inhibitors or beta blockers, maybe that you cut down it, and of course escalate to CT, spirometry and bronchoscopy if the patient is failed to produce empirically treatment. Thank you very much for patient listening. Thank you, friends.
Thank you, Parandaman. Very short. Sharply you finished in time.
Yes,
thank you very much. I think we will have the question and answers at the end of the session. We will straight away go into the next topic for the multiple cranial palsies. It's going to be dealt with by Dr. Vijay Shankar, who is the head of the neurology at Apollo Hospital, Chennai, and someone who specializes in the movement disorders. We are happy to have him today, and the stage is yours, Dr. Vijay Shankar.
Good morning, everyone, and thank you for D Club for giving me this opportunity to talk about the common cranial palsies and their management. This lady, she came to me with headache for 10 days, with a tiredness, fatigue, and initially she was treated by a local doctor for just with a paracetamol and zithromycin, because she told that she was tired, fatigue, some discomfort. So it was not as usual sinusitis. So with the paracetamol, suddenly after 10 days, she came with sudden blurring of vision. She told that it was very blurry, I'm not able to see properly. The one history, she told me that she is having difficulty in chewing the food. So what could be the diagnosis? Yeah. So, any new onset headache, jaw claudication, always in the older people, always think about a jaw claudication. It's always temporal arteritis. So, initially the MRI was done, MRI was normal, but when you had done the ESR and CRP, both were high. So, we have asked for a temporal artery Doppler. So, the temporal artery Doppler, usually in a temporal, like a temporal arteritis, mostly the MRI may be normal. So, first thing we'll think about any headache, do a MRI. If MRI is normal, we'll think always we'll struggle. We'll think about it's a migraine, we'll start all the medication. But nowadays we see temporal arteritis very, very commonly because it's a medical emergency, like that neurological emergency. If a patient with temporal arteritis, always send the patient to temporal artery Doppler, and if you see this type of halo sign, most of the patient will have generalized body pain, polymyalgia, rheumatica. In this case, always start the steroids yearly. That's very, very important, because if you don't start the steroids yearly, the vision will be lost and it is difficult to recover. And also, we need to send them for a temporal artery biopsy. So I have sent the patient, started on steroids. Second, I told them to get admitted. They came and they got admitted. We have done a temporal artery biopsy. Temporal artery biopsy was normal. This always we see. So I thought it's a temporal arteritis. If it is going to be temporal arteritis, the biopsy should show something. It was negative. The next question, should I continue the steroids or should I stop? This is what the question, we have the problem. The issue here is two possibilities. One, when you start the biopsy, there is a skip lesions are very, very common because the temporal artery is big. When you do the biopsy, if you take a small biopsy tissue, there is a high chance that biopsy may be missed, the lesions may not be there. Or sometimes, because we are starting the steroids yearly, because we are trying to save the vision, if you delay the biopsy like 3 or 4 days, there is a high chance the steroids will reduce the inflammation. Obviously, the biopsy will be normal. So, no need to worry. If you have a halo sign, don't worry, continue the steroids. That's very, very important. So, if you suspect giant cell arteritis, don't worry about the biopsy, start steroids and continue for steroids, first 500 mg to 1 gram for 3 days to 5 days, then followed by oral prednisone. Wait for the patient. If the symptoms reoccur, then there are new medications such as tocilizumab is available. Then we can start the tocilizumab. So the important point is, if a patient with new onset of older patient, headache with jaw claudication, always suspect giant cell arteritis, always look for ESR and CRP. Recently, when I started the practice, I always send ESR. Many times ESR will be normal. Recently I had a patient, somebody suspected giant cell arteritis, they are sent only the ESR. ESR is normal. The problem is I send the CRP. CRP is more specific than the ESR in giant cell arteritis. So do CRP also and start the steroids. Another diabetic, 66-year-old diabetic patient, sudden loss of painless monoocular vision loss. MRI is normal, no limb weakness, no pain, just a vision loss. What do you think? Stroke, optic neuritis, or retinal disc, CRA, OBRO, the amaurosis fugax, or non-arthritic optic neuritis. So in this patient, if you see, the upper half of the vision is lost. Only the lower half of the vision is preserved in a diabetic. So in this case, always look for RAPD. RAPD means if you flash the torch, one eye will be normally opening, others will be like usually when you flash the torch, the pupils will be constricting. But here in RAPD, the pupils will be dilating instead of constriction. It's opposite effect. And sometimes they can have a disc edema. The altitudinal vision loss is always suggestive of non-arthritic anterior ischemic optic neuropathy. In a diabetic, sudden vision loss, painless vision loss, always suspect non-arthritic vision loss. The important thing is, this is also another medical emergency in a diabetic patient. If they have this type of vision loss, always ask for ESR, CRP, because as we discussed giant cell arteritis, that is one of the most common cause in the elderly. Other one is diabetes is another. Diabetes is another common cause. So always ESR and CRP is very common, and do a MRI, because most commonly we see this in a strokes. If stroke is not there, always suspect non-arthritic optic neuropathy, and start yearly steroids. That's very, very important in this type of vision loss, because even if a stroke we can recover, but if eye is affected, it is a neurological emergency, we cannot recover. So we need to start the steroids at the earliest in these type of patients. So tight control of diabetes, hypertension should be controlled properly, lipids. The main thing is sleep apnea. Many times we don't consider sleep apnea as a problem, so sleep apnea has to be considered and treated properly. So as I told you earlier, check for ESR, CRP, look for pain or painful or painless. Painful means it is a optic neuritis, most likely multiple sclerosis. Painless, diabetic, optic neuritis. Okay. So this gentleman came with early ptosis of eyelid, gradually onset. Mostly commonly his eyes were normal in the morning, afternoon and evenings he developed double vision or sometimes ptosis. So fluctuating, MRI normal, we all know this one. Myasthenia. Always in a myasthenia, the simplest test, bedside test, what we can do is, look for fatigability, a Cogan sign. Cogan sign is ask the patient to look down and up. Usually, when you're looking up, usually the eyes, for us, it will be like this, just look at, it will stay in the center of the eye. For these patients, it will go up and come. That's Cogan sign. But the easiest and the bedside test is keep your eyes back. It's easily, we can do it in the clinic itself. If the patient is having ptosis, if you keep the eyes for a few minutes, automatically the eyes will open. This is one of the highest specificity and sensitivity tests. We can easily diagnose this patient in the clinic itself. No need for high-fi test. If your eyes test improves the diplopia, always it is myasthenia. Easily we can diagnose this one. So it's very common in younger patients, but we frequently see this type of patients. They will think that, okay, it's a myasthenia. We will send for AChR antibodies or Musk antibodies. Most often, it will become negative. Immediately patient will come. So, no sir, myasthenia and chonninga element negative. So, we'll also get a doubt. Am I really? And because AChR is the commonest test we see for myasthenia. Both are negative. Should I start a steroids or should I start before that itself will be more confident, I will start a Gravita. And he will say, come and say, sir, konjam better irukku, ana test la negative irukku, continue pannuma venava. This is a catch situation we'll have always. But the important thing is, there are two types of myasthenia we have. One is generalized myasthenia, we all know. They will have speech problems, swallowing problems, the proximal weakness, difficulty in raising arms, sitting to standing. But the subset of patients who has is a ocular myasthenia. In ocular myasthenia, only 50 to 60% of the patients can have the antibodies positive. Remaining 40% of the patient may not have antibodies. In that case, even though if it is negative, we can continue the like Gravitar and steroids, they will improve. So even though if the test is negative, don't worry, it is myasthenia, nothing else, ocular myasthenia. So just start pyridostigmine. If it is not improving, add steroids. The only thing is we can start steroids, but if it is going to be a generalized myasthenia, usually when we are starting steroids, we always start 1 milligram per kg in a normal patients. But if you are suspecting myasthenia, don't start high dose of steroids, because sometimes at least over the time 60 to 70% of the myasthenia will become generalized myasthenia. If it is going to be a generalized myasthenia, if you start 1 milligram per kg, there is a high chance sometimes myasthenia can suddenly worsen and they will end up in a myasthenic crisis. So the dictum in myasthenia is, if you are starting a steroids, start low, like 10 milligram. Then every week build up 10 to 20, 20 to 30, 30 to 40. Usually around 40 to 50 milligrams, usually most of the patients will respond well. So I have enough number of patients. We always, patient will be around the impending crisis, my slowly difficulty in speech, swallowing wrong. So we will be more, because money is the problem for them. Because if they end up in myasthenic crisis, we have to give IVIG or plasma exchange. That will cost around 5 lakhs, 6 lakhs, all this in hospital stays. Sometimes they go to ventilator, tracheostomy. It is difficult to bring them out immediately. So sometimes we'll build the steroids a little bit faster. Every 3 days, 5 days, sometimes if you increase the steroids rapidly, they will worsen. So be careful with myasthenia alone. The other important point is, if you are suspecting myasthenia, many antibiotics can worsen myasthenia. Like safest antibiotic is the cephalosporins and the augmentin. These are all the very, very safest medication, because many other medications can worsen myasthenia, so be careful with myasthenia. Another diabetic, looking at sudden double vision, looking at the left is fine, but if you look at the right eye, looking at the right side, it is not possible. It is restricted. So looking up and side is fine. Look at the right eye. The lateral rectus medial is fine. The lateral rectus is affected. We always know diabetes, diabetic lateral rectus palsy. What to do? The common thing, anytime, what we'll think is diabetic lateral rectus palsy, start steroids. But he is a diabetic. Already, so in that case, will you start steroids or not? Sugars adhigama irukke. The easiest concept what we initially practiced was vision is more important, lateral rectus is more important. So we can manage the diabetes, insulin potukalam. Abindha we'll do what, that's what we have standardly, like years together we practice. So start steroids, 500 mg methylprednisolone, and sugars அதிகமாகும் சொல்லிக்கலாம். 5 நாள் அப்படி தான் இருக்கும், பார்த்துக்கலாம். நம்ம அதெல்லாம் கொஞ்சம் அப்புறம் மிச்சம் மெதுவாக ஸ்டாப் பண்ணோடனே குறைஞ்சி போயிடும், பார்த்துக்கலாம் அப்படின்னு சொல்லிட்டு வில் ரெடியூஸ் த ஸ்டெராய்ட்ஸ். மெதுவாக குறைஞ்சோடனே சுகர்ஸ் குறைஞ்சி போய்ட்டு டில் தட் டைம் வில் மேனேஜ் வித் வந்து இன்சுலின். திஸ் இஸ் வாட் ஸ்டாண்டர்ட் ப்ராக்டிஸ் வி ப்ராக்டிஸ். ஸோ as I mentioned, isolated lateral rectus palsy, no pupils, always look for pupils, because if pupils are involved, always do a MRI, especially MR angiogram, because if pupils are involved, the pupils are in the center. Okay, central, if it is affected, usually it is an aneurysm. So sometimes they get painful or painless. Aneurysm bleed aachna painful aagum, aneurysm bleed agala, it's painless. So pupil sparing alien, first we need to look into it. So look for other cranial nerves. MRI should be normal. The problem is nowadays the guideline shows there is no need to start steroids in these patients, because it's a small vessel ischemic diabetes is small vessel ischemic disease. So no need to rush, no need to start steroids. Control the diabetes, that's more than enough. Okay, so the isolated in a diabetic, we commonly see the isolated cranial nerve palsy, that's common, and control the diabetes, control the hypertension, control the lipids, look for vasculitis. If there is vasculitis, commonly we see vasculitis with diabetes, like many patients have vasculitis. If they have evidence of vasculitis, then start steroids. If there is no vasculitis, no need to start steroids. Just tell them, yes, you have got a lateral rectus palsy, it will be there for a long time, you may have diplopia, there are prisms are available, or sometimes if the severe diplopia is there, we can give or shaded glasses are there, or closing the eyes, one eye, because if they have a diplopia, obviously they will have double vision, difficulty in concentrating, they will have headaches. So all this, like a non-pharmacological measures are there, we can use those till it recovers. So the important thing is, if a young patient, not only the lateral rectus palsy, like if they have multiple cranial nerve palsy or any persistent headache, not improving over the time, always do a MRI. Okay, the MRI may show some other involvement, some other problems in the brain, especially some patients usually like Tolasa syndrome. If the headache is there with lateral rectus palsy or other cranial nerve, always the orbital apex is very, very common. Tuberculosis or sarcoidosis, vasculitis are more common in these patients. So the common thing which we see, young male with a deviation of angle of mouth, unable to close the eyes. They will say typically when they chew, they are not able to chew. Drooling of saliva is there. When they brush or gargle the mouth, they will have a drooling of saliva is there. It's typical, we know, Bell's palsy. But always, if a patient is having Bell's palsy, it is our duty to differentiate whether it is a Ellerman sign or is it a human sign. That's important. Like ask the patient to wiggle the eyebrows, because if it is Ellerman palsy, most of the half of the face is affected. Like the eyebrows, they cannot do the eyebrow wiggling, or if you wiggle, only the wrinkling will not be there in a Ellerman facial palsy. If it is a human facial palsy, only the lower half is affected, only the deviation of angle of mouth will be there. If it is going to be a human palsy, always suspect a stroke, because many patients just a facial palsy alone can be there without the limb weakness, because sometimes it can affect the thalamus. They can have some sensory loss alone. Sensory loss they will ignore, they will not tell us. So we need to do a MRI. First look at a human palsy or Ellerman palsy, then we can decide what else. And always look for the ear pain, because when the patient is having a ear pain, usually it can be a Ramsay-Hunt syndrome, because it's a viral illness. Usually they will have a mild ear pain, and within a week they will develop a vesicles. It could be a Ramsay-Hunt. If you start like a acyclovir, they will respond. Or most commonly in our settings, what we see is it can be a ASOM or CSOM, because the facial nerve just comes closer to the facial canal. Mostly the ASOM, CSOM will be useful, because if it is going to be a facial palsy, we always start steroids. That's very first line of treatment. If you start steroids for ASOM and CSOM, obviously it can worsen the infection, so be careful with that one. So nothing, no steroids, no MRI required, no blood test is required. Start your steroids 50 to 60 milligrams for 7 days. That's important. And many people, okay, like they'll do, whether the patient is on steroids 5 to 7 days is enough, or 5 days of 50 to 60 milligram, like tapering dose, like 40, 60, 60, 50, 40, like another 5, 6 days we can taper also. Both are fine for us. For a routine, every day, if a patient comes to Bell's palsy, we start about 2 things. One is a steroid, next is acyclovir. Do you want, is there any role for acyclovir still? Should we start it or not? Any idea? Because this is what we say. Every patient start like a serological pneumonia, tap put I'm shooting all on facial palsy. We are very happy. In a neurological patients, examination, Bell's palsy, within 5 minutes, headache and Bell's palsy will finish up and chalo. But the important thing is now there are lots and lots of evidence are coming. The evidence shows that there is no role for acyclovir nowadays. But the problem is most of the studies are done in abroad. Now abroad we talk about infection. They usually say, நீ சொல்கிற மலேரியா நீ சொல்கிற இதெல்லாம் நான் பார்த்ததே கிடையாது எனக்கு தெரியாது. My boss is one of the best in the world. எந்த கேஸ் கொடுத்தாலும் he will crack it. He is that much of brilliant. He is considered one of the best. அவர் சொல்லுவார், he came to India 3 times. நம்ம போட்டதெல்லாம் நம்ம இந்த இன்ட்ரெஸ்டிங் கேஸஸ்லாம் போட்டதெல்லாம் பார்த்தா இன்ஃபெக்ஷன் ரிலேட்டட் மூவ்மெண்ட் தான், டியூபர்குலோமா அது நியூசிஸ்டிஸ் கேசஸ், அது ஏதாவது ஒரு மூவ்மெண்ட் சொல்கிற வரும். They will say, whenever I go to India, I will tell them, except whatever the autoimmune, all the cases he will catch up. But infection I always fumble, because they never see an infection. So all these studies are done in abroad. They never seen a infection. So they don't recommend acyclovir. But in Indian scenario, yes, there are lots of evidence shows that yes, acyclovir is useful, and use the acyclovir for 5 to 7 days and steroid as for 5 to 7 days. But important thing is start all the acyclovir or steroids within 72 hours. That's very, very important. Start the steroids and acyclovir early, and if the patient is having troubles, cornea, because they cannot close the eyes, so we need to patch up the eyes, teardrops, all these things very, very important. The next common thing, vertigo. We commonly see this patient. Sir, தலையை திருப்பினா இப்படி திருப்பினா லைட்டாக தலை சுற்றுது என்ன பண்ணுறது? This is the common thing we have. So in this case, commonly we need to, history is very, very important in this patient. In which position the vertigo occurs, that gives the clue which canal it is affected. So if somebody presents with a vertigo on looking up, it means it is occurring in the posterior canal. So looking up is posterior canal. If somebody says they are rolling up in the bed, bedla thalaiya thirupumbodhu thalasutthal varuduna, that is a horizontal canal. Or if you are bending down like a shoe kattumbodhu keela guniyumbodhu thalasutthal varudha, this is a anterior canal. Why it is important? We all give like vandavane vertin 8 mg podu pathaliya 16 mg podu pathaliya stemetil podu stogeron podu appdinu. But the problem is, these are all easy. If the patient settles down, we are also happy, they are also happy. There are some troublesome patients are there. Sir, now நீங்கள் கொடுத்தீங்க ஒரு மாதம் நல்லா இருந்துச்சு, ஒரு 3 விட்டோடனே மறுபடியும் வந்துச்சு. சில பேர் that are also fine. சார் நான் மாத்திரை போட்டேன், நிறைய தூக்கம் வருது, மாத்திரை குறைங்க. So obviously we cannot give it more. But when you reduce it, again the symptoms will be more. They will have persistent symptoms. In those troublesome patients, it is difficult for us. You can see this girl is an area postrema. She has got a, it's a NMO spectrum disorder, but she has got a upbeat nystagmus, almost similar to the posterior canal nystagmus, upbeat nystagmus. So the important thing is, the easiest thing is recognizing which canal is affected. There are some easy maneuvers are there. If it is a like a posterior canal, we can do a Epley's procedure, like turning the head. It is easily available in the internet. Epley's maneuver. If it is going to be a horizontal nystagmus, the barbecue roll. If it is an anterior canal, deep head hanging, these type of procedures are there. If you do the procedures, usually the patient will respond. These are all easy bedside procedures. We can improve the patient, but it is rewarding. Sir, they will say, sir, last time நீங்கள் பண்ணீங்க உடனே சரியாக போயிடுச்சு சார், நான் எல்லா இடத்துலையும் மாத்திரை சாப்பிட்டா சரியாக இருந்தேன். These are easy tests. We can easily do it in our clinic and we can score the marks easily with the patients. So, and sudden onset of slurring of speech, difficulty in swallowing. The problem is this gentleman came with a right-sided facial numbness, left-sided weakness. We all know that if there is a hemiparesis, it should be one-sided. But here, crossed, right-sided face, left-sided body. We always get confused. How can it be a hemiparesis? Yes, that's what. It's a brainstem cross deficit. Always it's a medulla because the fibers crosses there. So it is a lateral medullary syndrome or Wallenbach syndrome. So usually it can be a brainstem stroke, or a patient can have Horner syndrome, like pupils will be small, and also ptosis can be there. Mainly they can have a vertigo or hiccups can be very, very common. It's a crossed hemiparesis. So do a MRI brain. This I have 2 patients, same. They had the crossed hemiparesis. I know that, yeah, this is lateral medullary syndrome. I have done the MRI now. So I cannot explain. Patient is telling, so we have done all the tests. Once it is negative, now we get panic. They are negative. So we do all the tests. So usually, if it is going to be a posterior circulation stroke, there are many times the stroke may not be seen immediately. So many times they come with a vertigo. Slowly they will have a clinical features of stroke. Second day, third day, they can show the diffusion restriction in the MRI. So don't be panic, be confident, repeat an MRI after 3 to 4 days. But many times what our patient is, sir, 3 நாளைக்கு மட்டும் MRI பண்ணா மறுபடியும் பண்ண சொல்றீங்களா அப்படினுவாங்க. So we always told them, no ma, there can be infection, we'll do a contrast. So we do a contrast, but obviously the reason is they will not accept for the this contrast, or they will say MRA, MRB, deep anomaly, we'll do a repeat MRI. Obviously, we'll get the lesion. I have a patient, within week, 4 times we have done three MRIs. Every third day we have done, it was negative. Fourth MRI we found it. Especially a small stroke can be missed in this type of patients. And slurring of speech, this type of swallowing difficulties and difficulty in swallowing, nasal twang and weight loss, sensory symptoms, always look at the tongue, it's atrophy. This is very commonly we see in our practice. Is it a stroke? And look at the video. Always look for a fasciculations of the tongue. When the tongue is atrophied, look for fasciculations. The patient can have not only the fasciculations, they can have fasciculations in all over the body. This is motor neuron disease. There is a subtype of motor neuron disease. They cannot have any weakness or nothing in the whole body. Usually the two ways, it can start in the limb and can progress to the swallowing problems, tongue atrophy later on as a part and parcel of the disease evaluation. The other way around also is very common. They can have a tongue atrophy, swallowing difficulties, speech problems, then slowly evolve into a generalized motor neuron disease. So it is very, very difficult for us to treat because we don't have much of a treatment for this patient. Always in clinically look for a brisk jaw jerk and look for the other reflexes. Usually in a motor neuron disease, the other reflexes may be brisk and also atrophy can be there. Extensor plants are common. Always first thing is look for a MRI. If MRI is negative, put a needle EMG. The EMG always shows it could be a motor neuron disease, and always we think that it could be a motor neuron disease many times, but it can be a myasthenia also. Myasthenia mimics like a motor neuron disease. Always, if you suspect a motor neuron disease, autoimmune diseases, especially the paraneoplastic cancer-related diseases are very common. Do ACHR, MuSK and cancer tests. So nowadays we always give riluzole, but nowadays the problem is they cannot swallow. Nowadays the edaravone liquids are available. These things can slow down the disease process or a little bit prolong the disease process. And commonly what we see in our movement disorder practice, any patient comes with a slurring of speech and suddenly like this type of lips backing, otherwise no other symptoms. Yeah. Twitching of the lips like this, the twitch. Very, very common. So if anybody, we call it as a rabbit syndrome. Like any patient who comes with the perioral movements like this, or tongue it will be going like this, slurring of speech, always ask for what all the tablets they are taking. The most common culprit is domperidone and levosulfide, because we left and right we use a pan D, pan L, left and right, that's the culprit. But if you ask them to bring the prescription, they will say a prescription, maybe 1 year back somebody would have written the pan D, nothing will be there. And if you ask them bring they don't know what is the name, most of the village patients and all. If you ask them to bring what all the tablets they are taking, obviously they will come and show, sir, in the tablet sir. They will not, they don't know what is pan D, gas tablet, etc. So obviously if you see there is a domperidone or levosulfide, stop the tablet, obviously they will become better. And if within, only thing is how long you are using the tablet. If you are using the tablet for a short time, it will settle down within a month. But sometimes some patient takes longer time to recover. In those patients, tetrabenazine or even Botox we give, that responds very well. Thank you.
Thank you, Dr. Vijay Shankar, for your enlightening lecture on cranial nerve palsy. Now we will move on to the next topic, management of osteoporosis. I invite Dr. Usha Sriram to come to the stage. She has been a graduate from Madras Medical College, American Board Internal Medicine, American Board Endocrinology, and heading the Department of Endocrinology in Voluntary Health Service. And she has been
What did I do? Just go here, right? Either.
She's been one of the pioneers in the management of osteoporosis, and she taught me how to understand and diagnose and treat osteoporosis 25 years back when nobody was treating. Thank you so much.
Good morning, everyone, and that was a pleasant surprise because in 2023, I gave the Professor VTB oration online. So today, because I'm here in person, they honored me. Thank you so much. And everybody knows that both my husband and I are huge fans of Professor VTB and learned so much from him and continue to follow the things that he taught us in those days. And today's talk is on osteoporosis management. But before I begin, I just want to say what an amazing lecture that was given by Dr. Parandaman, and something as simple as cough, that he was able to explain it so beautifully, and then of course the entire talk on cranial nerve palsies. But unfortunately for osteoporosis, there is no symptom. See, cough is a symptom. You can work up and make the diagnosis. Neurologic palsies, it's a symptom. You can make diagnosis. This condition that I'm going to talk about, there are no symptoms. The only symptom is you break a bone. And kind of it's too late by then, and we'll have to work backwards in most cases. But what we really, as good physicians, we should be doing is to prevent those fractures. And that's number one. Number two is, even those who have had fractures, my good colleague Dr. Sriram Mahadevan will agree with me, even those people who have had fractures, we don't follow them up for osteoporosis. So we have these two golden opportunities. One is to take people, men and women, and prevent fractures. And those are mostly preventable. If somebody jumps from the 10th floor of a building, or we can't do anything, or they get hit by a vehicle, we can't do anything. But I'm talking about trivial falls. So one is very important as physicians that we prevent fractures. The second thing is the low-hanging fruit. Already those who have fractured, why not we make sure that they don't fracture again, because the next fracture is very common, and especially in the first 2 years after the first fracture. So we should be really making sure that people don't fracture again. And so I'll start with a clinical vignette and go through the different aspects of the overview, like what is osteoporosis, and what is the scope of the problem, and why is it important that we even make the diagnosis of or assess the degree of bone loss, what can we do with that, and all the current tools that are available and how to manage them. That's really the management. And I've drawn most of my recommendations and things for my talk from this position statement that has been put out by the Indian Society for Bone and Mineral Research. It's again being relooked and some modifications may come, but just to say that I've taken it from this and also from the Asia Pacific Consortium on Osteoporosis framework for management of osteoporosis. So like every important discussion, we should start with a clinical scenario. And I just want to say, this is a 63-year-old lady who had a fall in a vegetable market, and she's found to have a hip fracture. And she has had her menopause at age 48, which is the right age for menopause, both for, if you take Indian women, somewhere around 47, Western women, somewhere around 50. So she's she's in the right age. So it's not early menopause. And as a history of type 2 diabetes, for the past 10 years, she's on oral hypoglycemic agents metformin and sitagliptin, and her A1C is 7.3. 7.3 can be a little bit better for sure, but it's not terrible. I work in VHS. The average A1C I see is 12, 13. So 7.3 is brilliant control for us. She's recovered well post-op and ready for discharge. But there are a lot of questions from her family. Number one question, why did our mother have a hip fracture at such a young age? 63 is young for a hip fracture. Is this because of osteoporosis? And she didn't have any symptoms. So the first thing that we all have to remember and also impress upon the public is osteoporosis has no symptoms. The only symptom is a break. You end up with a fracture. Usually if somebody has aches and pains or problem like that, it's osteomalacia. Osteomalacia is soft bone. Osteoporosis is thin bone. And osteomalacia is from vitamin D deficiency. So the pain is from when people have vitamin D deficiency, usually, or of course if they've had a fracture in the back and they'll have back pain. But not this Kai-Kal Korachal type of thing is usually not an osteoporosis problem. Usually not. Then should we start her on any medications right away? Because she's just had a hip fracture, and what should we do? And how can we prevent another fracture? Very, very important question that the family is asking. So that's one important clinical scenario, and I'll show you the answers later. But I just want to say, as practitioners, we'll be facing a lot of these, like a gentleman who falls off a bus, is a tibial fracture, vertebral fracture. He's a smoker, but he's cut it down, but he's still a smoker. And he had a spine film because he had a back pain, and that shows an osteoporosis and a fracture. Then this 49-year-old lady who has rheumatoid arthritis has been on low-dose steroids, and she has a fracture after a trivial fall. And then a 75-year-old gentleman who tripped on a wire at a wedding, can happen to any of us, and he has no risk factors. He's not, his men are not postmenopausal, he's not on steroids, not a smoker, none of those kind of things, but he's 75. And this one is very important. A 58-year-old lady, she has done a DEXA as part of a master health checkup, and they find osteoporosis. So no symptoms, no risk factors, no nothing. Incidentally found osteoporosis. What do we do with someone like her? So these are the kind of things we normally face. And of course, nowadays, some people are coming to us even in their 30s and 40s and saying, my mom has it, or aunt has it, or grandmother has it. What can I do to prevent it? So why should we learn everything about osteoporosis? Just want to show you that by 2050, the people over the age of 60 in our country will be 19% of the population. And then by the end of the century, the elderly is expected to be 1/3 of our population. So you can see how osteoporosis is going to be, it's a problem of aging. It's a problem of postmenopausal state. So there's a lot we can do as public health, from a public health perspective. So the burden of osteoporosis is very high. As you can see, 1 out of 5 Indian adults, which translates to 20 crore population or higher, at the risk of getting an osteoporotic fracture. So that, and also there is it involves a high cost, not just in terms of rupees and paise cost, human cost. These are people who have high mortality within 1 year. They are people who have maybe another fracture. They may never return to their previous level of functionality. Almost 20% do not return to their previous level of functionality. And other issues happen when someone has a fracture. So it's not just a question of cost to the individual or to the healthcare system, but also in terms of health. So despite being so prevalent and so costly in every way, so underdiagnosed, under-recognized, underappreciated, and undertreated. Just don't know why. So really we need to take this thing on a war footing. And I just want to say, you take a person with diabetes. We spend so much time trying to bring their A1C under control, putting them on a statin to bring their lipids under control, try to get their blood pressure under control. And let's say, or now with all the obesity drugs, bringing their weight under control. Let's say we do all of this, but ignore the osteoporosis, and that person develops a hip fracture. That would be a crying shame, an absolute crying shame, that if we did not have this kind of a holistic approach, also because diabetes itself is a very high, big risk factor for diabetes, type 1 much higher, and type 2. So one is the fact that the population is aging, and second, this bone biology that keeps going on constantly. Bone is being eaten up, then bone is being put back, bone is being eaten up, and it's being put back. This goes on throughout our life quietly. We think bone is a dead tissue, just supporting structure, but it's actually alive, living, and constantly remodeling and doing wonderful things to our body, but we don't recognize that. So, because this is also going on, and if there is an imbalance in this, and why can an imbalance happen? The imbalance happens for many reasons. It can be aging related, it can be disease comorbidities, it can be post-menopausal state. And I just want to show you that beginning from the menopause transition, the reduced estrogen leads to a decrease in critical bone mass. Do you see how rapidly and how much it comes down in that short duration? 5 to 10 years, we lose a significant amount of bone. So it's so important to make sure that women entering the menopause enter with good bone health, and they exit the menopause also with good bone health, and then subsequently we keep following them with that. So estrogen has multiple effects on these very important bone biology, on the osteocytes, osteoclasts, and osteoblasts. So if there is estrogen deficiency, this is going to happen. So the automatic question that comes up in people's mind is, so why not give estrogen and reverse everything? So it's not so simple. We know that some women will benefit from use of menopausal hormone therapy early on, especially if they have early menopause or premature ovarian insufficiency, or if they have symptoms. But otherwise, we are not using menopausal hormone therapy primarily for the purpose of prevention. So remember that patient who had 63-year-old who had the fracture. So there's some quick responses to the family. So why did our mother have a hip fracture at such a relatively young age? So risk is earlier in Indian persons, 10 years earlier, as we know, like most things. She's 15 years post-menopause and has type 2 diabetes. All are risk factors. In addition, diabetes predisposes people to falls. It can be vision problem, it can be proprioception problem, it can be a hypoglycemic thing, it can be any of those things that makes them fall easily, and therefore they're also at risk for falls. Is this because of osteoporosis and she did not have any symptoms? I've already told you, typically asymptomatic, and fractures happen because of what we call bone fragility. And I put this here because we now use the term bone strength, and bone strength is made up of both bone mass and bone quality. This quality is one abstract thing. There are a lot of things that contribute to bone quality, and that's why for the same bone density, some will fracture, some won't, and that depends on the bone quality they have. Should we start her on any medications right away? Obviously, optimizing her vitamin D, making sure her calcium is adequate. Use of specific agents. So this is something I want to leave here about osteoporosis. the role of the physician is in prevention, recognizing, screening, diagnosing maybe. But when it comes to management, you can seek the help of experts, and because it becomes a little bit more nuanced, because we want to risk stratify people and then choose the right medication. And we may not use the same medication. Now we have what's called as sequential treatment. We start with anabolic, then we chase it with the anti-resorptive. They may have been on anti-resorptive. We may have to choose something else. So it's a little bit more nuanced, but at least the first part, the recognizing, the diagnosing, the screening, the counseling, the optimizing of calcium, vitamin D, physical activity, all of that is the role of the physician, is what I'd like to say. And then how can we prevent another fracture? Obviously by following this patient and putting them on appropriate treatment. So how does the World Health Organization define osteoporosis? We use this classic T-score. So if the T-score should be normally up to -1. If it is up to -1, it's considered normal. -1 to -2.5 is called osteopenia, something like pre-diabetes. Then -2.5 and more is osteoporosis. And of course, severe is when either the T-score is very low, or if they have established fragility fractures. So this is how it is diagnosed. Now, next question I want to ask is, why is diagnosing osteoporosis important? So what if there is a fracture? You fix the fracture, you send them home, right? Not so simple. So first one is treatment of osteoporosis lowers risk of future fractures. And I just already said, fracture is not so simple. Edo kaal odanjadu, edo fix pannom kadiyadu. People lose their lives, people lose their independence, people lose their quality of life, people lose their livelihood, and so many things happen because they have a fracture. And then, is there a benefit if you treat these people, assess them? Why should we screen them and assess them? Number one, you rule out secondary causes. Aging, postmenopause is one thing, but you can get osteoporosis because somebody has rheumatoid arthritis, they're on steroids, they're on other medications, they have cancer. So many things can cause secondary osteoporosis. Second thing is, we need to document the extent of bone loss so we can choose which drug to use. So many are there now. And then also to monitor therapy. Choice of therapy will depend on severity, and also we must document incident vertebral fracture. So nobody will come and tell enak mudu odinju poidhu. When their leg breaks or their arm breaks, you will know because it's broken. But if they have a fracture of the spine, very rarely they are going to come and say, I have fractured my spine, unless we look for it. The moment, so every patient you diagnose with osteoporosis or osteopenia, please get a simple lumbosacral spine film. Or if you have vertebral fracture assessment, VFA in the DEXA, you can do that. That is so important because it will completely change the risk stratification of the patient. Let's say you have a T-score of -1.9 and you see a fracture in the spine. Immediately that changes the risk stratification for me. So, and it is an absolute must that we do the spine film. And there are many, many tools that for motivating patients to adhere to treatment. See, imagine somebody who has no symptoms and you tell them you have to take these things for some months or years or do this and do that. They're not going to be, it's not like cough. They don't want to get rid of it. It's not like diplopia. They don't want to get rid of it. They don't have symptoms. So we have to impress upon them that fracture is not a benign condition. And primarily because big gap exists in evaluating and treating patients post-fracture. So really important for us to have a really good relationship with our orthopedics colleagues and work with them and make sure that all these people are followed up. And I'll give you a simple analogy. Just take somebody, they have chest pain. That's like a fall. Immediately we'll get ECG, we'll get cardiac enzymes, we'll rule out non-cardiac causes. Here we should do X-rays and other, ruling out other conditions. And then we would put them on antiplatelet, we would do some invasive interventions, but here we are supposed to do the fracture reduction stabilization. Following that, what will we do? Follow these patients, we'll put them on a statin, we'll put them on beta blockers, and now we put them on SGLT2. We keep following them up. Here we are supposed to be treating them for their osteoporosis. Do you see where we are dropping the ball? We're not doing any of this. Just imagine, it's exactly like that. So how do we determine who's very high risk and who's high risk and very high risk? High risk is T-score between -1 and -2.5 if they already have a fracture, and T-score between -1 and -2.5, and what's called a fracture risk assessment, 10-year probability of a major fracture more than 20%. FRAX is like a poor person's DEXA. You can also use it with BMD also, but you can do a FRAX. If they're very high risk, of course, prior fractures, elderly, frail, increased risk of fall, very low T-scores, and they take medications like glucocorticoids. So let's see what tools are there for diagnosing and managing osteoporosis. Most important, history and physical. Complete history, what are the medical conditions they have, what medications they are taking, and as was mentioned very nicely, sometimes you have to ask people to bring their medicines with them. Appadan theriyum. They'll be on steroids for many, many years, or they'll be taking something they should not be taking. So very good history and physical. Then laboratory test, very simple. Always get a calcium and an albumin level to assess the calcium. Make sure you look at a CBC to see if they are anemic. And if they are, you have to connect the dots and see, could this be a myeloma? Could it be kidney problem? So also get a creatinine, very simple. Some very basic stuff. Get a vitamin D level. After this, if there is a calcium issue, then we can get a PTH level. If you suspect Cushing's or something, you can look for it. If you suspect a myeloma, you can get a protein electrophoresis. Other than that, very simple stuff is all that's needed. Of course, if they have diabetes, you want to assess their diabetes control. Then imaging. Imaging is X-ray, I already told you, but don't use an X-ray to diagnose or quantify osteoporosis, because it takes nearly 30% of the bone to be gone before you can diagnose osteoporosis. Also, when you start treatment, you can't use an X-ray to follow them up. So it's hard for us to assess, are they improving or not. So X-ray is to rule out fractures, not to make the diagnosis, except in very rare situation when we don't have anything, or if it is super obvious on the X-ray. And then I'll show you something about the DEXA and finally, also about FRAX. So these are the tools. History and physical, I already said. Personal history of fractures, family history, smoking, menopause history, breast cancer, post-cancer treatment, vitamin D status. A lot of people nowadays are vegan, they don't do this, they don't do that. So get a good history, and medical history for secondary causes. And then physical examination, look at their weight, calculate a BMI, look for kyphoscoliosis, clinical signs of secondary osteoporosis, and especially sarcopenia and malnutrition, very important. One of the reasons why osteoporosis is more common in men in our country is actually sarcopenia. So look for that. And then lots of medicines, as you can see, steroids and proton pump inhibitors and aromatase inhibitors, big laundry list of medicines that can cause. So you'll have to go through every medication the patient is taking, Then there is this radiographic techniques that are listed. All I want to tell you is X-ray to rule out fractures, and then the dual photon X-ray absorptiometry, which is the DEXA for the diagnosis. Bone markers, we really don't use it for diagnosis. We use it sometimes for following up the patients. And again, those are nuanced techniques and should really be left to the specialists. And we really don't do biopsies, and very rarely, these are research tools, very rarely we have to resort to biopsies and all that to make the diagnosis. So this X-ray business, I told you, I can't stress it enough, so important, because you will pick up fractures so often. And this FRAX is a tool. We have FRAX for India, though it's not Indian patients. They're Singapore Indians that has been developed. But now I think, Sriram, we now have Indian patients from Chandigarh. No. It has come in there? Okay. So we now have Indian patients. So you should use FRAX, and you put in the risk score, and you can also add BMD. It'll give you the risk for major fracture, and that's a very important tool also to assess. So the ISBMR, Indian Society, gives us recommendations. So we have lowered it from 65, the international guidelines, to 60 for Indian patients for women and 65 for men. And then, as you can see, for others earlier, if they have fragility, fractures and things. So this is all you need to do. Get the spine, and we look at the total spine. Get the hip. We can just do one hip, left or right, and make sure that you just need to do these two. In special circumstances, CKD, hypo and hyperparathyroidism, conditions like that, you can do the forearm, but not in, we don't need the whole body DEXA at all. It's just spine and one hip. So the bone density, as you can see, as people get older, they are going to lose bone. The lower the bone density, greater the fracture risk as people get older, and also its prediction as for every SD decrease in BMD, fracture risk doubles. Okay, so we use T-scores except in premenopausal people and men and children, like I said, spine and left hip. So quickly, because the treatment is actually the simpler part. All this what I've spoken now is the most important part. So lifestyle modification, exercise, weight-bearing exercise, safe movements, avoid falling, balanced diet, sunshine, 20 minutes between 10 a.m. and 4 p.m., prevent obesity, avoid smoking and alcohol, limit alcohol consumption, and avoid all those medicines that I showed you on big list. You have to go through that. And then this calcium supplementation is under a scanner all the time. Just make sure people get enough in their diet, and maybe a 500 milligram once a day for postmenopausal people and older men. We don't need more than that. But vitamin D, major deficiency issue. 50% of patients with osteoporosis also have an osteomalacic component. So you have to make sure that their vitamin D is optimized, very important. Then comes the question, who needs pharmacologic therapy? Osteopenia or low bone mass, history of fragility, fracture, definitely, even if they have osteopenia. T-score of -2.5 or lower, definitely. And T-score, again, osteopenia, -1 and -2.5, but if their FRAX score, probability is more than 20%. These are people who need pharmacologic therapy. Just look over there. Look at the high-risk people and very high-risk people, and we treat them with pharmacologic therapy after optimizing their vitamin D. If they are very high risk, or if their T-score is very low, we choose the anabolic agents, teriparatide, abaloparatide, which we don't have in India yet, and romosozumab that has come recently. We use these drugs, anabolic agents. Romosozumab is for 1 year, teriparatide is for 1.5 to 2 years. And then we finish that course and then close that or capture that with an anti-resorptive. But if they are only high risk, you can consider a bisphosphonate like zoledronic acid, or you can use denosumab. So treatment of osteoporosis, when you have come to this part, I think is a little bit more nuanced and should not be casually considered, and ideally we should take the help of the specialists. And as you can see here, if they are very high risk, use teriparatide, abaloparatide or romosozumab. Then you consolidate what you have gotten with the anti-resorptive, and then of course we stop it only if they have gone into a very low risk group. I also want to, we always talk about drug holiday and all that. We don't give a holiday to people with diabetes or high blood pressure or heart disease. So even osteoporosis management, really don't think of as, I'll use it for 2 or 3 years and stop it. We will have to use other agents that may be safer and keep monitoring the patient. So really no holiday that way. We have to keep on following them up. This is, all about these drugs. I just want to say again, they are all proven efficacious. We do not use calcitonin for osteoporosis treatment. We use menopausal hormone therapy for select women early in their postmenopausal years, but not afterwards. So we really are now down to just 3 drugs: bisphosphonates, denosumab, and teriparatide. I mean, now we have romosozumab, 4 drugs only. So choosing that becomes based upon risk stratification and other complications of the patient. So really important for us just to keep that in mind. Very important that we don't have this gap of post-fracture assessment. That is a huge gap. Whenever people have new fracture, we are now having something called as FLS, or Fracture Liaison Service, not there in every state, in 2 or 3 states and in Europe, where special nurses follow the patients who have had fractures, proven to be beneficial. Hopefully that will come to more places in India. I'll stop here by just saying that most important thing about osteoporosis is preventing it by recognizing and screening everybody you think who's at risk, and following the guidelines on who should be screened, how should they be screened, and making sure everybody is following all these simple lifestyle measures to improve their bone health. Thank you so much.
That was a wonderful talk. I think in lack of time, we'll go on to the next topic. Thank you very much, Dr. Usha Sriram.
Thank you.
Next speaker is Dr. Sriram Mahadevan, somebody who strongly believes in evidence-based medicine and very cost-effective endocrinologist from Chennai. He had his education from PGH Chandigarh, both MD and DM endocrinology. I've known him for nearly now 30 years from SMF days. I'm happy to have him here again. Dr. Sriram Mahadevan.
Thank you, sir. At the outset, my profuse thanks to the organizers. I was just asking, sir, D Club, the Singam Badathla or Operation D. So this is a very good opportunity for me to interact again to our many familiar faces here, all our senior physicians. My job is slightly more difficult actually, to talk on a very pretty common topic which all of us face, put it more interesting, and I have been given now 25 minutes plus. I will quickly rush through as much as possible. We will have at least 5 minutes of interaction if possible. Okay, straight away going, I will go through, even though I started putting the slide as hypo to hyper. How do I change the... enter பண்ணனுமா? ஓகே. ஹைப்போதைராய்டிசம் விட்டுட்டு கொஞ்சம் தைரோடாக்சிகோசிஸ்லேருந்து ஆரம்பிக்கலாம்னு தோணுச்சு, which is less common definitely. although we also see it frequently. This is a very straightforward case which we will all easily identify. Young lady, net out a picture down. Every other times, many times, even when a distance with a stare, we can guess that there is something wrong with this lady. And an astute observation of the neck with diffuse goiter will immediately give you the diagnosis that there is something wrong. And patient is solidonga, mukavasi neram. And the symptoms are very obvious in contrast to the previous talk by Dr. Usha Madam on osteoporosis, which is largely silent. The previous first two I was told, I was listening to the cranial nerve thing. This is very symptomatic. In the Maris patients, frankly, practice lang konjam nalla odudu. Because they will be so bad that you diagnose them correctly and you treat them, within weeks they will improve. They will be so grateful to you for reassuring and getting to the diagnosis correctly. To be very frank, most of these patients and their family will be your long-term patients, and these are all long-term conditions also. And very rarely they are serious to cause trouble to you. That's also there. But there are some caveats. If time permits, we will allude to. அதுக்கு தான் நிறையா அதை பற்றி டிஸ்கஸ் பண்ணிகிட்டே இருக்கணும். இல்லைன்னா நாட் எவ்ரி திங் இஸ் ரன் ஆஃப் தி மில். இந்த பேஷண்ட் குவைட் ஸ்ட்ரைட் ஃபார்வர்ட்னு நான் சொல்கிறேன். பட் sometimes they will have associated problems which will lead to more conditions. And if there was an MCQ asked, what is the commonest cause of thyrotoxicosis? What will be the answer? There is a catch here. The catch is the word thyrotoxicosis is a generic term. It means your blood levels of thyroid is more, that's all. It doesn't mean the cause. So what is the commonest cause of thyrotoxicosis? Over treatment of hypothyroidism, the most common, if you ask me personally. Personally, statistically also. A subset of these patients only will have excess thyroid hormone blood levels due to over secretion of the gland. And the over secretion of the gland is hyperthyroidism. அதுலேயும் அது ஓவர் செக்ரீஷன் இருக்கணும்னு அவசியம் இல்லை. The gland can get damaged due to an infection or drug or radiation or surgery or whatnot. And the gland stored hormones can come out, what we call thyroiditis. Most commonly it is due to an infection, viral infection. You see, thyrotoxicosis catch and the PG level leg pulling questions. Thyrotoxicosis கேட்டால் you should say iatrogenic-னு சொல்லக்கூடாது. இப்போ எல்லாரும் அந்த iatrogenic வார்த்தை எதுனா அப்புறம் இங்கே இப்போ இந்த லிட்டிகேஷன் ஏரியாவில் வந்து யூர் தான் ஓவர் ட்ரீட்மெண்ட் ஆகணும். இட்ஸ் வெரி காமன். எனிவே, if you leave out that over treatment of thyroid hormone, then all patients with hyperthyroidism, almost 90% of them will fall into that previous patient. Graves disease. எப்படி பேக் போகுதுப்பா? How do you go up and down this slide? Enter போட்டால் ஃபார்வர்ட் போகுது. ப்ரீவியஸ் ஸ்லைட் எப்படி போகணும்? லெஃப்டா? இங்கே பண்ணால் வரலையேப்பா. உனக்கு ஒண்டி தான் வரும், இல்லையே வரலையே. ஓ, ஆரோ இதை யூஸ் பண்ணுமா? சரி, ஓகே. And this is too basic a slide. Thankfully, thyroid hormone is very, very important. All of us understand, more than 100 years of research in this. Every cell, nucleated cell in the body, because these belong to the nuclear family of the super, the receptors are in the nucleus. So every cell in the body requires thyroid hormone for its optimal functioning. So excess or deficiency of thyroid hormone will have an impact cutting across any symptom, any organ system, or any tissue for that matter. That's why you see they will be going to several specialties, not necessarily to a particular one, from gynecology to neurology to whatnot. And this is not a thyroid specific condition alone, because it has an autoimmune component most often, and it is systemic in nature. Why we call it systemic? Not because of the thyroid hormones effect on every system. It has, you see, so there are certain thyroid autoinflammatory spillover effect on the skin. We call it dermopathy. You can have the orbit involved thyroid associated orbitopathy. So these two are evidences for us to say that this is not just thyroid alone limited condition. And that's why we should also know that it can get associated with several other autoimmune conditions. Especially the condition which I am discussing is Graves' disease, very, very common, most common among the hyperthyroid patients. It can occur at any age, but invariably 80% will occur between the age of 20 to 40. After 40, 50, it is less common when you should suspect nodular thyroid disease. If this was a medical college PG teaching, we will put all rare atypical manifestations of Graves, and so many spotters will be there for us to pick up some points, including thyroid acropathy, the HPOA, pulmonary osteoarthropathy, the grade 4 acropathy, brittle nails, you can have movement disorders, everything. So there will be and atypical manifestations including hypokalemic periodic paralysis, very common in Asian, very important to know in India. This is a very peculiar rare manifestation of Graves, or for that matter thyrotoxicosis, presenting as hypokalemic periodic paralysis. Sometimes they can present with generalized lymphadenopathy due to lymphoid hypertrophy secondary to autoimmune phenomena. You treat Graves, it will become normal. This is called pseudolymphoma. The other DDs for that is chronic phenytoin therapy. What an infection. So many times, I think Sir Swami Kannu Sir also has referred we have discussed quite a few. We have published also one paper. PUO, fever of unknown origin, 6 weeks, 8 weeks. Kadasiya the gray, Kadasiya the thyroiditis na kandupidikum, Graves na kandupidikum. So it's on paper it is simple, but sometimes in a busy clinic, sometimes it gets overlooked. Adidan jagrati irukano. So today, at a drop of a hat, you can get all these tests done. You can get either total T3, total T4 or free T3, free T4, doesn't matter for this diagnosis. That don't do, my humble request is do a good clinical examination of the neck. If there are any suspicious nodules, you may probably get an ultrasound. Otherwise, ultrasound has very little role in this condition. Less role. I am not saying it has no role. But that should not be the immediate investigation. Because it is easily available and it is financially viable, people start doing it. But it won't help in the patient management because you won't know whether it is thyroiditis or Graves' disease based on this. And today, in addition to getting this either nuclear scan, we also get a TSH receptor antibody because it is easily available today. 10 years back, it was not that freely available. So simple classification, decreased, increased, these are standard, very easy to diagnose. A diffuse goiter with increased uptake is Graves. 80% of the people will fall. No uptake, invariably it is thyroiditis. It's very reassuring to diagnose this. Management has 3 major options, all of us know. Either you give carbimazole, propylthiouracil, kind of, no other antithyroid drugs. Unlike diabetes or any other special field where every other year we are having a new drug coming up. That's carbimazole தான் இன்னும் பேசிட்டு இருக்கோம். அது என்ன சும்மா மெத்திமசோல்னா ஒரு பாயிண்ட் எக்ஸ்ட்ரா போட்டுக்கலாம். Very, very interesting to note that even in the USA, you see the modality of therapy for any Graves' disease is invariably medical today, not radioiodine. For various reasons, it's all stakeholder-based and insurance-based change in guidelines. Stakeholders means the patient also gets involved in the management. Why do you want to destroy the gland when the gland is otherwise an innocuous? It's not a cancer, it's not something. So give medical, and anyway it's an autoimmune phenomenon, it can get suppressed. So primary mode of therapy will be medical with all its attendant plus and minuses, relapses, remissions. Only in a subset of patients you require surgery or radioiodine therapy. We will come to it. I will skip many of this for posteoptomy. If I go through each slide in great detail, I will radioiodine therapy. Interesting. Yes. When do you choose? See, you choose a modality of therapy based on the background of the patient. We would have treated not less than 10-20 patients with a heart disease. Heart disease and thyrotoxicosis invariably go for permanent therapy, especially rhythm problem. I saw that you are having a session on palpitation. You can have an atrial fibrillation, you can have a paroxysmal, some other phenomena, MVP, or a mitral valve disease, whatever that is. If a patient comes with one more heart problem and Graves' disease, you should from day one try, unless there is a contraindication for the other therapy, go for radioiodine. இதில் என்ன ஆகும்னா எங்கள்கிட்ட அமியோட்ரோனை போட்டு வந்துடுவாங்க. அமியோட்ரோன் போட்டு வந்த அப்புறம் தான் ப்ராப்ளம் ஆகும். We cannot give radioiodine therapy. As I said, hypokalemic periodic pulse is a very serious condition where we go for permanent therapy. Big nodules or a cold nodule in the goiter, all these are indications for surgery. This one slide will give you all the previous slides because you don't decide the therapy based on the Bailey and Lowell. நான்லாம் வந்து ஸ்டான்லியில் MBBS படிக்கும்போது it was very, today going back it looks slightly odd that surgeons were only seeing thyroid diseases, and half my thyroid knowledge in MBBS was from general surgery department. Medical specialties rarely spoke about how to manage the thyroid problem. அப்போ என்ன சொல்லுவாங்கன்னா, they will say elderly above the age of 40 na வந்து below the 40 na radiation கொடுக்கக்கூடாது. So many things were, some conventional misconceptions were there. Orbitopathy and high risk of remission, pregnancy, அதெல்லாம் இருக்கிற பிளானிங் இருந்தால் தான், or in general medical therapy. Medical therapy இதில் எல்லாத்துக்குமே ஃபிட் ஆகும், but certain conditions you need to have definitive therapy. Quickly, because this is a senior physicians forum, in the next 5 to 10 years, இப்போ டயபிட்டிஸ் ஒபிசிட்டியில் நிறைய குழப்பி மருந்தெல்லாம் பேசுகிற மாதிரி இதுக்கும் வரப்போகுது. Because this is a primarily an autoimmune phenomena. இது வரைக்கும் நம்ம பேசினதெல்லாம் சும்மா கிளாண்டை அழிக்கணுமா, கிளாண்டை கண்ட்ரோல் பண்ணணுமான்னு பேசிக்கிட்டு இருக்கோம். Because this is an autoimmune disease, you can target the immune system and you are going to get molecules which can either focus on the CD40 ligand or on the antibody wash out பண்ணிடலாம், அல்லது அந்த ஆன்டிபாடிக்கு ஆன்டிபாடி லைக் anti-TSH receptor antibody, monoclonal antibody to that. இதெல்லாம் phase 1 phase 2ல இருக்குது. It is very likely at least 2 of these are going to phase 3. நன்னா குழப்ப போகிறது, இன்ஜெக்ஷன் போடணுமா வேண்டாமா எல்லாம் வரும். It will be so in future the algorithm will look like this. Only in that young patient where you cannot give any of this therapy, planning pregnancy, small goiter, young, remission is less, no other associated condition, you give antithyroid drug. Otherwise you have to decide whether this is called precision medicine now. In the and AA decide பண்ணிடும் whether this patient, நீங்கள் அவங்களோட ஃபேக்டர்ஸ்லாம் போட்டு blood test பண்ணிங்கன்னா தெரிஞ்சிடும் இவங்களுக்கு வந்து CD40 ligand ஆன்டிபாடி கொடுக்கலாமா, இவங்களுக்கு கிரேவ்ஸ் டிசீஸை பர்மனெண்ட்டாக பேஷண்ட்டே கேட்க ஆரம்பிச்சிட்டாங்க. நான் சர்ஜரிக்கு போன்னு சொன்ன பேஷண்ட்டு ஒரு 4 வாரம் முன்னாடி ஷீ இஸ் கம்மிங் பேக் அண்ட் டெல்லிங் மீ, சார் நான் ஏன் வந்து அந்த புது தெரப்பிலாம் வந்திருக்கேன், மைக்ரோவேவ் அப்லேஷன், ரேடியோ ஃப்ரீக்வன்சி பண்ணிக்கிறேன். அண்ட் ஷீ வென்ட் டு ஒன் பிக் பிளேஸ் வேர் தே டோல்ட் ஹர் டு கெட் தைராய்டு ஆர்டரி எம்போலைசேஷன் பண்ணிக்கிறேன்னு போயிட்டாங்க. இட்ஸ் நாட் ரைட் ஆர் ராங், நான் இங்கே மாதிரி ஓப்பன் ஃபாரமில் ஐ டோன்ட் வாண்ட் டு டிஸ்கஸ், பட் த pathology was not clear. And because it is fancy, that concerned place, they also swayed towards that therapy. The nodule was not confirmed to be benign. So இதெல்லாம் tricky things. So as Dr. Usha madam was saying, for osteoporosis, இந்த மாதிரி ஃபோரமில் வந்து black and white சில எதை சொல்ல முடியாது. Given patient வந்து nuanced, the nuance is the correct word. There will be a grey area. ஓவர் சிம்பிளிஃபைடாக நம்ம சொல்லி T3, T4 high, TSH இப்படியே பேசிகிட்டு இருந்தால் அது வேறு மாதிரி இருக்கும். Layers and layers of complexity are there with a given patient, and we need to individualize the therapy. This slide I deliberately put to give you the idea that Graves is also going to get not as simple as carbimazole, propylthiouracil. Yeah. Quickly, 2-3 case scenarios. That lady, we won't do any of this. We will do only antibody, and we will do uptake. We will offer medical therapy because she is young and she has gross orbitopathy. I will not give ablation. So all these are straight away. Now the picture paathe sollidala. She has severe orbitopathy, she has this. She comes after 2 months. T3, T4 konjam koranjiruchu. Nallave koranjiruchu. Symptoms. In fact, naanga padikum bodala we never used to do T3, T4, TSH every visit. Weight ஏறினாலே she is improving னு அர்த்தம். Only one clinical sign. And symptoms would have ablated. And TSH can get many months to come back to normal. That's one important point. So TSH won't normalize. நம்ம எல்லாரும் உடனே T3, T4 லோ ஆனால் TSH ஏறணுமே, கிரேவ்ஸில் ஏறாது, ஆன் தெரப்பியில் ஏறாது. இட் வில் டேக் 6 months 1 year டைம். இது உங்களுக்கு அதை பார்த்துட்டே இருந்தால் பழக்கத்தில் தெரிஞ்சிடும். Now she comes back like me with a severe sore throat and cough, and immediately your bell should ring whether she has a problem due to the carbimazole. So we should actually put a red label, a seal, or at least tell them that if they have such symptoms, they should stop carbimazole, check the counts, sometimes rarely. This is an idiosyncratic reaction. It is not related to dosing. நீங்கள் உடனே சிபிசியை மாதம் மாதம் பண்ணிலாம் பார்த்து வேஸ்ட். Only if the patient has a problem, you have to check. Okay, and suppose she is of that patient who is planning pregnancy only, the role of propylthiouracil. Today propylthiouracil has no role except for a transient period in the first trimester, because it is, unfortunately, it has got the dubious distinction of causing fulminant hepatitis. So it is out of vogue now. You use methimazole, carbimazole, that's all. And in all these patients, the salt kurakkiren adha pandren, it has no role actually. You use normal iodized salt for everybody. I am not going into pregnancy, this is too much of time. So this is very common. Routine health checkup when you have dysglycemia and thyroid is also checked, and if the TSH is low, please remember this thyroid can also contribute to that kind of a glucose abnormality. Make them euthyroid and recheck. This is a simple suggestion. And madam oda last talkum and number talkum directly connected. If you have TSH suppressed, two important risks: palpitation, stock-odium connected, atrial fibrillation, osteoporosis. Rendum direct thyroid all over. Adanal we are very, 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 very serious about TSH getting suppressed in 40, 50 plus people. It is not at all good. வருஷக்கணக்காக போட்டுருக்காங்க. நீங்கள் அப்போ அவங்கள அப்போ பார்த்தேன், அந்த 100 மைக்ரோகிராம் ஏதாவது ஒரு பிராண்டு பேரை சொல்லுவாங்க, அதையே போட்டுருக்கேன், 2-3 வருஷமாக செக்கே பண்ணல, TSH 0.1. பாவம் அவங்க நல்லா தான் இருப்பாங்க, ஆனால் உள்ள போனும் ஹார்ட்டும் பாவம் கஷ்டப்படும். அது வெளியில் வரும்போது ரொம்ப பாவமாக இருக்கும். அவங்க ஒரு ப்ராப்ளமோடு நம்ம அதை டயக்னோஸ் பண்ணும்போது இதனால தான் சொன்னேன், எப்படி 10 வருஷமாக இப்போ இந்த மருந்து தப்பாம்பாங்க. Anyway, this is long-term chronic disease, we have to be aware of it. So, TPO antibody ki romba role kidayadu. It may be positive in 30% of this. Suppose the uptake was less, this is called thyroiditis. Most often it is lymphocytic thyroiditis, which will just settle. You can call it hashitoxicosis also. Viral thyroiditis na nalla painful, very classic. Nama the corona bodala nariya paathom. The viral thyroiditis will be symptomatic for that. This is I just put because senior physicians are here. Most often we will have a cardiac patient, multiple medications including எங்களுக்கு catch point and amiodarone தான் கண்டு போகும், because it is containing iodine at least 10 times more than the daily requirement. And an elderly man, ischemic heart disease, he may be harboring a nodule. Our thyrotoxicosis போயிட்டார்னா, then we have two varieties, amiodarone induced type 1, type 2 thyroiditis or thyroid. So it's a very tricky situation. Invariably they have to be on carbimazole, frequent monitoring அதெல்லாம் தேவைப்படும். Heart failure level இருப்பாங்க. So the cardiologists take the lead role. From the thyroid point of view, as quickly as possible we have to adjust and get down on the thyroid by medical therapy alone. You can't be too heroic. இங்கே தான் நான் ஒரு புது பாயிண்ட் என்ன தெரிஞ்சுட்டேன்னா, in the last few monthsல, suppose this kind of a patient comes, he is in the ICU, thyrotoxicosis is very severe. The team feels that thyrotoxicosis is the main cause of heart failure. Then we have the role for plasmapheresis. That's where we should know. அதுக்கு தான் இந்த டயக்னோசிஸ்லாம் முக்கியம். இது கிரேவ்ஸ் டிசீஸா, ஆன்டிபாடி மீடியேட்டடா, இல்லை இது நாடியூலர்னால் நான் பேசுகிறது பிளாஸ்மாஃபெரசிஸ்லாம் பண்ண முடியாது. பட் கிரேவ்ஸ் டிசீஸாக இருந்தால் யூ டூ பிளாஸ்மாஃபெரசிஸ், within hours he will improve. Within a day or two he will improve, because the toxicosis will dramatically come down, antibody will drastically come down. நான் அதான் யோசித்தேன், என் ஃப்ரெண்ட்ஸ்டெல்லாம் பேசியிருந்தேன், ஐவிஏஜி கூட கொடுக்கலாமா, ஏன்னா எனிவே இட்ஸ் ஆல் மாப்பிங் ஆஃப் ஆன்டிபாடி. ஸோ தட் கேன் பி கன்சிடர்ட் பை சீனியர் ஃபிசிஷியன்ஸ். யூ வில் என்கவுண்டர் தீஸ் பேஷண்ட்ஸ் நவ் அண்ட் தென். ரொம்ப சிக்காக இருப்பாங்க. வி ஹவ் லாஸ்ட் அட்லீஸ்ட் 5 or 6 பேஷண்ட்ஸ் இன் த லாஸ்ட் 5 years. It is not that easy sometimes. Even young patients, அந்த ஹார்ட் ஃபெயிலியர்லாம் வந்து இந்த டாக்ஸிக் எங்கேயோ இருக்கும். நம்ம சும்மா கார்பிமசோலை போட்டுருப்போம், அவங்களுக்கு கன்ஜஸ்டிவ் ஹெப்படைட்டிஸ் இருக்கும், நம்ம ஆன்டிதைராய்டு ட்ரக்கிங் ஏற்ற முடியாது. யூ கான் கிவ் ரேடியோஐடின், தே ஆர் ஆன் அமியோட்ரோன் ஆல்ரெடி, சர்ஜரிலாம் ரூல்ட் அவுட்டு. இங்கே தான் வந்து இந்த புது தெரப்பிலாம் ஹீரோயிக்காக பண்ணணும். இந்த தைராய்டு ஆர்டரி எம்பலைசேஷன் இல்லை ஏதாவது ஒரு ஆல்கஹால் அப்ளேஷன், நாடுலாக இருந்தால் இதெல்லாம் பண்ணலாம். அண்ட் கிரேவ்ஸாக இருந்தால் பிளாஸ்மா ஃபெரசிஸ் பண்ணலாம். That is a possibility. This is just to give new thoughts on this. Quickly coming to hypothyroidism, this is classic, all of you know. TSH very high, T4 very low. Patient has quite a few symptoms which are quite commonly attributable to hypothyroidism, except weight gain. The weight gain, weight gain happens even without thyroid problem, but irregular cycle, tiredness, fatigue, yes. So we all know this negative feedback mechanism. TSH goes very high. That is how it should be. Then only the diagnosis of primary hypothyroidism is classic. This is straightforward. Then comes this kind of patient we very commonly see T3, T4 normal. T3 வேண்டாம், T4 போதும். It could be free T4 because in Chennai all the major labs they do free T4 more commonly than T4. நாங்கள் படிக்கும் போதெல்லாம் total T4 தான் எழுதுவோம், இங்கே தான் free T4. But anyway, TSH is elevated. இதை ட்ரீட் பண்ணுமா வேண்டாமா? This question always comes to everybody's mind. Many guidelines are getting revised. Overall, the first, can anybody just for interaction, எல்லாம் ரொம்ப நாயாக நான் பேசினேன். What will you do, madam? Somebody in the audience, will you treat this patient? She is a... Yeah, absolutely, absolutely. You should do clinical examination. It's normal. goiter இல்லை, என்ன பண்ணுவோம்? ஃபேமிலி ஹிஸ்ட்ரி நம்ம ஊரில் என்ன ப்ராப்ளம்னா, இந்த மாதிரி எல்லா பேஷண்ட்டையும் ட்ரீட் பண்ணி யாரை கேட்டாலும் தைராய்டு ப்ராப்ளம் இருக்குன்றாங்க. நீங்கள் ஃபேமிலி ஹிஸ்ட்ரி வந்து நிஜமாகவே TSH 150க்காக ஆரம்பித்ததா இல்லை அவங்களுக்கும் இந்த மாதிரி 7-8க்கு ஆரம்பிச்சதான்னு எப்படி தெரியும்? டிபியூ ஆன்டிபாடிக்கு முன்னாடி என்னோட ஒரு ஸ்மால், இன்றைக்கி டிபியூ ஆன்டிபாடி பண்ணி தான் ஆகணும். ஐ எம் நாட் சேயிங் சார் இஸ் ஜெயக்குமார் சார் இஸ் அப்சல்யூட்லி கரெக்ட். பட் என்னோட ஒரு ஸ்மால் ரெக்வஸ்ட் இஸ், இதை ஒரு வாட்டி ரிப்பீட் பண்ணுங்க இந்த டெஸ்ட்டை. ஒரு 6 வீக்ஸ் கழிச்சு 12 வீக்ஸ் கழிச்சு, அன்லஸ் ரொம்ப ரேராக இந்த 18 year old உடனே நாளைக்கு இவ ஜெர்மனி போகிறா, அடுத்த வாரம் போனால் அப்புறம் வரத்துக்கு 1 வருஷம் ஆகும் போட்டு நம்மளை பாதி நேரம் சோஷியல் ப்ராப்ளம் தான். மெடிக்கலி இட்ஸ் ஈஸி டு சே, நான் படிக்க போகிறேன் வரேன், இல்லை வந்து இவளுக்கு 24 வயசாக இருக்கும், அடுத்த 6 மாதத்தில் கல்யாணம். தேர் கம்ஸ் தி, அது உங்களுக்கு ஸ்லைடில் போட முடியாது. அதுதான் இண்டிவிஜுவலைசேஷன். அதுதான் வந்து யூ ஷுட் நோ ஆல் ஃபெசட்ஸ் ஆஃப் தி ப்ராப்ளம். எனிவே, பெஸ்ட் வில் பி டு ரிப்பீட். நம்ம ஊரில் லேபு அது வேறு, நம்ம அதுக்குள்ளே போக வேண்டாம். இட்ஸ் நாட் த லேப் விச் இஸ் இன் ப்ராப்ளம். பயோகெமிஸ்ட்ரி பீப்புள்கிட்ட நான் நிறையா பேசி வாட் ஐ லேர்ன்ட் இஸ், டுடே ஆல் த மிஷின் ஸ்டாண்டர்டாக அந்த 3 மிஷின் தான். ரோஷு, சீமன்ஸு, பெக்மன் கோல்டரு, அந்த 3-4 ஆபட், அட்வியா, சென்டார், 4 மிஷின் மேக்ஸிமம் போனால். 4 ஃபோன் தானே இருக்குது, 4 கார் தானே வண்டி ஓடின்னு இருக்கோம், எல்லாம் அந்த 5 கார் தான். அதுலேயும் சில கார்லாம் வந்து இன்ஜின் வந்து ஒரே இடத்துல தான் வருது. அந்த மாதிரி மிஷினுக்கு தப்பு பண்ண தெரியாது அப்படின்னு எல்லா பயோகெமிஸ்ட்ரி சப்போஸ் எனக்கு நான் லேப் எரருங்கிற வார்த்தை சொல்லாதீங்க. இட் இஸ் மோஸ்ட் ஆஃபன் ப்ரீ அனலிட்டிக்கல் எரர் ஆர் இன்டர்பிரிட்டேஷன் எரர், ஆர் அவன் பண்ணும்போது ஒழுங்காக போடல, லேபிளில் தப்பாக போட்டான், அதெல்லாம் என்ன பண்ண முடியும். அண்ட் இஃப் தி மிஷின் இஸ் நாட் மெயின்டைன்ட் வெல், இட் இஸ் தட் ஃபார். எனி குட் லேப் இன் சென்னை மீன்ஸ் அட்லீஸ்ட் 30, 40, 50 samples பர் டே வர இடத்துல வந்து பிரச்சனைலாம் வராது. வந்ததுன்னா அப்போ அந்த அவங்க சம்திங் எல்ஸ் இஸ் ராங். அண்ட் ஒரு குவாலிஃபைட் பர்சன் சூப்பர்விஷனுக்கு இருந்தால் ஒன்றும் வராது, அதெல்லாம் வராது. எனிவே, ஜஸ்ட் டு டெல் யூ தட் திஸ் இஸ் பை டெஃபினேஷன் கால்ட் சப்கிளினிக்கல் ஹைப்போதைராய்டிசம். தட்ஸ் த டேர்ம் வி யூஸ். இது ஏன் தான் அந்த வார்த்தையை வச்சாங்கன்னு தெரில. யூ கேன் கால் இட், என்ன சொல்லுவாங்க, என்னது யூதைராக்சினிமிக் ஹைப்பர் தைரோட்ராபினிமியா அப்படின்னு சொல்லலாம். இது டு கால் இட், இது வெறும் TSH, இட்ஸ் a biochemical diagnosis that it won't relate to anything. When will it have clinical significance? If you repeat it after a few weeks, 6 weeks or 12 weeks, it shows progressively increasing trend over the next 6 months. So as practitioners, all of us have to repeat once more from more reliable lab. If that is also showing 9 and 10, then use your common sense. Then அங்கே தான் சார் சொன்னதெல்லாம் வரும். Does she have any other autoimmunity? Does she have any other problem which can explain this? அதில் தான் இதெல்லாம் வரும். இதெல்லாம் நீங்கள் ஹிஸ்ட்ரியிலே கொஞ்சம் கேட்கலாம். இதில் பிட்யூட்ரிலாம் விட்டுருங்க. இந்த ட்ரக்ஸு, recent illness, very common. See, I am having a severe viral and post-viral problem for the last 2 weeks. If I do my TSH now, it will be invariably elevated. நான் வேறு இப்போ 2 வாரமாக எங்கள் எல்லோரும் டெஸ்ட் பண்ணல. நான் இப்போ டெஸ்ட் பண்ணேன்னா டெஃபினட்டாக ஐ எம் ஷுர் மை தைராய்டு வில் ஷோ a recovering trend and I will be labeled subclinical. And you can have people with other illnesses also recover. And in another common question asked in all our forums is, fastingல பண்ணுமா அப்புறம் பண்ணுமா? we have tried to answer it by a couple of studies where we showed that fasting TSH, morning TSH will be always 2 to 2.5 units more than afternoon or evening. And we showed that it is not due to food, but it is due to the time. So any TSH done between 7 a.m. to 9 a.m. will be higher than anything done after 10 a.m. by to the tune of 1.6, 2.5 varaiyum. So you can imagine, pregnancy illa adum gynecologist la inga irundanga theriyadhu romba narrow pointe irukum. 2.5 to 4 kulla irundha enna பண்ணுவேன்னு கேக்குறாங்க. TSH ங்கிறது இன்ஹெரண்டாவே அதுல 0.6 to 0.8 வேரியேஷன் இருக்கும். பெஸ்ட் ஆஃப் லேப்ஸ்ல கூட. Repeatability, reproducibility, coefficient of variation, which assay, third generation, fourth generation. Anyway, this is very important to pick up for senior physicians. Patient will have symptoms suggestive of hypothyroidism, but the reports will show this. நீங்கள் லேப் எரராக இதை எடுத்துக்கூடாது. யூ ஷுட் ரிப்பீட்டும் இதே மாதிரி காமிச்சா வாட் இஸ் த டயக்னோசிஸ்? பாசிபிலிட்டி the T4 is low and the symptoms are very suggestive. Any guess? One important catch here is the feedback is not operating. You see, the TSH should have gone like the first patient, more than 150. It's not happening. This is called inappropriately normal TSH for the low free T4. So, in the patient, ஒரு simple thyroid test வச்சே நம்ம இது pituitary problem னு சொல்லிடலாம். So, this patient should undergo an MRI, cortisol estimation, prolactin, இதெல்லாம் தான் next. To rule out pituitary tumor, invariably they will have a pituitary. I can write it. It will be pituitary. Unless நீங்கள் அல்லது ஏதோ மிஸ் பண்ணுறீங்கன்னு அர்த்தம், அல்லது அந்த அளவுக்கு அந்த லேப் நம்மளை குழப்பிடுச்சுன்னு அர்த்தம். That's a rare possibility. But she has symptoms also. You see here she has some sleepiness, headache வேறு இருக்குது. You can guess it. So thyroid profiles can give you rare diagnosis also. I am not going into hormone resistance, congenital, elderly, sickness, pregnancy. அதெல்லாம் நான் மிஸ் பண்ணிட்டேன் because already இன்னும் ஒரு நிமிஷம் தான் இருக்குது. Quickly, this will encounter, this elderly person is saying, நான் ஒழுங்காக தான் மாத்திரை போடுறேன், ஆனால் டிஎஸ் திருப்பி 80, 90. இன்வேரியபிளி நம்ம ஊரில் கம்ப்ளைன்சேஷன் இஷ்யூ, டக்குன்னு பிராண்டை மாற்றிடுவாங்க. they will go for some Jan Aushadh kind of brands which are not of high quality. I don't want to go into it. Please be aware of it. So you can have antibodies also interfering with the assay. This is biological. We published a paper recently on how scrub typhus patients, due to their Will-Felix kind of that antibody, they had abnormal thyroid functions. At least 8 to 9 patient பாதணும். So be aware that antibodies can interfere in the assay, just like how it. So a hypothyroid patient comes to you on follow-up. The patient is on 100 microgram thyroxine. What will we do? Reduce the EC. Reduce by 25. Damol dimil மாதும். ஒழுங்கா போட்டாங்களான்னு கேட்கணும். இது ஒழுங்கா போட்டால் தான் இப்படி வரும். டெஃபினட்டாக. நெக்ஸ்ட் இந்த மாதிரி வந்தால் சேம் 100 மைக்ரோகிராம் ஏற்றுறதுக்கு முன்னாடி செக் கம்ப்ளைண்ட்ஸ். கரெக்டாக போடணும், வெறும் வயிற்றில் போடணும், அரை டம்ளர் தண்ணியில் போடுங்க, 1 hour இதெல்லாம் பண்ணி சொல்லிகிட்டே இருக்கேன். நான் ஒரு 1000 வாட்டி இதை சொல்லிகிட்டே இருப்போம். அப்பயும் அது பாவம் விட்டுருவாங்க. அது போர் அடிக்கும். டெய்லி போடுறாங்களே அது குழந்தைகள்லாம். And very rarely absorption is a problem. But please remember, they are all in the autoimmune spectrum. They can have atrophic gastritis. இதோட 3 talkலையும் we have commonly said proton pump inhibitors will decrease absorption. All acidity is required for absorption. So that could be a reason. Suppose it's like this. இது நம்ம HbA1c சுகர் மாதிரி டெஸ்ட் இன்னைக்கு ஒண்டி மாத்திரை ஒழுங்காக போட்டிருக்காங்க, அதனால தான் 1. அல்லது மாத்திரையை போட்டுட்டு டெஸ்ட் கொடுத்துருப்பாங்க, அன்றைக்கி ஒண்டி நல்லா வரும், மற்ற நாளில் ஒழுங்காக போடல, அதனால தான் TSH is high. நம்ம HbA1c கண்ட்ரோலில் இருக்காது, ஆனால் அன்றைக்கி சுகர் நல்லா இருக்க மாதிரி இருக்குது. This is that. Again, compliance is a problem. Rare thing. The last one I am not going to discuss. So just to we all in the mari meetings, thanks to the organizers again, we are rededicating ourselves for better patient care by approaching it holistically and keeping diagnosis as straightforward. Thank you. Thank you very much. Thank you.
Thank you very much, Sriram. And I think of the 4 speakers, 2 speakers are available. We can have 1 or 2 questions quickly before the inauguration.
Mike. பரவாயில்ல.
That can happen with intracellular conversion of T4 to T3. If it is not happening properly, the first thing to go is TSH, because intracellular energy sensor is a AMPK. That AMPK stimulates the hypothalamus to release the TSH from the pituitary. So can we take
இதுதானே? Oh, sorry.
yes, subclinical hypothalamus where low T4 and more, high TSH. So that situation where we come across day and out, and whether this should be taken as a cellular hypothyroidism, which is reflected only by a rise in TSH, where T3 T4 is normal. Because know that before you fall in the T3 T4 levels, the AMPK acts on the hypothalamus and stimulates the pituitary to increase the TSH, because the cellular energy is less. That is sensed by this. So can we take it and treat, even though guideline is not now recommending to treat it so aggressively or initially?
This very, very tricky question. Sir, the T3 plus T4 therapy talks எதாவது கேட்டிங்களா? அல்லது அதை பற்றி எதாவது படிச்சிங்களா? Because அங்கே தான் இதை பற்றி இந்த tissue hypothyroidism concept is coming from there.
Yes.
If you take pituitary as a tissue, we take pituitary tissue as a surrogate marker of the whole body's euthyroid state. Yes. That's what we mean when we say I give thyroxine and TSH normalizes, means அதே மாதிரி தான் மற்றதெல்லாம் ஆகும். But common sense tells us that medicine is not as simple. Other tissues, there may be a lagging time. Other tissues may not be as normal as pituitary. So when you have TSH going down well with T4 therapy, thyroxine therapy, it means T4 to T3 conversion is excellent.
Yes.
Deiodinase, in fact, hypothyroid state la vandu the deiodinase type 1,
Yes.
which is supposed to convert peripherally T4 to T3, they are supposed to be hyperregulated. They are very rigor. They'll be waiting for T4 to come. So நீங்கள் சொல்கிற மாதிரி conditions are rare. நீங்கள் சொல்கிறதுலாம் அந்த deiodinase defects, some rare congenital conditions may be there. I'm not going into it. That's beyond. அதெல்லாம் அந்த thyroid hormone resistance அந்த மாதிரி condition low. 99% of what we see in general in population is when you have hypothyroidism, நீங்கள் வெறும் T4 கொடுத்தாலே எல்லாம் நார்மல் ஆகிடும். 90%.
Thank you.
புதுசாக ஒரு குழப்பம் எங்கே கொண்டு வராங்கன்னா
Parandaman, I think we will continue the discussion
over a cup of tea.
We have shortage of time.
Sir, good morning, sir. I have one very short question.
Make it very short, ma'am.
Yes, sir. My question is to Dr. Vijaya Shankar. In his
I think he is not here now.
Okay, he mentioned about neon, and he also mentioned it is a painless condition. So I would like to know, we have not faced any neon conditions in Chennai. So only in T Nagar Lions Club, Dr. Rajan has reported one, but we do not have much details. He has not mentioned it. So what is your take on that? Especially now with lot of anti-obesity hype drugs hype in the market.
I am sure, ma'am, everybody has the same question. But we don't have much data, even in the internationally, we don't have much data on GLP-1. I think only one case they reported, and after that we didn't hear anything more than that.
Yeah.
So
I'm sure are not
I'm sure we more and more usage of GLP, then only we'll know what is the exact incidence of this neon.
He has mentioned it is a painless condition, sir.
Yes, it is a painless.
Okay, right. Thank you, sir. Thank you.
Thank you so much. Thanks a lot. We'll close this section. Thank you.
With that, we have come to the end of the first session. I thank all the speakers for their engaging and insightful presentations. Now we move to the formal inauguration of DCON 2026. To begin the inaugural ceremony, I kindly request you all to rise for the rendition of Tamil Thai Varthu. Yes, thank you.
பாரத கண்டமெனில் திக்களவும் அதில் சிறந்த திராவிடர்கள் திருநாடும் தத்த சிறு திரை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Now we have Ms. Pragati with us to sing a prayer song. Over to Ms. Pragati.
मैत्रीं भजत अखिलहृजेत्रीं मैत्रीं भजत अखिलहृजेत्रीम् आत्मवदेव परानपि पश्यत आत्मवदेव परानपि पश्यत युद्धं त्यजत स्पर्धां त्यजत युद्धं त्यजत स्पर्धां त्यजत त्यजत परेष्वक्रममाक्रमणं त्यजत परेष्वक्रममाक्रमणं मैत्रीं भजत अखिलहृजेत्रीं जननी पृथ्वी कामदुगास्ते जननी पृथ्वी कामदुगास्ते जनको देवः सकलदयालु जनको देवः सकलदयालु दाम्यतदत्त दयत्वं जनता दाम्यतदत्त दयत्वं जनता श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां.
Thank you, Pragati. That was beautiful. Please remain standing as we now proceed with the traditional lighting of the lamp. May I respectfully invite our esteemed dignitaries to the center of the place for the ceremonial lighting of the lamp. Dr. Usha Sriram, Dr. Swami Kannu, Dr. Parandaman, Dr. A. Natarajan, Dr. Dhanamitran and Dr. Jayakumar. Please do the honors. Thank you, everyone. Please give them a warm round of applause and kindly be seated. Now we move to a very special segment of today's program. It is now time for the Professor Dr. V.T. Balraman Memorial Oration, a tribute to the life, legacy, and invaluable contributions of the late Professor V.T. Balraman to the field of diabetology. We are honored to have Professor Dr. J.S. Rajkumar deliver this year's memorial oration.
It is my pleasant duty to read out the citation of Professor V.T. Balraman Oration Citation. DCCON 2026, Saturday, 11th July 2026, Ramada Plaza, Gindi, Chennai. It is a matter of
Unfortunately, doctor is not here with us due to unavoidable circumstances, so he sent us a video, so we will be playing that video for all of us now. Yes, thank you.
Sorry for the inconvenience. Sir is not able to make it today's function because he's got held up in Dubai. So, and video show, we just read out the citation. It is a matter of immense pride and privilege for organizing committee of DCCON 2026 to honor an outstanding surgeon, distinguished academician, visionary leader, healthcare leader, accomplishing author, and inspiring humanitarian, Dr. J.S. Rajkumar. He is a chairman and chief surgeon of Lifeline Multi-Specialty Hospital Private Limited. He is a consultant surgeon gastroenterologist, Malar Hospital, Chennai, the adjunct professor of Sri Balaji Medical College Hospital, and a visiting professor of Mahatma Gandhi Institute of Medical Sciences, and internationally respected ambassador of Indian surgery. Dr. Rajkumar's journey is a remarkable story of brilliance, dedication, and excellence. He is an alumni of Don Bosco School, Egmore, Chennai. He secured state rank in 1979 and emerged as a national topper in the NCET-RT examination. During his medical education between 1980 and 85, he received extraordinary 32 gold medals and academic awards reflecting an exceptional commitment to scholarship and excellence. He was also honored with Best Outgoing Postgraduate Medical Student Award during the Master of Surgery training in 1997. His pursuit of surgical excellence led him to earn fellowship from most prestigious surgical colleges across the world, including Royal College of Surgeons, England, Edinburgh, Glasgow, and Ireland. Over the years, he has been elevated a fellow of numerous distinguished professional organizations, including the International College of Surgeons, Chicago, the American College of Gastroenterology, the International College of Angiology, Royal College of Society in London, and the International Medical Science Academy, and many other places. He is a minimal access surgeon in India and is a several national, international surgical bodies recognize his excellence. As the founder of chairman of Lifeline Multi-Specialty Hospital, Dr. Rajkumar has combined clinical excellence with the compassionate patient care, innovative surgical practice, academic mentorship, visionary hospital leadership. His contribution to minimally invasive surgery and surgical gastroenterology has been earned his admiration and respect college across students and patients across India. Today, we are privileged to have Dr. J.S. Rajkumar deliver the most prestigious Professor V.T. Balraman oration on the thought-provoking topic, "Forever Young is Medically Prone." In recognition of his outstanding contribution to surgery, medical education, academic excellence, hospital leadership, literature, and dedicated service to the society, the organizing committee of DCCON 2026 takes great pleasure in conferring upon Dr. J.S. Rajkumar the prestigious Professor V.T. Balraman Oration Award. Ladies and gentlemen, it is our proud privilege to invite J.S. Rajkumar to deliver the Professor V.T. Balraman Oration.
Afternoon to all our lovely doctors there. I am really pleased and honored to deliver this Professor V.T. Balraman oration for the Doctors Conference 2026. I want to start by thanking the entire panel of organizers, especially Dr. Natarajan and Dr. Dharani, for having invited me to give this oration. I consider it a great honor and privilege. I am following the good work of the Doctors Club, and I am very proud to note that such a group of academics who are interested in keen pursuit of clinical medicine are operational in our wonderful golden Chennai. Next, let's talk about Professor VTB. I was fortunate to be part of his 34-year-old journey in the Madras Medical College. We all used to attend his clinics and his classes. Famed for his humor, he used to hold us thrilled to our chairs. Specifically, the terms that he used to describe a diabetic's problems, where Professor VTB used to say, "Sir, na thanni goda 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 nu kudikren, ana urine mattum goda 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 nu pogudhu." They are unforgettable to describe the polydipsia and polyuria of a diabetic. Many more phrases of his describing situations in clinical medicine have become immortal in the corridors of Madras Medical College. Most importantly, he was a man who wished the best for all his students, and to this day we all remember and think of Professor V.T. Balraman with love and affection. It was a crowning glory that Professor VTB got a Lifetime Achievement Award when we celebrated 175 years of the immortal Madras Medical College. We always crave his blessings today and forever. Right, on to the topic then. Is it possible to remain forever young? Is it medically proven? What is the data? Well, Professor VTB was forever young throughout his life. The concept of longevity or extending one's physical and biological age has been known since time immemorial. For this, one has to go back to Sri Krishna and the Bhagavad Gita, where he actually says, he describes all the human beings on earth as ghatasum or aghatasum, either those who have died or those who are waiting to die. In a sense, every one of us, every organism, from the time of its birth, it has got the apoptosis or programmed cell death, where all our times are marked. But it is possible, using medical data, using a mixture of East and West, to prolong this and add life to years and years to life. Let us then move on to looking at what medicine 1.0, 2.0 and 3.0 are. 1.0 medicine is basically just treating disease completely empirically. Medicine 2.0 for the last 30-40 years before was treating a disease after it attacked a human being. Now we are in the era of medicine 3.0, where you anticipate disease, studying the genes and the background of a man, and ward off anything that could possibly kill him or her so that you can extend the life. So we are in the age of medicine 3.0. Let us see how we can use it for our longevity. The Holy Bible speaks of the 4 horsemen on white horses who will appear at the time of the damnation of the world. They are called the horsemen of the apocalypse. Well, today's mankind is also looking at 4 such horsemen who are the biggest killers of humanity today. Many of you may be thinking that COVID killed a lot of people. COVID killed 4.5 million people on the planet. Wow, right? And 1.5 million in India. Wow, right? Every year, even during COVID, the number of people who are getting killed by these 4 horsemen is close to 4 crores or 40 million people. Who are these 4 horsemen? Let's study about them. All of longevity medicine is based on keeping these 4 horsemen away so that we could live long and healthy lives. These 4 horsemen that kill 80 to 90% of humanity are: number 1, heart disease; number 2, cancer; number 3, neurodegenerative diseases like Alzheimer's, Parkinson's; and number 4, metabolic disease like diabetes. Let's take the heart for example. In Tamil Nadu, every year 7 to 8 lakh people die of all causes. Of these, 36%, that is close to 2.5-3 lakh people, die of heart disease. This suddenly clutching your chest and dropping down dead occurs to about 1,500 people every year in Tamil Nadu, but nearly 2.5 to 3 lakh die of heart disease, and that is only the tip of the iceberg. Let us study these 4 horsemen in great detail. The famous Stoic philosopher in Rome, Epictetus, was asked, "Tell me one universal truth." And he said, "Everybody dies." That is the truth. There's a famous story of a Greek demigod called Tithonus. Now, Tithonus prayed to the gods for eternal life, but he forgot to ask for eternal health. So he just remained old and weak and completely knocked out, but not dead. So it's useless to just live long, but to live like a vegetable. So therefore, it's important for us to add not only years to our life, but we must add life to our years. We have to look no further than people like Tirumular, who reportedly lived for 3,000 years in the 7th century. Even well before that, thousands of years before that, we have Agathir, who wrote, which is the basis of Siddha medicine, of course, of how to live long and to live healthily. In other words, my dear friends, every one of you doctors must also live ages that are far lower than your chronological age. You could have a chronological age of 60 or 70, but you should have a biological age of 30 or 40, and that is the principle of anti-aging therapy or of longevity. We talked of medicine 1.0, 2.0, and now 3.0, which includes anti-aging medicine, customized, personalized medicine, etc. The sheet anchor of medicine 3.0, especially for longevity, it relies on lifestyle modification, diet, exercise, sleep, which we doctors don't do very well. Very important, these 4 or 5. I will talk about them in detail. It's not just exercise, but how you exercise. Apart from these, you have disease-modifying drugs. If you allow your diabetes to get you, if you allow your BP to get you, it's pointless. Last but not least, it depends upon specific drugs known as specific anti-aging medication. This is what we're going to talk about. This entire list that I gave you, if every one of you could follow it, you will certainly be able to add good life to your years, and you will be lowering your age tremendously. Let's jump into this interesting topic. So every slide that I'm going to tell you is going to affect your life, so please listen carefully. First, blue zone concept. Across the world, there are many places in which people live to more than 100 years in a very, very high proportion. And these zones all over the world are known as blue zones. 2 of the big blue zones are found in Japan, and the others are scattered all over the world. What is common to the people who live more than 100? The so-called centenarian zone. All of them have healthy food. Almost none of them go to, Pizza Hut or Burger King or McDonald's. None of them splurge on aerated drinks. They all believe in good sleep. Almost all of them have a sense of purpose. They may want to attend to a garden. They may want to go and play bingo every Friday. They may want to learn dancing. And this kind of behavior in the blue zone causes a slowdown of vascular aging. In other words, yes, my dear friends, you are only as old as your blood vessels. Your hair could be white or gone. Your skin could be wrinkled. But if your blood vessels are clean to the brain, to the kidney, to the heart, to the lungs, you will be forever young. In other words, a man is only as old as his blood vessels, and one of the sheet anchors of anti-aging medicine is to keep the blood vessels from getting clogged. How do we go about this? Let's see. Of the 4 horsemen of the apocalypse, the only one that medicine 2.0 has managed to contain is heart disease. Why? Thanks to angioplasty, stents and coronary artery bypass, we have managed to materially extend the life of those whose cardiac disease, especially coronary disease, is picked up early. The cardiac disease load in India is huge. Many of you here might be having silent coronary artery disease. My humble request is, please do a proper forecast of your own self. If you're a diabetic, hypertensive or a dyslipidemic, especially if you have any symptoms when you climb up stairs or symptoms when you do the treadmill or when you walk, please go and get a coronary CT. Nothing is as accurate as a CT coronary angiogram. There are all these cardiologists will say, oh, this is the false negative, false positive. What we know is that if your coronary arteries are as clean as a whistle in a CT coronary angio, you definitely don't need anything. And if they show more than 70-80%, you definitely need something. In between, there is an area where nobody knows exactly what's happening. When in doubt, please do that coronary angiogram. It might well save your life, as it will show us the road as to what kind of intervention we should do. Soon we will see how the drug-coated stents, like rapamycin-coated stents, are steeped in history. But for now, watch your coronaries in order to live long. Genetics and aging or degeneration have a very strong linkage. We are all programmed to die or to get degenerated at a particular time based on our genes. Let me give you 2 examples. There are numerous examples. One is the ApoE gene. The ApoE gene comes as ApoE 1, 2, 3 or 4, any of these pair of alleles. In a family, anybody with an ApoE 4 has a very high tendency to develop Alzheimer's disease and neurodegeneration. On the other hand, ApoE 2 actually gives an anti-Alzheimer's and an anti-aging link to the patients. This is why when we work up patients for anti-aging, we always go to genes to find out. It's like looking at the horoscope. What can hit this patient in the next few years, and then we take steps to block it. Finally, there are some genes that will help us, like the FOXO3 gene. Brilliant gene that most of us have. This FOXO3 is the gene that is responsible for anti-apoptosis, for autophagy, etc. Can you activate your FOXO3 gene? Yes, you can. By exercise and by caloric deprivation or intermittent fasting. These two things activate our FOXO3 gene, which in turn mediates and prevents cellular damage and retards the process of aging. So that's the link between genes and aging. Right, so shall I give an action plan for all of us to live long and to live well? Very simple. Eat less, live long. We know that food itself is a toxin. Every major study on longevity done on animals shows that those animals, especially rats, that were starved, not completely starved, kept on under-caloric inputs, or ate less, starved, were the ones that lived longest. So eat less and live long. We follow the crazy Caucasian pattern, breakfast, lunch, dinner. Who gave us that pattern? So beautifully in Tirukural it says, Marundena vendam yakaiku. Your body, yakai means your body doesn't require any medicine. Arundiyadu attradu potri unin. If you understand that what you have eaten is digested, then you eat. Don't simply eat before that. And Avaya so beautifully said that in 2 words. Quran itself is 7 words. 2 words. Pasit pusi. Feel hungry and then eat. This is one of the secrets of living long, is to eat less. Now how does it happen? When you eat less, there are certain complexes called mTOR complexes inside our cells. These complexes are responsible for certain metabolic changes, making you diabetic, making you a cholesterol patient. The mTOR complexes have got mTOR1 and mTOR2. mTOR1 is suppressed when you go into caloric starvation. mTOR1 is suppressed by rapamycin. We will talk about that shortly. Suppress your mTOR complex 1. Live long. How? By eating less. I always would say, have breakfast, lunch and dinner. And your figure also will be like this. Instead of breakfast, lunch and dinner, in which case we will all resemble oversized ulakkais. When it comes to diets, there's a wide variety that you can take. I will tell you that one of the longevity diets is a diet that I am personally on. It's a complete vegan diet, otherwise known as the Esselstyn diet or the Dean Ornish diet. Esselstyn from the eastern seaboard of America and Ornish from the western seaboard. They both found out that any form of animal protein, can be milk, can be yogurt, can be anything which contains a non-human protein, can be egg, causes an autoimmune reaction. And this causes subendothelial plaques and can cause vascular clogging. They proved that patients who could not have stents put in, who could not have bypasses, stringy blocked vessels, even these patients were living much longer when they were put on a vegan diet. So that's the vegan diet. It's a difficult diet and you'll always be deficient of protein. You have to keep taking soya, tofu, etc. The Atkins and the paleo diets, those of you who are meat lovers, if you want to lose weight, take the Atkins diet. It means only fat and only lots of protein, almost zero on carbs. You lose weight, not so good for blood vessels. Paleo diet, again, what the Paleolithic man had, mainly meat and some berries, good to lose weight, good to get good stringy muscles, not so good from the point of view of longevity. Here we come. What is TRF? Time restricted fasting. Don't eat after 6 or 7. Don't eat until 6 or 7. About 12 hours if you're over 50, 55. 16 hours if you're younger. Even 18 hours if you're even younger. When you time restrict and fast, the pancreas, which is normally sleeping in the evening and night, is not activated. And therefore, your insulin, which causes fat, which causes a lot of metabolic changes, will get reduced and your insulin resistance will come down. The bottom line, my friends, is CR, calorie restriction. If you want more of weight loss, you go for TRF, time restricted fasting. If you want muscle but calorie restriction, go for paleo. If you want to protect your blood vessels of your brain, and your coronaries and your kidneys and your legs, go for vegan. So there are various types of nutrition. The last 3 points that I want to tell you, nutrition should be constantly in your mind. You should have a judicious mix of protein and carbohydrate. Never forget, the more protein you take, the better for you, except if you're suffering from diabetic nephropathy or kidney failure. Protein is always better than carbohydrate. Plant protein is always better than animal protein. So if you have to choose between, say, peas and soya and tofu on one side and beef, etc. on the other, or mutton on the other side, which is safer for you. So this is a quick bird's eye view of the importance of nutrition in longevity. Good luck. Let's talk about exercise, another sheet anchor of anti-aging therapy. Every one of you must study your Vmax O2, every one of you. That means it's like a treadmill. You run fast and find out how much oxygen you are consuming as you exercise. It's very important as a measure of your aerobic activity. Please remember that what is very, very useful for every one of us is level 2 aerobic activity. It is not Vmax, not maximum. But you walk at a pace like 4 kilometers an hour or 5 kilometers an hour, at which you can talk to your friends. Like many people walk around the apartments, around the park, chatting together. It is very good. When you chat, you feel good. Plus, level 2 means you can maintain a conversation. What happens? When you do level 2 oxygenation, you increase your brain-derived neurotrophic factor and you increase the mitochondrial output known as mitochondrial biogenesis. This increases the amount of mitochondrial availability for you, which is the most important basis of anti-aging. Finally, HIIT, high intensity interval training. You walk for 4 or 5 minutes. You run for 1 minute, really fast. Then walk on the treadmill, very slow. Run. If you put in this intermittent sprinting, not if you're above 55, 60, etc., but this HIIT is very good for you. Strength. Please, all of you must not just walk around the park and go home. Carry 2 books. Carry Bhagavad Gita on one side, Bible on one side, something. Carry some heavy books. You can help your wife by carrying groceries, bottles, whatever. You should be able to carry your exercise. Strength training should be like bench press, pull-ups, push-ups. All these are anti-gravity. We know that using anti-gravity muscles will definitely slow down the aging process. There is enough data to say that those who do yoga properly tend to live longer, especially those who are doing the extension or anti-gravity like Bhujangasana, Dhanurasana, etc. Never forget that the shoulder, hip and pelvis are very, very important, not just in yoga but even simple exercises. So please do squats, do shoulder rotational exercises, do hip opening exercises where you rotate the hip, not just sit down and get up. Some of the weaker muscles as we grow older are the gluteus and the quads. So you can lie down in the prone position, raise your legs to give you the gluteal exercises, and of course squats for the quadriceps. So the muscle and bone complex is very important as you use your muscle. The bone will also be vascularized and there is a less chance of osteopenia, osteoporosis or fractures, common cause of mortality in the elderly. Many drugs and hormones can slow down your aging process. Earlier, it was thought that people's hormones came down because they got old. Now we know that their hormones come down and so they become old. So by replacing your testosterone, or if you're a female, your estrogen, your progesterone, by replacing your DHEA, which is dihydroepiandrosterone, a byproduct in the cortisol to testosterone pathway, which is known as the happy hormone. You feel high when your DHEA is high and you feel down when the DHEA is low. That's why we check the DHEA for people who feel down in the post-menopausal or post-andropausal era. Similarly, there's a drug called NMN, which is a nicotinamide that activates the mitochondria, but that is not fully clinically proven. On the other hand, melatonin. Not only does melatonin give you very good sleep, which is good and refreshes you, it also acts as a neurotransmitter, telling your hypothalamo-pituitary axis that you're still young, and activates cortisol, activates the entire adrenal, activates the anterior and posterior pituitary. Brilliant hormone, melatonin, something that I personally believe in. Also, omega-3 fatty acid found in flax, often maximally found in fish, is a general anti-inflammatory which decreases the chances of subendothelial plaques breaking off. So, anti-inflammatory drugs, very important. Finally, you want to look very nice like Tom Cruise or Brad Pitt, all these 50 and 60 plusers who look very handsome and young. You need growth hormone, which makes your skin and your hair and your bones and muscle look like you're a 20-year-old. Very, very expensive, number one. Number two, it needs to be injected. Number three, it has its own side effects, like increasing your sugars, sometimes increasing your BP, etc. So this is one of a range of drugs and hormones that you can take to look and to be young. Let's look at one of the other horsemen of the apocalypse, neurodegeneration. You will not believe it, but a large number of Indians are beginning to suffer from neurodegenerative disorders like Alzheimer's, Lewy body disease, Parkinsonism, atherosclerotic brain disease, dementia, etc. Simply getting more than 6 to 8 hours of sleep every day, 6 to 8, is a preventative factor. Why? Because this beta amyloid, the protein that coats your brain in Alzheimer's, gets washed off when you sleep. There's another protein called tau, T-A-U, that gets deposited. That also gets washed off. We know that cortisol causes deposition of beta amyloid. Avoid stress or decrease stress. Do some meditation, do some sleeping, watch some movies with your spouse and decrease that stress, decrease your beta amyloid. Simple cold pressed, unheated coconut oil, 2 teaspoonsful every day, is supposed to delay all the neurodegenerative diseases. Curcumin is nothing but a protein that's found in turmeric. Turmeric is such a powerful anti-Alzheimer's, anti-Parkinsonism drug. This is why those days itself, we've all been taking ginger and turmeric and pepper. The beauty of South India. The pepper that we add to the turmeric and the ginger dissolves the metabolic enzymes that would otherwise metabolize ginger and turmeric. So the availability of curcumin is more when you take it along with pepper, black pepper, as we do in the South Indian meal. 2 more quick points. The vascularity of the brain is very important. That's why you must take either aspirin or clopidogrel to keep the blood vessels running. And if necessary, you can go on a vegan diet to open up the blood vessels. Higher vascularity for the brain, less the degeneration. Finally, a nice little point. I don't know how many of you brush twice a day. Do brush twice a day. Whenever you can, you floss. Flossing alone has been shown to decrease neurodegeneration. Why? There is a bug called P. gingivalis between the gums, between the teeth and the gums. When you floss, you get rid of it. And the incidence of neurodegeneration is less statistically in those who floss and get rid of P. gingivalis. Not only does it cause neurodegeneration, it also increases coronary artery disease. So flossing seems to be the new brushing for all of us. Another bad horseman, cancer. We've actually not been able to bring down the mortality of cancer despite doing billions and billions of dollars of research. It is still killing at a very steady pace. I personally start my anti-aging treatment by telling people to first rule out all the cancers that can get them. Prostate, breast, colon, lung. And we start by endoscopy, colonoscopy, whenever required, MRI for the prostate, fibroscan for the liver, more to study fatty liver going in for cirrhosis. These days, we have liquid biopsies where we can simply take 10 cc of blood and find out whether circulating cancer cells are present in that. Very importantly, we have terrific blood tests that we do almost every day. CA125 for ovarian cancer, CEA, colonic cancer, AFP, liver cancer, PSA, prostate cancer, CA19/9, pancreatic cancer. I believe that we should all make use of these changes to pick up these diseases very, very early so that we can treat them. We all know that when you pick up a cancer in stage 1, practically the patient is going to live a long and healthy life. You pick up the same cancer a year later or 2 years later, we have a very short lifespan. So picking up cancers early, we indeed do a genetic screening, and I can know who's going to get a colorectal cancer in the next 5 years, gastric cancer in the next 5 years. And then we scope them accordingly, pick up early disease and give them a long life. Again, another powerful, we talked about heart disease, we talked about cancer, we talked about neurodegeneration, the fourth horseman, metabolic breakdown, and led by diabetes, accompanied by obesity, dyslipidemia and hypertension. This NCD load is humongous. My advice to all of you is please do not rely upon HbA1c. In anti-aging, we don't go by HbA1c. We go by a far more accurate measurement, namely CGM, or continuous glucose monitoring. Some people do it for 7 days, some 10, some like to do it, like my close relatives like to do it till it runs out for 14 days. But that's okay. You need to know when the sugar goes up and down and treat it accordingly. CGM. Similarly, if somebody says, which is one single best test for my dyslipidemia, it's not your cholesterol triglyceride. Check your ApoB. It's your ApoB that determines which bit of your lipids is going across into the subendothelial plaque. And luckily for us, statins like rosuvastatin and newer drugs like IOX3, they lower the ApoB significantly. So ApoB and CGM are two things that every one of you physicians should keep in mind. I personally believe that for younger people who are obese, who've got diabetes plus obesity, it's wonderful to give them injections like GLP-1 and GIP-1 blockers like Mounjaro, Ozempic, etc. And those who are resistant or refractory, even to that, there is still a role for metabolic surgery, which one shot will knock off 25-30 kilograms, knock off the sugar, knock off the BP, knock off the cholesterol, knock off the reflux, knock off all the comorbidity. But that's another story that we should discuss. Only thing is, please be aware of metabolic degeneration, which is killing thousands of us every day. Remember, 1, that every 20 seconds, a leg gets amputated for diabetes. Every 30 seconds, somebody goes blind because of diabetes. Every 45 seconds, somebody goes on permanent dialysis because of diabetes. Every 60 seconds, a life is lost because of diabetes all across the world. And even the best Ozempic or Mounjaro is temporary. And when you stop it, patients will just bump up and become huge again. So please do consider the metabolic surgeries, which are actually longevity giving, and they are supposed to extend life by about 15 years. A quick little talk, we all know about Easter Island in the Pacific Ocean, where these huge stones are being found, prehistoric and huge faces. This island is otherwise known as Rapa Nui. There is a volcano there, and the mud from that volcano seemed to give people miraculously antibacterial, antifungal, antiviral and anti-cholesterol impact. From this, due to the pioneering work of an Indian scientist called Suren Sehgal from America, he died early. But from this grew the wonderful drug called rapamycin. Many of us in this crowd, including myself, have stents that are coated with this rapamycin, which is supposed to inhibit further subendothelial plaques. Perhaps the future is to be able to take rapamycin orally to prevent the subendothelial plaques, but at this point of time, that is still experimental. There's something called biohacking, which means you get into your body's program, the motherboard, and change it to make you live longer. These are called biohacks, and my next book coming out is called 100 Biohacks for Everybody. Today, I'm going to just give you a few of those. We know, for example, that the parasympathetic, the bigger the parasympathetic and less the sympathetic, longer the life. Parasympathetic is carried by the vagus nerve. The more you stimulate the vagus nerve, the longer you will live. Let me give you some simple yoga tips. One is double inhalation. See, when you do one breath taking in and then another one, so it's a typical biohack. The second inhalation crunches the neck muscles against the vagus and increases vagus tone, increases your parasympathetic tone, and increases your chances of living long. Anything that you do, similarly, chin tuck, bring the chin down and move the chin back like this. That causes vagus. I'm just giving you some, there are 100 in the book. And there's the importance of your breath. Watch your breath. Make sure you can take in 3 or 4, let out a 6. The exhalation should always be longer than the inhalation, and this will stimulate the vagus. There is a wonderful thing called Viparita Karani, where you lie down against the wall with your legs up and breathe 4 in and 6 out. And recently, Stanford and Oxford, both of them worked and showed that doing that and breathing 4 in and 6 out presses against the thoracic duct and empties the wastes, decreases the edema, increases cardiac function. These are just some things, but come to me and I'll talk to you, help you with more of these biohacks, or wait and get my signed copy of 100 biohacks. These are simple tricks to make you live long and to use your physiology to get you a much better state of living. Adi Shankara, in his famous Bhaja Govindam, says, Punarapi Jananam, Punarapi Maranam, Punarapi Janani Jatare Sayanam. We are all either dying, or we're being born, or we are waiting in that interval to enter somebody's womb. That's what a lifetime of science and philosophy has taught me. However, it is our duty as physicians to make this short stay on earth as pleasant and fulfilling as possible and as meaningful as possible. And my 15 years of experience in anti-aging has taught me this, that most of our physiological processes can be manipulated by the correct mixture of lifestyle, habits, drugs, and attitude. I hope I've brought some sense into your already erudite and scholarly minds. Once more, thank you for giving me this opportunity of presenting some interesting facts to all of you. Good luck, everyone. Jai Hind.
That was a detailed presentation. Thank you. Now we are moving on to the second session for the day. So we call upon Professor Dr. P. Parandaman, the physician and academic head, Sugam Hospitals, and chairperson of this session, and Dr. G. Jaikumar, consultant physician and diabetologist, and chairperson of this session, to introduce the next distinguished speakers. Over to you, sirs. Thank you.
So our next topic today is approach to palpitation by Professor Dr. A.M. Karthikesan, consultant cardiologist. He is a consultant cardiologist and electrophysiologist at Apollo Heart Institute, Grimms Road, Chennai. He is a member and fellow of Heart Rhythm Society, member of Indian Heart Rhythm Society, member of Asia Pacific Heart Rhythm Society. He is focused on complex cardiac arrhythmia ablation with RF and CRYO. Over to you, sir.
So good afternoon, one and all. At the outset, I would like to thank the organizers for inviting me to deliver this talk. And it's an important practical topic. So palpitation. So it is one of the commonest problem every practitioner come across in their day-to-day practice. Whether you are a general practitioner, a physician, or a cardiologist, or be an electrophysiologist, every practitioner, irrespective of the specialty, even on any other specialties also, the patient come to you with some sort of feeling of their palpitation, that is, one's aware of their own heartbeat. Normally, we don't feel our heartbeat, so it does its work and we do our work. But once it seeks your attention, started feeling that, either in the form of fluttering sensation or third feeling or missing or a fast heartbeat or whatever ways, raising heartbeat, people describe in a different manner. But the bottom line is they feel their heartbeat, which they don't routinely feel it. So that's why they come to us, something is happening, so I am feeling palpitation. So what is it? So how do you evaluate those patients? In a cardiology practice, the most important things next to chest pain, palpitation is the commonest symptom which we come across. In a general practitioner, around 16% of the patient come to you with some sort of palpitation symptoms. If you are a medicine, maybe around 20-25%. If you are a cardiologist, maybe 30%. We as electrophysiologists, almost 70 to 80% of the patient come to us with this palpitation problem. So whether all palpitations are serious or everything can be neglected, if you see that 40% of the cases are related to cardiac, remaining 60% is non-cardiac, especially in a general practitioner, general physician. Mostly some psychiatric or any drug-induced or some sort of unknown reason, they feel their heartbeat. Okay. So the purpose of this talk is, how do you counsel your patient, how do you evaluate, and which are the patients undergo stricter investigations to rule out a serious problem, which are the patient needs reassurance and send back home. That is the purpose of the talk. One should not miss the serious problem and the patient come to you and getting into problem. So history is the most important thing. Without just brushing aside, it's a palpitation. So just go through some of the things, listen to them, what exactly they feel. Are they feeling the skipping beats or thumping sensation, which could be the misbeats, which is the commonest problem, especially ventricular misbeats, PVCs or something we call. They feel suddenly heart is skipping and beating. They feel that, So they may have only 1 or 2 skipping beat per day, but that causes serious symptoms, so they come to very serious symptoms, they come to you. Sometimes sudden onset, sudden offset, which is a classical of SVT. Suddenly they feel fluttering sensation, it stops suddenly. So the history is very classical. They are very clear. Any other time I don't feel anything, doctors. All of a sudden my heart is rising, then it stops within a few seconds or few minutes, it stops, comes back to normal. That few minutes I am not able to do any work. I have to go and sit and take rest. I have to lie down. I have to drink water. I have to go to the washroom. Something is not making me comfortable in that particular 5 minutes or 10 minutes. That is a classical history. So the patient is definitely giving an important clue to that they are suffering some rhythm problem. Some patients tells you palpitation when they are getting up from the sitting position. After sitting off 10-15 minutes, when they get up, they feel some palpitation. That could be a postural blood pressure related, or can be a what you call POTS, orthostatic tachycardia syndrome. Especially we saw a lot of patients after dysautonomias and post-COVID. So many patients we come across this sort of problems. So this very advantage. Some patients come to the videograph also. The neck vein is palpitating, so a neck engorgement, carotid pulsation they record, so they see that when the heart rate goes up, my neck pulsation I could able to see. Or even the pediatric patients, the mother records a video or the bystander records a video and show it to you. This is what happens. So they are giving the diagnosis to you. So when they are suffering this sort of thing, some SVT is going on. Sometimes, the onset gives history, very important. Is a sudden in onset, is a gradual in onset. As I mentioned, sudden onset, sudden offset, it's definitely there is arrhythmias. In that particular few minutes or few hours, patient is very discomfortable and not able to do any work. That's a warning sign. Sometimes gradual onset, gradual offset, which could be of sinus tachycardia also, or sometimes atrial fibrillation. Those are the arrhythmias, so we may not, gradual onset. Some of the tachycardias like atrial tachycardias, waxing and waning, it's a warm-up. Gradually gets accelerated, then gradually decelerates. So this giving few questions to the patient and the important about the palpitation. Apart from the regular history, hypertensive, diabetic, or they suffering any heart attack, or they are suffering any other problem, any other medical history, all those things are very important. Apart from that, elaborating on this, what they exactly feel during palpitation, it's very important for us to analyze further. The bottom line what we discussed is risk stratification. So we should not brush aside every patient palpitation is psychiatric or negligible or due to stress they are getting from failing palpitation. So what we need to understand is, are they feeling associated palpitation, any giddiness or loss of consciousness is there? That becomes very, very important. They are suffering some hemodynamic problem and they are feeling palpitation. We feel that, the patient tells suddenly palpitation, doctor, at that time I feel some giddy, I have to sit down. I am not able to continue my kitchen work. That gives important history. That is not only causing palpitation, rhythm problem, it causes some hypotension also, BP drop also. That's why they are not able to stand, they have to lie down. And sometimes, near loss of consciousness, that gives maybe AV block or something, or rapid arrhythmias, ventricular arrhythmias is possible. There is associated with chest discomfort. That's the other important thing. Associated with chest discomfort, dyspnea or chest discomfort could be a symptom of ischemia. And the most important thing is family history of sudden cardiac arrest. When they said this set of symptoms, one of my elder brother suddenly died at the age of 45, 50 years. That could be a very serious problem. Are you dealing any genetic problem which can give rise to rapid sudden cardiac arrest or something? This man is getting pre-monitoring symptoms of palpitation, something which could be of short runs of ventricular arrhythmias. We don't know. So we have to evaluate, we cannot relate it. So the eliciting these histories are very, very important before sending them home. What they want is simple investigative tool. ECG is a very, very important, simple, safe and non-expensive investigations. Unfortunately, we see that some of the great diagnosis missed by not taking ECGs. Patient come to you with the large files of MRI and CTs and so many scans, but they have to literally find out where is the ECG. They don't even remember. I don't think nobody asked me to take ECG, doctor. So that is simple investigation gives a lot of value to your diagnosis, especially if you have a WBW pattern or a long QT pattern or pathological QAs due to old MI, left ventricular hypertrophies or any Brugada pattern. So we'll show some of the example I'll show you. Lot of diagnosis, you should not expect the patient coming to you with a documented tachycardia to you. The patient is killing palpitation, which is a tachycardia, could be. When the resting ECG shows abnormal, you should take it for granted that some serious problem is happening. You cannot expect the patient to come with the serious documented ECGs to the emergency. When coming to your OPD with some palpitation, resting ECG shows some problem, you should think that these are the possibilities that palpitation could be due to ventricular tachycardia, could be due to a serious supraventricular arrhythmias, or could be the SVT, or it could be a PVCs. So I need to evaluate further. So that's what the important thing. Simple blood test, rule out anemia, hemoglobin, just ask for one hemoglobin. And ask for one thyroid, hyperthyroidism. Patient come to the hyperthyroidism palpitation, there will be sinus tachycardia or paroxysmal fibrillations. And electrolytes, any of these electrolyte, potassium, magnesium problem can cause PVCs and some problems. So ask for simple blood test and then simple ECG. I'll show an example. This I dealt with this case almost 15 years back. This patient was a 10-year-old girl taken by his mother to the pediatrician for the history of palpitation. This girl is telling on and off telling palpitation, doctor. Just pediatrician, just brush her eye, what is this, so no, don't worry, now ask her to eat well, drink well, just reassurance and send the patient back. And then few days later, ambulance was called because kid collapsed at home and she was resuscitated with the DCCON version. And this was the DCCON version at home, it was done and then brought to the emergency and ECG was taken. What do you see this? The WBW syndrome, you can see the short PR slurring in the upstroke, it's a WBW pattern. That's the importance of getting an ECG done, even the patient come to your clinic without anything, also just symptoms of palpitation. If that pediatrician taken ECG and documented this, unless proven otherwise, you are taking for granted that some extra connection is there, 1 in 1,000 people, disaster, some re-entry tachycardia is going to happen. In this re-entry tachycardia going to SVT, SVT can degenerate to atrial fibrillation, ventricular fibrillation, then lead to sudden cardiac arrest. If you had taken simple ECG, this diagnosis could have been picked, and luckily that that was abroad patient. There the ambulances at immediately the minutes the ambulance can reach, so they could save the patient. So so it's very important to take one ECG and underlying to find out the problem before brushing aside. This all nothing happens because just that 10-year-old girl, what the big disease she is going to have. So that should not be the order. Irrespective of the age, at any age, even the neonates, mother tells, suddenly the SVTs, what the neonates and infants are diagnosed by the mother. Mother comes and tells, while feeding the breastfeeding time, I am feeling heart rate is going up. So we pick up like that. We never neglect the history and just document anything in its problem by simple ECG. Some of the times, that's what I repeatedly tell, you cannot expect the patient to come to you with the documented tachyarrhythmia ECGs. But if you are suspecting that, ask them to do a daily problem. It's a 24 hours monitor is available everywhere. You can ask them. If it is once in 2 days, once in 3 days, the problem, as per a 7 days monitor, 14 days monitors are available. These are all nowadays simple patches are available. They can continue to do their work. They can go to the job, do the work, but continuously 24/7 ECG is documented. Then 1 in 3 days, 4 days, then they get the problem. You analyze it and see what sort of problem they are having it. Still is infrequent problem. Nowadays, smartphones, smart things are used, smartwatches are used. You can ask them to document the pulse rate or ECGs, all those facilities available with all the smartphones and smart watches. Any infrequent symptoms, once in 6 months, unexplained palpitation, syncope, or those cases, loop recorders are available. We under the precordial region, we will put a small incision and put a small, like a pen drive, not even pen drive, nowadays like a capsule it has come, which records ECG for 3 years. So infrequent symptoms, but we strongly feel that it could be a cardiac problem, we insert those things. And ask for echocardiogram. So echocardiogram is nowadays becomes a routine part of evaluation. So it can, some of the structural problem like mitral regurgitation, aortic problems, or some of the ASDs, they would have married and pregnancy, everything would have completed. But if you do, and they come to palpitation at 30 years, 35 years, if you do an ECG, you will find out ASDM, secondum ASD. So they would have been symptomatic for many years. Now they come with simple palpitation. So your structural problem easily can be ruled out. Any silent problems, some cardiomyopathy. So those things can be ruled out by important taking on echo. This is a girl, repeated palpitation, connected the Holter, everyday palpitation. See the classical of SVT. And this man, post CABG, came to my OPD, just gone on and off palpitation associated with giddiness lasting for a few minutes. And we connected the Holter. You see that there is a ventricular tachycardia going on. Okay, so in spite of all the medications, and we are doing ablation. And this lady, on and off palpitation, ECG shows singles, couplets, triplets, like non-sustained VTs are going on. When we connected the Holter, we can see the number of PVCs. Out of 1,20,000 heartbeat, 58,000 heartbeats were abnormal. Almost nearly 50% of the heartbeats are like you can see by Gemini. One normal, one abnormal, one abnormal, like this. It goes on. That they feel palpitation, they feel dizziness, they feel exertional breathlessness, because 50% of the cardiac output is problem in the contraction is not happening. So this is the problem. Sometimes it's a young man, young boy, 16-year-old boy. Now he's these are very old. He's finished now. He's MBBS also. He's doing MD. And this boy come with continuous palpitation by couplets going on with almost more than 12% of the PVCs are going on. And so we can't ask these boys, they're taking long-term medications, so the long-term medicines, they will not tolerate it, and we don't want to give lifelong medication. He was taken for ablation, it was coming from the left coronary cusp. The near the pulmonary valve, near the aortic valves are the common sites to produce this set of PVCs. The PVCs are not controlled with the simple medication like beta blockers. We will tell them in the huge burden like this, 15%, 20%, 30% are there. We tell them to go for ablation and find out the spot and neutralize it, everything eliminated. Now almost more than 12 years over now, so he is without any symptoms, no medications. All the PVCs are not benign, and this lady continuous PVCs. You can see few beats normal, few beats are abnormal, not very wide PVCs, because it is coming to the near to the conduction system. It is narrow QRS, but it is a PVCs. Because it is going on like this, EF has reduced to 45%. This is called PVC induced cardiomyopathies. All PVCs you cannot neglect, it is a benign. Somebody is having huge burden of PVCs, the LV function start deteriorating. They will develop heart failure, LV dysfunction is a reversible cardiomyopathy. If you control the PVCs by medication or ablation, the LV will come back to normal. That's what happened to this lady, and she was ablated after it was coming from the near the LVOT region. As I mentioned, below the aortic or below the pulmonary valves are the common sites for these idiopathic ventricular PVCs and non-sustained VTs. It was ablated. As I mentioned, you see these PVCs. This patient came with a palpitation, and young lady, palpitation with the syncope. And when we connected the Holter, the number of PVCs are not very huge, like compared to 50,000, 40,000. Its here is not very huge, only 2,000. But what is alarming here is you see that PVC and these PVCs. Those who want, I can go back. These PVCs, you can see these PVCs coming well away from the previous QRS complex. The QRS complex is finished here. The PVC is coming from here. Contrary, you see this PVC is sitting on the T wave of that previous QRS complex. This is called, classically we have been taught in MD days, MBBS days, R-on-T phenomena. The PVC falls on that previous QRS complex, it will create VF. That's what happens in these patients, that could have been the cause for the, you see, the PVC falls on that, it degenerates to polymorph VT and VF. They will recover. This is self-terminating VF, they will recover, fall, they will get up and walk. But if you miss it, next episode may not be the safe episode. That's where the very important. We cannot just 2000 PVCs, you can't brush aside. So this PVC, where it is coming from, how it is located, what is the relation to the previous QRS complex, is this life-threatening or non-life-threatening? You cannot make it a general statement that all PVCs are benign and is non-life-threatening. So that's very important. And this is again another example, you can see that is creating VF, this is a recurrent syncope. This patient, when we connected, this is what we found, we implanted the ICD. Whenever the VF comes, ICD will deliver the shock. Of course, we give medication to prevent it. If the medicine is not working, we will ablate also, we will do it. But nothing is guaranteed, your life is secured with the ICD. Sometimes we need a special investigations, like a treadmill test. Only on exertional palpitation, we do, so we ask for a treadmill test. And sometimes tilt table test. So like as I mentioned, positional palpitation. When I get up only I am getting palpitation. We'll do the tilt table test to make them upright and see there is any like a partial orthostatic tachycardia syndrome is there, or neurocardiogenesis pre-syncope or syncope is there, that is causing palpitation. Some of the cases we do previous PVCs and all, huge burden, we'll do MRI to find out any sort of genetic cardiomyopathies or any post-myocarditis sequelae, anything is there, we do MRI. And highly suspected patient, we don't mind taking the patient for EP study. We don't harp on you document and come, you document and come. We don't make that statement. The history is classical. We don't want any documentation. I can take the patient directly for EP study, find out the problem, what kind of arrhythmias, I can ablate it in the same sitting. When also somebody is lost for 5 minutes, 10 minutes, there is no point in asking them to go and document the ECG and come. Before they get out of the home, tachycardia will terminate. There is no point in doing that. This is a young girl, finished engineering college, and just she was complaining when he's climbing staircase, she gets palpitation. Many times we brush it aside, while climbing staircase, everybody get palpitation. But she was so young patient complaining this, when you put her on treadmill, that's what has happened, ventricular tachycardia. RUOT ventricular, right ventricular flow tract below the pulmonary valve, she was developing pulmonary ventricular tachycardia at this young age. These are the patient, we can't give a stiff dose of beta blocker for long term, these are all ablatable. We just took her for ablation and eliminated it. As more than 10 years over, she is doing well without any medicine now. Again, yet another palpitation. When we took the ECG, we were lucky enough to get the pre-excitation intermittently. One QRS is normal, one QRS is becoming pre-excitation. Then as I mentioned, if there is a pre-excitation is there, is unless proved, otherwise this patient is suffering from SVT. So when we took her to the cath lab and we induced it, there was a SVT, we also ablated. So there is no point in asking this patient, when you are getting the palpitation, you go to the emergency, record one ECG and then coming to me. The history is classical, ECG is showing evidence, just go for ablation. Another patient, palpitation, you see the ECGs. In a 32-year male, you don't expect the T-wave inversion to V1 to V6, which is abnormal. Okay, that needs warrant investigations. Only pediatric neonates, infants, you see that T-wave inversion. Adult patient, carefully see the epsilon waves also. And we do the cardiac MRI when you find all those sort of pouchings and other things called ARVD, arrhythmogenic right ventricular dysplasia, and these are known to cause ventricular tachycardia, so needs ablation or ICDs or medical treatment. Last not the least, the most burning problem what we are facing in the world today is the atrial fibrillation. Due to rising incidence of what you call hypertension, diabetes, more of patients getting paroxysmal atrial fibrillation coming to our OPD and coming to a stroke and heart failure. Even young patients are getting into atrial fibrillation, what you call non-valvular atrial fibrillation. Those days we see rheumatic heart disease related atrial fibrillation. Nowadays we see more and more hypertension, diabetes related, obesity related atrial fibrillation more commonly. In those patients, medicine is a thing, but the medicine success rate is only 40%. And those days we used to do ablation with the radiofrequency ablation, which has a success rate of 80%. And nowadays, last 3 years, we switched out to cryoballoon ablation, and see the patients runs of sinus rhythm, then again runs of atrial fibrillation. Because it's just only 38 years, not thinking of giving any powerful medication, anticoagulation, antiarrhythmic medication for many, many years. We just take them for ablation, ablate the pulmonary vein ostial region, and just keep them on only beta blocker or sometimes not even any medication. And what we recently launched last month is the first in Tamil Nadu is a pulsed field ablation for atrial fibrillation. Atrial fibrillation is the most commonest arrhythmias, but people think that amiodarone is the only drug of choice, only give amiodarone. It has a potential toxic side effects. It has only 40% success. Whereas in ablation like cryoballoon ablation or pulse field ablation has success rate of 80 to 85% without any medications. If you add some non-toxic beta blocker, the efficiency crosses more than 90%. So you can prevent stroke, you can prevent heart failure. So before subjecting the patient to the very powerful medication, for toxic medication, they should be referred for ablation to consider, so that the disease will not progressive. Atrial fibrillation is a progressive disease. As age advances, the frequency, duration keep increasing. So that in the initial stage itself, that's what the data shows. If you ablate it, they'll do extremely well in long run. Not the least, bradyarrhythmia sometimes causes palpitation because these 2:1 blocks suddenly become 1:1 conduction. People become 100 heart rate palpitation. Suddenly it drops to 50 heart rate, they feel normal. So again, this AV block also, they may come to you the palpitation. Sometimes tachybrady syndrome. This AF terminates, long pause. Then always they are junctional rhythm or sinus bradycardia. These things also come into tachybrady syndrome where the pacemaker is the treatment of choice. So the last treatment is from ranging from reassurance to catheter ablation. So simple, any PVCs, start on beta blockers. If it is not possible, not responding, not intolerant to medication, ablation is a treatment of choice. And SVTs and atrial tachycardias, atrial fibrillations are easily picked up by emergencies or any Holters or monitors. Again, we'll do medication or catheter ablation, depends on the patient, the comorbidity, aging process. And SVTs are totally curable. SVT patients, we no longer keep them on lifelong medication. It is potentially curable disease like WPW syndrome, AVNRTs and all, more than 99% success rate. It is potentially curable problem. We don't keep them on medications. And AF and other things, we'll tell them to try simple medication, not responding, go for a latest ablation technologies. Ventricular tachycardia is life-threatening. If you pick it up, I was thinking whether to go for ablation or ICD implantation, depends on the scenarios. And these are the very challenging patients, inappropriate sinus tachycardia POTS. They will be, they don't have any problem. They have some psychological problem, autonomic problems. We put them on ivabradine or combination with the beta blockers, especially propranolol, highly high effective doses, but needs lot of counseling. Sometimes involve the psychiatrist on board also. Reassurance, when you are completely evaluated by all those things, nothing is there, and tell them to lifestyle modification, timely food, the previous speaker enlightened us, timely food, timely sleep, avoid too much excessive alcohol, holiday heart syndrome, smoking, caffeines, all those things. We have to go through the history, what makes them feel the stress, or spend some time, understand what makes them, everything is normal, but what they exactly feel. They themselves come out and tell that when the palpitation is there, my heart rate is only 80. Why the 80 heart rate, why the person is feeling palpitation? So that means something is going on. Maybe so we need to understand that and help him to come out of the problem. So the take-home message is, never underestimate the palpitation or jump to conclude that it is all psychological. We have seen many patients gone to the psychiatrist for just because they could not document the ECG palpitation, we have ablated it. So just because the history is classical, we got to move forward or refer to the specialist for further evaluation. So sending to psychiatrist sometimes disastrous. So always rule out syncope, chest pain, family history of cardiac arrest first. Always do ECG echo and basic blood test to rule out any serious problems. Let the frequency decides what sort of ambulatory monitoring you require, 1 day to 7 days or 1 month or whatever recording you can do it. And everything is normal, reassure the patient whether they are not having any problem. And sometimes symptomatic medications, some beta blocker sometimes helps to overcome the problem, psychiatric counseling if warranted. And electrophysiology study, catheter ablation, ICDs in selected cases. So based on the situation, life-threatening problem, we will put the ICDs, some of the problems will be ablation, some of the time diagnostic study can be performed, electrophysiology studies. All those things in a case-to-case basis, we will do that. So we'll try, almost as possible, we'll try to avoid any long-term medications, and unless the patient has a multiple comorbid problem. Thank you very much.
Thank you very much, sir, for a brilliant presentation. Very clear insight on palpitation. As though it is a very common, very confusing, very difficult situation for a physician to manage. Started with the history. Skipping beat or thumping beat is a benign. So it is not usually. And sudden turn off, a sudden off, sudden on, sudden off of palpitation suggests to SCT. So you can clinically suspect, and palpitation standing from sitting posture, probably postural hypertension causing palpitation, and frog sign, that is neck thumping sign, that is SVT, that is AVNRT. So very clinically you can make a diagnosis even with the history itself. And the simple test you can do is that ECG. That ECG will tell you the benign or malignant. And if you want to have a doubt, if you have a doubt, you can do 24 hours Holter monitoring. If it exceeds more than 7 days, you can go for continuous patch monitoring. And if it's less than 1 month, you can smartphone based ECG and of course more than 1 month you can go for implantable the divisor. So all these things are very nicely enlightened, but it's a very eye-opener for all of us. And the special situations you can do TMT, heart altering, cardiac MRI and echocardiography also useful for identifying the structural image which is causing palpitation. And even benign, all benign palpitations are not benign, it's sometimes malignant, it may cause ventricular dysfunction, and everything is very nicely alluded. Wonderful information. Thank you very much, sir, for your great presentation.
Thank you very much.
Next, we will move on to the next topic for the session. The most important is the panel discussion on hypertension. For that, may I request the moderator, Dr. V. Madhavan, who is a senior consultant diabetologist, interventional cardiologist, Kaveri Hospital, Vadapadani. He is the director, Diabetes and Heart Specialty Clinic, Virukambakam, Chennai. He is the director of SPM Hospital, Ashok Nagar, Chennai. A star awardee of Diabetes India and also Diabetes India in 2015. The Best Doctor Award, Stanley Medical College of Government, Tamil Nadu, in the year 2022 and 2023. He is going to moderate this wonderful session. May I invite the moderator to the stage. Over to you, sir.
Good afternoon, each everyone. I have to thank the organizing as the scientific committee of the DCON 2026 for this invite, and I thank the chair. No chair. So I thank for the wonderful introductions. So let me go on to the topic. So we are going to focus the importance chapter, what is called the silent killer. So hypertension. I say it is not a silent killer, it's a silent architect of that invite your heart to go for heart failure. There's an architecture that designs your hearts to go for a failure mode, go for invite heart attack and stroke on. Instead of calling a hypertension silent killer, it's a good thing term is silent architect of inviting all the diseases and things. And if you understand the hypertension scenario in India, it's very, very alarming. Nearly around 220 billion people are affected, million people are affected with hypertension. Out of 420 is having hypertension. And 50% of patients does not know they have hypertension. Even the people on treatment for hypertension does not reach the target of what we have specified for the individuals. That is a worrisome factor. It is easily treatable. It is not the problem with the medicine. It is a problem with the diagnosis, it is the problem with the follow-up, and the problem with the adherence to the therapy. So much of pitfalls is there. Especially when you underlie people with hypertension, whether young or old, they say when the BP comes to normal, they want to stop the medications as like they do for a fever or they do for headache. So you have to impart a knowledge that is a long-lasting disease. You have to take the medications, even the BP is reached under controls. To unlight the focus on various spectrums, how you are going to manage the BP in heart patients, both on heart failure as well as hypertension, and how you are going to handle the BP on kidney aspects, how you are going to handle the hypertension in elderly patients, and only in female, especially women of childbearing age or gestation people, how you are going to handle. We have a stalwart experts. So first I invite Dr. Manikandan, who is a cardiologist, senior assistant professor working in Madras Medical College. He has a professional expertise of done more than 5,000 angiograms and angioplasties and did more than 300 pacemakers and performed more cath labs and structural interventions in government sectors. An experienced interventional cardiologist and academician with an extensive expert in diagnostic interventional cardiology and device implantation and structural heart interventions. I invite Manikandan to come and occupy the chair. I invite Dr. Priya Mali, who is an associate consultant of geriatrics and a senior consultant diabetologist, is having a clinic at Kalatur, and he is ENT and Premaskan ENT and Diabetes Center, and he is a principal investigator of various clinical trials, had good reputed several publications in national and international, is one of the teaching faculty in Tamil Nadu Medical Universities and one of the organizing committee of the DCCON Southern Chapter and RSSDS. He is a gold medalist in MD, Best Doctor Award from the government sector from KMC as well as MMC. He is a geriatrician, is going to enlighten and hypertension management in elderly patients. Next I invite one of our good friend, Dr. Sumita Sriram, is a senior obstetrician gynecologist and laparoscopic surgeon, Director SPM Hospital and Arjun Nursing Home, Chennai. He has a vast experience of 20 years in the field of obstetrics and gynecology and fellowship in minimal access surgery. He is a member of FOGI, OGSSI and so much of academic feats. And academic activities and more of faculty in many of the stalwart OBG conference across our India. And field of interest is high risk obstetrics and minimal invasive surgeries. Next in line, I invite Dr. Navneet Mohan, who is a consultant nephrologist and renal transplant physician, an alumnus of AIIMS, New Delhi, is a gold medalist and Best Doctor Award from Department of Medicine, AIIMS, and cleared European specialty examinations in nephrology, and holds various posts as a membership of various professional organizations. His special interest is renal transplant and peritoneal dialysis and hemodialysis, and current affiliation is attached to Asian Institute of Nephrology, Urology in Chennai. So let us move to the topics. So any questions from any audience, we invite, because we can utilize the expert panel who can give their insights, whatever clinical dilemma you face in your day-to-day practice. So the questions are framed in such a way that each and every physicians get benefited. So it's not going to in-depth about the medications, in-depth about the disease. We wanted to throw the importance of hypertension management at your clinic or a primary care centers. The first question, Dr. Manikandan can answer. In a patient presenting with a STEMI in a primary care level, not at a tertiary care level, it's primary care level. When a physician diagnoses the patient with STEMI, we routinely administer loading dose. We often give statin, 80 mg, clopidogrel, aspirin to reduce the mortality. So should we consider, whenever we check the pulse may be of 120 or 130, or BP may be 170 or 180, should we consider initiation of any cardioprotective therapies like ACE inhibitors, low dose, or your high heart rate may have a problem for the increased mortality, patients may go for a VT. Is it judicious to use a beta blocker at a primary care level, and should be referred to the patient to the nearest center?
So, good morning to everybody. So this question, the primary aim in STEMI is to establish the reperfusion. So that should be our prime motive. So only we are giving the loading dose, that is we are giving dual antiplatelets, aspirin and clopidogrel, in order to inhibit the platelet activation and to stop the platelet aggregation. So that is the prime aim. This question, whether ARBs or beta blockers can be given as loading dose, we should be cautious in giving them, because beta blockers, when the patient, STEMI patient, is suppose he is in cardiogenic shock, or is having a low BP, or is having some bradycardia or some AV blocks, without looking into that ECG, we cannot give the loading dose as beta blocker. After ruling out this contraindication, if patient is having a hypertension and he is stable, then beta blockers can be given, because they have some proven benefits. They reduce the infarction size and prevent arrhythmias, and that is a cause. But we should be cautious in administering it as a loading dose. And ARBs also has an established evidence. It prevents the remodeling of left ventricle. But it should be initiated within the first 24 hours, not at loading dose.
So very good. So we have a statistical data to support loading dose when you diagnose STEMI. But we don't have any scientific rationale to start or give a loading dose of ACE inhibitor or ARB or a beta blockers. But it has to be started as early as possible in ICU settings. Whether the patients land up in a cath lab center or non-cath lab centers, these medications have some time to initiate. Even the BP is 170 or 190, you can wait. These medications can wait. So it does not have a class 1 indication, has like a loading dose what we give once you diagnose the patient with STEMI. Next question is Dr. Priya Malini. For elderly patients, the current hypertension guidelines recommend different blood pressures. If you go by AHA, ADA, and so much of things, whenever we see elderly patients, the target is different. We are confused. So we could not able to follow what therapy for these patients. Some patients may come for 75 years, active, very active. Some patients have 75 years having so much of cognitive impairment, physical disabilities. How you are going to set your target for these individuals, depending upon the age, frailty, other comorbidities. In your practice, how do you individualize the BP goals for a robust versus frail older patients? What factors most influence your decisions? What are the factors you will consider these medicines it suits for these individuals?
Good morning, one and all. I would first like to thank the DCCON for this opportunity. Yes, coming to elderly population, we know the population is growing and we have huge sector of people above 60 years. Now, when it comes to management of hypertension and diabetes, so we have to individualize targets. We know we have n number of guidelines, the American Heart Association and the European Society of hypertension. So every guideline says a different thing. So mainly when it comes to a practical purpose. So you have to analyze an elderly person as a whole. So you have to categorize them. It's not the numbers, we have to treat. It is the patient as a whole. So you have to look into the functional age, where even Rajkumar sir was talking about the vessel age. So always look into the vascular age as well as the physical fitness. So even, the AHA guidelines itself tells us it divides into fit or robust individual above 65 years and very old or independent frail individuals above 80 years. So you categorize, so you have to analyze an elderly person as a whole, do a functional assessment. What we tell is a comprehensive geriatric assessment where you can decide what is the memory of the individual, what is the cognition of the individual, any risk of falls is there, or patient is having multiple morbidities, patients on multiple drugs. So you have to analyze a patient as a whole. First, you analyze them, you fix up targets. So target fixing is very, very individualized in elderly patients, especially when it comes, when think about hypotension. So do no harm. And also calculate the life expectancy of a particular patient, so that when your risk benefit versus the balance between disease as well as benefit of decreasing a cardiovascular risk or preventing a stroke or decreasing a mortality and morbidity becomes very, very important. So you analyze, fix your target, and then you categorize, you choose your drug. So choose drugs, not too much of long-acting drugs or high-dose fixed drug combinations. So you have to go very, very slow in them, and also monitor them. Monitoring is very, very important. So monitoring for hypertension, especially postural hypertension or orthostatic hypertension, is very, very important. So whenever you check BP of an elderly patient, please do both the testing. So I clear the sitting position as well as standing position. Any drug, it's not only alpha blockers, any drug can produce a postural hypertension. So that increase the risk of falls, patient might have dizziness. So you go into a cascade of events. So trying to treat one illness, you go into a cascade of events. And also monitor for other complications. For example, all the electrolyte disturbances, and sometimes if you have volume depletion with diuretics kind, you can even end up in AKI. So all these factors has to be kept in mind. So choose the right drug for the right patient, analyze them, fix up targets, start in very slow doses. This should be the ideal target.
Yes, we'll come to that. What is the target you want to fix for healthy older individual? What is the target you want to fix a frail individual of a similar age? Yeah. Suppose 8 years walking to your clinic is having no that much of light diabetes, something else, kidney parameters are normal. What is the target you want to fix? You want to fix as like sprint trial, you want to keep the BP of less than 120/80, or you want to have some sort of less stringent control? Yes, sir.
So if the patient is going to be fit, whatever be the age, I would prefer to maintain the BP target is around 130/80. So I will start, I can start with even non-pharmacological measures, but only it exceeds 140/90, I will start with pharmacological measures. So if it's going to be very frail individual, I will uptitrate. My target will be a little more. I will try to maintain my systolic between 140/90, 140/150, and the diastolic should not go below 60. That's my opinion.
Good. So any elderly patients very active, we can target the BP of 130 or 80 if there is no contraindications because of the medications or other comorbids. If there is frail patients, you can have some sort of lesion, you can target the BP of 140 and pay attention and drop in diastolic BP. Many of the people may have isolated hypertension. Whenever you push the systolic BP to lower zone, the probability of diastole goes to lower, more common. Next for Madam Sumita Madam, this is an obstetric angle. Who should be screened more intensively for hypertension in a pregnancy? Many of you are seeing many of the ANC patients whom you wanted to intensively screen for hypertension in pregnancy, and what are the current recommendations for the BP surveillance?
Good afternoon, one and all. Thank you for having me here. In pregnancy, sir, it's a universal screening. We do check blood pressure for all pregnant women regarding whether they have risk factor or not, sir, because anytime we can identify hypertension in pregnancy. And for intensification, when women has higher risk factors, like major risk factors, when they already have a hypertension history, or they are on they have diabetes or a kidney disease, autoimmune disease, or in prior pregnancy they had history of preeclampsia, we intensify the surveillance, sir. And also if the woman is first time pregnant or her age is less than 19 years when she becomes pregnant, or more than 35 years, or if this pregnancy is an IVF pregnancy, it's a multiple pregnancy, we intensify and increase the surveillance, sir. And our current recommendation is, if the blood pressure is more than 140 by 90 millimeter mercury, on 2 occasions, 4 hours apart, we categorize them as hypertension in pregnancy.
Okay. So next is for our friend nephrologist. This is the place where we are having so much of stucks whenever we treat, because high BP, nephrology patients will come with high BP, but we could not able to give all the medications at par because kidney will not be acting friendly to reduce the BPs. Here's a patient, the stage 3 CKD, which is commonly seen, all diabetic individuals, all the physicians may see EGFR around 45 to 60, the CKD stage 3. When already patient will be on taking 3 hypertensives. So other way around, this is called resistant hypertension with a diuretic, yet BP remain uncontrolled. So how should I approach these patients? What are the common reversible causes I have to look in these patients, and investigation that should every physician consider before escalating therapy?
So good afternoon one and all, and at the outset I would like to thank the organizers D Club, Natarajan sir, and obviously our moderator also for all these very good clinical scenarios which are very common. So this is a very common scenario, right? So you have a patient with uncontrolled hypertension. So the commonest cause, whether it's a renal patient or not, would be actually volume overload. Sodium retention is actually the most common cause, followed by RAS activation, sympathetic activation, in that order. So the first thing, the most important thing is to take the history. So the commonest cause for uncontrolled hypertension is actually patient non-adherence. So you might be writing many drugs, but many times the patient will not be taking as per your prescription. You might have written BD or TDS, patient will be taking only once. See, I've had even patients who say, sir, I never had headache, so I never took antihypertensives. So patients have this thinking that they need to take antihypertensives only if they have symptoms like headache. So you need to ask whether they are actually taking the medications as per your prescription. Second would be the diet. So whether they are compliant with the salt restricted diet advice which was given. So what misconception many patients which they seem to have in IC is, they think that they need to decrease the salt in the food that is in the rice. But they'll be taking pickle, they'll be taking dried fish, and they'll be taking savories from outside. So you need to ask them to cut all these added salt which they have in their diet. Then do a small examination. Many of these patients might be having volume overload. They might be having pitting pedal edema. They might be having engorged veins or even crackles. So many of these patients would need a good dose of diuretics. I think I have a question on diuretics. At that time, I will elaborate more. Many times, if you have a patient who was doing well till then, his BP was well controlled, was all doing well, suddenly he comes to your clinic and his BP is gone up. Look at his drug chart. Many times I've seen that they would have taken an NSAID, that is some painkiller recently. They would have been started on steroids recently. They'll be taking some decongestants. They'll be taking some pseudoephedrine or phenylephrine or some cough syrup, or started some alternative medications. So that would be the reason for the acute rise in BP which you would be seeing. So more than 80% of the time, this would be actually the cause. So if you have ruled out all these things and even then the patient's BP is truly high, then you have to look for the other causes like renovascular hypertension or some endocrine causes and all those things. And one other important cause which we tend to overlook is actually obstructive sleep apnea. So if the patient is very obese and is having a resistant hypertension, you're giving 3 drugs and even then his BP is not coming down, do a polysomnogram and see if he's having obstructive sleep apnea. You treat it, most of the times his BP will come down.
Good. So from this first, we have a data to support loading dose in MI, but we don't have any data to support. We have mortality benefit by introducing a ACE inhibitor or beta blocker, but that should not be done as OP settings. So we can give loading dose as OP setting, but you should not, whatever the BP with MI, come to your clinic or a ER, don't give that medications. Please admit the patient and then you can initiate the antihypertensives. That is a lesson learned from our cardiologist. In geriatric perspective, we assess the patient as a whole, respect his vascular age, and depending upon the other comorbidities, other conditions, you have to set the goal. So not for all this, one size does not fit for all. And for obstetrics, the surveillance is very, very important. You have to accept the red flag signs. Who are the patients are prone to develop hypertension? How you are going to monitor these patients? Whenever the BP is more than 140 or 90 in 2 consecutive events, you can. These are the ideal candidates for initiation of the antihypertensives. Regarding CKD patients, which we commonly see, you see as a reversible causes. Pay attention on the complaints of the medications. Pay attention on the diet. The complaints of the diet. Next, assess other reversible causes like obesity, OISA, and so on. Next, only you can go for other sophisticated investigations. Don't jump directly to investigations. Pay attention on the history, whether the complaints of the medications and the food is very good. Whenever you jump for a next investigations to address hypertension. Next is what is your opinion on beta blockers? Because beta blockers, many of the things as a physicians, we have some sort of disturbance in introducing a beta blocker. We are comfortable with ACE inhibitors, ARB, calcium channel blockers, but when it comes to hypertension, and the Indian subset, we see high tachycardia. The patients comes to our clinic with BP of 150/90, high sympathetic activity, pulse may be ranging in the 90. But whether I can start this patient in beta blocker, because many of the guidelines are not supporting, because the first line of hypertension management, even second line, many of the guidelines don't support. So beta blocker is kept as a reserve for treating hypertension. Many of the Western guidelines, even Indian guidelines shows that. So what's your opinion on reducing the CV risk in a patient with high BP? Do you have any preference for beta blocker or in this hypertension management?
Sir, as rightly said, beta blockers are not the center stage drugs as per the guidelines. So only other three drugs, the diuretics, ARBs and long-acting calcium channel blockers are the drug of choice in hypertension. But there are some specific subsets, patients having established CVD, cardiovascular disease, or patients having reduced EF, heart failure. In that patient, there are some compelling indications to use beta blockers.
We are focusing on, suppose diabetic with high risk CV events. The patients can benefit of HL inhibitors.
Yes.
These patients are ideal candidate for GLP. As like high cardiovascular risk, hypertension with obesity, smoker, high sympathetic activities. Can you initiate beta blockers as a monotherapy or a second line after ACE inhibitor, ARB, as per the guidance? Can we initiate, updated the beta blocker as early as in the course of management of hypertension?
Yes, sir. Some young patients with increased sympathetic activity and some patients with metabolic syndrome, this especially this beta blocker nebivolol has some vasodilatory effect. It has some proven benefits in this metabolic syndrome. But without any other compelling indications, beta blockers are not the first line drugs in hypertension. All the other three drugs should be first tried, and in resistant hypertension it can be tried.
So when there is evidence of high sympathetic activity, there is a role for beta blockers, and all the beta blockers are not same. So you choose a highly cardioselective beta blockers like nebivolol or some other bisoprolol and all that can have minimal side effects on the metabolic parameters, or minimal side effects on other COPDs, other components. So there is a role for beta blockers. I'm not here to say the beta blocker has to be started first. So pay attention of the clinical scenario of the individuals. If there is a need, if there is high evidence of high sympathetic activity, if there is high evidence for the patients can go for heart failure, a stable angina is there, you can give some sort of low dose beta blocker if it's warranted. For geriatric senses, many geriatric patients receive 4 or 5 medications, maybe having a diabetes, maybe having some sort of arthritis, or so much of things, maybe have many parameters, may coexisting illness as age advances, and these patients also have decline in GGFR. Age itself a parameter that can decline EGFR, can have a negative impact on the hepatic clearance. So whenever we want to start the medicines, we have awareness whether this drug will interact with my drug in terms of BP reduction, this drug will produce any problem in the kidney or renal angles. So how you are going to balance the BP control at the same time we want to have an optimal BP control.
See, when it comes to geriatric population, multimorbidity is very, very common. So the multiple comorbids, so patients on multiple drugs. So polypharmacy becomes a very important issue we face with the geriatric population, as well as age-related changes, increase in arterial stiffness, the baroreceptor mechanism goes off, and you can have a decline in EGFR. So all these factors put together, it becomes a very task to treat a geriatric population. So the main important thing is always assess the renal functions. So when you are starting a new drug, you assess the renal EGFR. Don't go by the creatinine values, because in the geriatric population there is a decrease in muscle mass. So the creatinine will not guide you for the drug dosing. So you always go by the EGFR levels. And drugs which have which acts more on second phase of hepatic clearance, because the first phase of hepatic clearance is decreased in elderly. So those who have an effect on the second phase of, so choose drugs like that. And when it comes to polypharmacy, so it's better that first you choose a single drug which you have multiple actions. For example, if an elderly male is having a prostate issue with hypertension, you can go for, though it is not a first line of choice, you can choose an alpha blocker when compared to other drugs. So choose one single drug with multiple effects, and try to review the medications, and always you think about de-escalating drugs, de-prescribing drugs. So always there is a prescription cascade. For one patient would have given amlodipine for BP control, we developed a fatal edema, then he would be started on diuretic by another person. So they visit multiple consultants, and over-counter drugs are also possible. So when, how do you really manage them is that first you review all the medications. That's very, very important. You ask them to bring all the medications given by multiple consultants, you review the medications, and when you start with very, very low doses, go very slow, and try to monitor them. That is more important. And always look into for side effects of treatment, like when the patient is developing fatal edema or hypertension, and try to de-escalate the drug. So choosing the right drug for the elderly is very, very important, so that you avoid complications. Mainly we are talking about the hypertension and falls. So, and a fast decline, a rapid decline in BP is also to be avoided. That is more important, because we know there is a risk of confusion, delirium, because of the cerebral perfusion being impaired, and also a cardiac compromise can also occur. So we can precipitate a MI rather than decreasing a cardiovascular risk. So rapid decline to be avoided, low dose combinations, start very slow and go slow, and monitor for drug therapy.
Very good. So the primary point is start low and go slow, and see the other prescriptions what the patient is taking on. If possible, add a medication that can have a synergistic effect on the primary illness, as told by madams. So, and obey the contraindication, use the indication of the medication and obey the contraindication of the medication, because these patients have decline in EGFR, decline in hepatic clearance, though drug toxicity may be very high. So usual dose cannot be updated or applicable for elderly patients. You have to go slow only. And for obstetric angle, how aggressively should be BP lowered without compromising uteroplacental perfusions?
Sir, if the patient is in a mild preeclampsia, where a blood pressure is around only 140/90, our target is it has to reduce the blood pressure on 135/85. We start them immediately on antihypertensive. But if the woman is in the severe range of hypertension, where a blood pressure is around 160/110, these are the women who require admission, and we monitor them every 50 to 30 minutes, and we try to reduce the blood pressure within 1 to 2 hours. That will reduce the maternal as well as the fetal complications. It has to be a prompt reduction, but it has to be gradual. It should not be precipitous, because it will cause fetal distress in the baby as well as maternal complications.
So depending upon the clinical scenario, you have to be aggressive or maybe non-aggressive. And you have to assess the clinical conditions.
It's a mild or the severe range. Mild is
we
can follow them up.
Okay. For nephrology friend, so we have renovascular hypertension often considered reversible causes. Many of the times we advocate go for renal stenting, as we do with coronary and carotid stentings. There are many guidelines says you can go for renovascular hypertension, can be a reversible cause potentially. You can go for stenting, so renal stentings. But many of the latest Astral, Coral trial has not given that much of weightage. That is, renovascular hypertension treatment by stenting is not that much efficient as like a optimal management. So what are the red flag signs that should be make a general physician to suspect these patients having renovascular hypertension? How should we investigate these patients? And which patients still clearly benefit with renal revascularization?
So again, I like that sentence very much, sir, but it can also be over-investigated. That is very true. So whenever we talk about renal hypertension, so increased blood pressure because of the kidney is primarily because of a chronic kidney disease or a chronic glomerulonephritis rather than a renovascular hypertension. So whenever we say renal hypertension, many times it is CKD rather than a renovascular hypertension. Actually, in practice, less than 10% of the renal hypertension patient would be because of renovascular hypertension. That is because of renal artery stenosis. So that's why I think that sentence is very much important. So for whom do we really think about renal artery stenosis? So patients who come with very severe hypertension for the first time, especially when their age has been above 55 and are having other atherosclerotic diseases, because the commonest cause for renal artery stenosis is again atherosclerotic renal artery stenosis. Or you have a very young female with where you can suspect fibromuscular dysplasia, then you would consider. Or patient who is having recurrent flash pulmonary edema. Or in patients where they are having unequal kidney sizes. So they do an ultrasound, the kidney sizes are unequal. And in patients who have a progressive deterioration of the renal functions, or you have started them on AC inhibitor or ARB, and suddenly their creatinine rises by more than 30%, let's say by around 50% and all those things. So only in these patients you would really consider renal artery stenosis and then investigate them. Now, investigating for renal artery stenosis is again an issue, because the commonly used investigation is a Doppler, which is highly operator dependent. So it might not be really the best test to really diagnose renal artery stenosis. So if you have a very high clinical suspicion and you are really planning a intervention for the patient, you might have to go for CT renal angio or a magnetic resonance angiogram. The only problem is when you go for a CT renal angiogram, you'll have to give contrast. And if the patient is already having renal dysfunction, then again that plays on your mind. But to be very honest with you, if you are clinically, you have a very high suspicion and you feel this patient would need intervention, intravenous contrast should really not be a deciding factor in not giving the investigation to the patient, because that will change the outcome for the patients. Or if you are really very much worried about contrast, you can go for magnetic resonance angiogram. The latest gadolinium is really not a problem, but again, you'll never know what type of gadolinium the lab is using. So you can go for time of flight sequence where no contrast is really necessary. But the gold standard would always be a digital subtraction angiogram. And at that time, you will do the stenting as well. The only issue is, as sir rightly pointed out, most of the trial data right now really does not stenting for every renal artery stenosis. So there are specific indications where renal artery stenosis would be really considered. Number one would be a recurrent flash pulmonary edema. That is, the patient is coming to your ER again and again with flash pulmonary edema and is having an accelerated hypertension. So these patients, if they are having a renal artery stenosis, might benefit. Patients who are having resistant hypertension, that is, you have given them more than 3 classes of drugs and even then their BP remains above 160 or 180 and you are just not able to control the BP for these patients. The third category would be patients for whom they are having progressive decline in their renal functions. That is, their eGFR keeps falling in spite of you being able to control his BP. For these patients, you might consider a stenting. To be very honest, in practice, not even 10 to 20% of the patients would be actually fitting into any of these categories. Most of the patients with the modern medications which we have will have good blood pressure control and will not have any of these issues, then they may not really benefit from stenting. So it's not that you see a renal artery stenosis in Doppler, everyone should be stented. That's not the case.
Good. So renal vascular hypertension is one of the reversible causes commonly seen in people young age. So whenever there is evidence for any atherosclerotic events, any other arteries, you may suspect renal vascular hypertension or evidence for fibromuscular dysplasias or patient recurrent admission for accelerated hypertension, flash pulmonary edema. Please pay attention to assess renal vascular hypertension. One of the more golden modalities is subtraction, digital subtraction angiography. Even ultrasound can have an evidence of some sort of things. And all the patient, as we do in coronary, the stenting is not beneficial. That is the things we want to know it. So presence of renal artery stenosis does not mean the patient is a candidate for stentings. Please pay attention to optimal medical means. We have good molecules in our hand that can reduce the BP, that can increase the survival individual, not only putting a stent across the renal artery as we do in coronary arteries. So third, how do you determine the optimal timing of initiation of beta blocker in a patient with reduced heart failures? So when the patient, now we are going for hypertension and we know what is the role of beta blocker in MI. Now we are paying attention, reduce ejection fraction patients, because many of them comes with pulmonary edema, breathing difficulty, V's will be there. But heart rate is also very high. So when you are going to start beta blocker and how you are going to up titrate the patients?
So this is a very good question. So as we know, there are 4 pillars in the treatment of heart failure with reduced ejection fraction. Beta blockers, the ARNIs, and the SGLT2 inhibitors, and MRAs, mineralocorticoid receptor antagonists. So of this, I think the next question also we are going to discuss this. So first in this question we will discuss about this beta blocker. When the patient is first presenting to you, we have to assess the hemodynamic status. If the patient is hemodynamically stable and his kidney function is also good, then the safest drug to initiate first will be the SGLT2 inhibitors and IV diuretics. First we have to decongest the patient and stabilize the patient. And after 48 hours, we have to see whether he is hemodynamically stable. And as I said in first question, we have to see the ECG. There is no bradycardia, or there are no AV blocks, and the urine output is good, and the patient has become euvolemic. Then we have to start beta blockers, that too in the lowest dosage. The 3 beta blockers that are approved in the heart failure with reduced ejection fraction are the metoprolol, bisoprolol, and carvedilol. So bisoprolol, we should start with the lowest dose of 1.25, metoprolol 12.5 BD, and carvedilol it should be 3.125 milligram BD, and we have to slowly assess by the second week and up titrate the drug if the patient is hemodynamically stable.
So even one of the 4 pillars of heart failure management is beta blockers. Many studies have clearly showed the initiation of beta blocker reduces the mortality in terms of reduction of arrhythmia and increase the longevity, but it should not be started in acute decompensated settings. So the drug has to wait. So once there is evidence of pulmonary edema, you should not start on a beta blocker, and every ECG showing any contraindication like more than first degree of block, you should not start these medications. Make the patient euvolemic, decongest the lungs, the priority will be given for the decongestions. Even heart rate is 120, 130, don't be in attempt to start a beta blocker because that produces worsening act. So when I was doing MBBS, beta blocker, when you say the beta blocker is an indication for heart failure, will be failed. Now the beta blocker is one of the gold standard molecules that can reduce the mortality is a scenario now. So in that beta blocker, we have time tested scientifically proven molecules. The one is bisoprolol, carvedilol or metoprolol at the lowest start to the titration as depend upon the hemodynamics. Next is aging causes structural changes. As you already told, the vascular aging, we have to respect the vascular age of the individual with more rigidity. So these are the patients, geriatric patients who are more prone for isolated systolic hypertension. Patients may come to our clinic with BP of 180, systolic and diastolic of 80. So aggressive titration to reduce the systolic BP may also have a negative impact of reducing the diastolic BP. But many of the times we know that coronary perfusion relies more on diastolic BP. So if you target systolic BP by reducing the diastolic BP, will not produce any problem on the heart of the elderly patients.
Yes, sir, true, sir. So isolated systolic hypertension is one of the common problems we encounter in geriatric population. So when to treat them? So definition is very well known to us that when the systolic exceeds more than 160 and the diastolic will remain low, less than even 80. So when you start aggressively treating them with multiple drugs, you will definitely encounter diastolic drop. So diastolic drop means you are increasing the coronary perfusion risk. So in CAD patients, you keep your target. So here treating, maintaining your diastolic BP becomes the most important target than treating your systolic hypertension. So by reducing the systolic hypertension, we try to bring down the stroke risk and cardiovascular risk. But by decreasing the diastolic BP, you increase the cardiovascular risk. So in a CAD patient, in an elderly patient, you try to maintain your diastolic BP around at least above 70. So otherwise, don't go below, diastolic BP should not go below 60. So the main important thing in you choosing your drug. So we know very well that calcium channel blockers, mainly the non-dihydropyrin calcium channel blockers like amlodipine and nifedipine play a role in bringing down the isolated systolic hypertension, and also thiazide and thiazide-like diuretics. So both of them, they will have a very, very specific effect on the systolic hypertension, and the diastolic fall is going to be very, very low. And one important thing is that the J-curve phenomenon should be maintained. So that is also very, very important in an elderly diabetic. And don't bring the white pulse pressure also to be addressed. So choosing right drug is very important, and most important thing is you don't fastly reduce the blood sugar. So rapid decline in blood sugars should also be avoided in elderly population.
So isolated systolic hypertension also carries high mortality. So we have to pay attention to reduce isolated systolic hypertension because that is a surrogate marker for strokes. So when you want to design a treatment, you use the drugs that acts on the vascular tree. So majority of times calcium channel blockers have a beneficial effect in terms of reduction of isolated systolic hypertension without dampening much diastolic BPs. But at the time, every time the patients go for ambulatory BP monitoring or home monitoring BP, ask them to record both the systolic and diastolics and give attention for both the parameters. So drop the systolic, but not to the great extent of diastolic falling below the less than 70. So drugs designed to reduce isolated systolic hypertension has to be used whenever you see a patient like calcium channel blocker or a diuretic, then going for a BP like ACE inhibitors that can have a drop on the diastolic BP also. After this, why is labetalol is considered the preferred beta blocker compared to other beta blockers? In which clinical situations would you avoid labetalol or consider alternative?
Labetalol is the first antihypertensive choice in pregnancy, sir. It has a dual blockade. It has both alpha-1 adrenergic and non-selective beta blockers. It causes very minimal maternal and fetal risk. In mother, it does not cause reflex tachycardia, whereas in babies, it does not cause brady or hypotension or a growth disturbance. And it's also very versatile. We can give it as an emergency also as an IV form or a chronic oral management. It is only thing it is avoided in bronchial asthmatic women or women with cardiac failure, where we consider a second line agents like calcium channel blockers, nifedipine or alpha methyl dopamine.
So any other beta blockers of choice, and the labetalol is contraindicated. So any other choice, metoprolol or something.
Metoprolol we can start.
Yes. So yeah, labetalol is friendly for both the fetus and mother. So that becomes a choice one drugs. But we have some sort of lacunae in hypertensive asthmatic patient or some sort of heart failure patients. We don't use labetalol. That the time you can switch over the cardiac selective beta blockers like metoprolol, or there is a way attention. So you can for a non-thyroid dependent calcium channel blockers. So time is only we have 20 minutes. We have to go for another 2 rounds. So I want we have crisp answers. So managing BP in a patient with diabetic kidney disease carries a vital importance. We have to target the BP, otherwise diabetic kidney disease may worsen. Patient present with marginal elevations of renal parameters, subtle elevation of creatinine of 1.8 or 1.9, potassium or 5 or 5.5. How you are going to initiate time-tested lipid ACE inhibitors? How much of escalation of serum creatinine can happen when I put this patient on ACE inhibitor or ARB, or even for MRA or non-steroidal MRA for this patient?
So ACE inhibitor or ARB would be the drug of choice for any patient with diabetic kidney disease, especially proteinuria diabetic kidney disease. And whenever we start these patients on these drugs, there is expected rise in creatinine of up to 30%. So this is almost always expected. And if the rise is more than this, you should always see whether the patient is getting dehydrated. So if the patient is on a diuretic as well, then there can be more rise than which is expected. And even then, if you're not able to explain, look for renal artery stenosis, which we had already talked about. As sir had said, the other most important thing, actually the most important thing in practice is actually potassium. So many times when the patient is having renal dysfunction and you start them on ACE inhibitor or ARB, your potassium tends to go up. So always make sure you tell your patient to take a potassium deficit diet. So me being a nephrologist, I saw so many patients this season, all of them had taken mango. So you do tell them don't take fruits which are rich in potassium, but then the patient will not be following your orders. So always take that history, that's very important. But the latest recommendation is, even if your potassium is going up on ACE inhibitor or ARB, you don't usually stop the drug. You are supposed to give something to reduce the potassium if it's possible. So initially we were using calcium polystyrene sulfonate. Nowadays we have a drug called Lokelma, which is sodium zirconium cyclosilicate. Exorbitantly costly, that's the only problem, but otherwise a very good drug. If your patient is able to afford, you can start your patient on that. So the bottom line is, we would like you to continue ACE inhibitor or ARB unless and otherwise you're not able to give the drug at all.
So I can take this way. The patient having creatinine of 1.8, if I start ACE inhibitor ARB or a non-steroidal MRA, if it crosses more than 30%, I have to look for the reversible causes. First, dehydration or any dietary non-compliance. If the patient is compliant, if the patient is hydrated, I could not able to identify renal artery stenosis, can I stop ACE inhibitor?
Yeah, you will end up stopping. But the first thing before stopping that would be to give calcium polystyrene sulfonate or sodium zirconium cyclosilicate and recheck. But if the potassium is not coming down, even then you will end up stopping the drug.
In the Indian scenario, I think Lokelma is too costly. I think 750 and one sachet is called 750.
Yeah, 500 to 750 rupees per sachet.
It is very too costly because ACE inhibitor is very low. The treatment to come back that is very costly. So can you go for one single drug instead of MRA or non-steroidal MRA or ARB?
Yeah. So usually if the patient is on both, we would obviously stop anyone. So usually we wouldn't have started the patient on NSMRA before ACE inhibitor ARB. So the first thing we would have given would always be an ACE inhibitor or an ARB. And if the patient is doing well and the potassium is normal, only then we would have added the NSMRA. So if the patient is on both and the potassium is high, then you can stop any one of the two. So here comes the debate. So the recommendation is actually to stop NSMRA and continue the ACE inhibitor ARB. But many times if you see continuing the NSMRA and stopping ACE inhibitor ARB is actually easier. Because the finerenone, which is the commonly used NSMRA nowadays, the chance of hyperkalemia with that is lower than the chance of hyperkalemia with ACE inhibitor ARB. But again, NSMRA is much costlier when compared to ACE inhibitor or ARB. So if cost is an issue, you would probably stop the NSMRA and continue with the ACE inhibitor or ARB. But cost is not an issue, and you feel monitoring potassium frequently would be a bigger problem, then do the other way around.
So we have only 17 minutes left. So fourth is, what is your real world algorithm for initiating and updating the 4 pillars of heart failure? Which clinical parameter you take into consideration whenever you want to escalate? So BP, heart rate, sodium, renal function, because many of the drugs acts on the kidney may have a negative impact of increasing hyperkalemia as told by previous talk. But be crisp, because we have only 17 minutes.
So I'll try to be very crisp. So in this starting this 4 pillars, now we follow this rapid sequence algorithm. So we try to get on board all the 4 drugs before the patient discharges from the hospital. So as the previous question, if the patient is hemodynamically stable, there is no inhibition, we can start first SGLT2 inhibitor, we can start either DAPA or empagliflozin can be started safely. Only thing we have to monitor the renal function. So next comes if the patient is BP is holding, systole is above 100, we can start with low dose of ARNI, sacubitril valsartan can be started. The things we have to monitor in sacubitril valsartan combination is BP, again BP and renal function. So as our nephrologist told, we have to monitor whether the EGFR up to 30% increase is allowed, and potassium also should be monitored. And after this IV diuretics and patient is off this inotrope, then we can, in the second or third day, we can start with the low dose beta blockers, and we have to titrate this dose. In this beta blocker, we have to monitor the BP and heart rate. And the last drug, we will try to add this MRA. In HFrEF, we are using this spironolactone and eplerenone. Both are approved for usage. Here again, we have to carefully monitor the potassium, because they tend to raise the potassium levels, and also renal function has to be monitored. And from the second week, we can try up titrating the dose. The maximum tolerated dose should be we have to titrate till the patient tolerates what is the maximum dose, and we have to try to discharge the patient with all the 4 drugs on board.
So nutshell is, whenever the patient is going to get discharged, all the 4 drugs should be there in the prescription if there is no contraindication for the drugs. So all the drugs in the minimal dosage is except SGLT inhibitors, where you can start at the maximum dose of dapagliflozin 10 mg or empagliflozin 10 mg. Other drugs you have to wait based upon the heart rate, volume, congestion and all. So preference is given for volume status of individual, preference is given for the hemodynamic, renal function. And depending on the renal function, you can down titrate or escalate the medications of ARNI or MRA. And in MRA, we have eplerenone as well as spironolactone edge in heart rate with the reduced ejection fractions. And every visit, you have to pay attention for the baseline investigations, echocardiogram, as well as BP, pulse, heart rate. Then you can slowly uptitrate the molecules. So next is what is the common cause for treatment failure or not able to reach target hypertension in elderly? Your experience and how do you address them? Many of the times you are not able to attain the target in elderly patients. We have only 14 minutes.
Yes, sir. See, mainly it is non-adherence or giving a suboptimal dose. There's a therapeutic inertia, missed doses. So all these are very common causes of treatment failure. So when we see a geriatric population, that you go for start low and go slow, but go for early fixed drug combination so that you'll achieve your target BP as soon as is possible. And look into other comorbidities also. So choosing drugs based on other comorbidities is very, very important, and not the wrong drug. For example, for isolated systolic hypertension, I can start him on a beta blocker first. So that should be an amlodipine or this. So these parameters we follow, you'll be able to have less treatment dropouts.
Lower doses, you can go for a fixed drug combination that can address different aspects of BP. So if you, instead of going Nicardia 20 mg BD, you can go for amlodipine 5 mg. You can add some other diuretics or some other low dose ACE inhibitor as a beta blocker, depending upon the clinical scenario. So low dose, you can avoid the side effects, and competitive mechanism, synergistic blockade of many alternative mechanism can drop the BP to the target. Next is, which laboratory tend to be more productive of progression of severe disease, whether these patients go for HELP syndrome or these patients go for, what are the laboratory predictor? So I can follow these patients go for eclampsia.
The first one to decrease will be the platelet count, sir. When the platelet count is less than 1 lakh or it daily drop of more than 40,000. Second will be the elevated liver enzymes, which will be twice the upper limit of normal or more than 70, or we see any evidence of hemolysis, where there will be increase in LDH or there increase in total bilirubin, or in peripheral smear we see cystocytes, we think of HELP.
So how often you will do in a patient you are treating hypertension with pregnancy, how often you will do in this test?
So if it's a mild pre-eclampsia, at 28 weeks, once in 2 weeks we repeat those tests. If it's a severe eclampsia or with other comorbidities, sometimes twice a week also we repeat all the blood investigations. Sir.
Any change in medications when the HELP syndrome is happening? Suppose patient is BP is uncontrolled, hemolysis is happening, low platelet is happening. We have to change the medications.
Delivery is the first step. We have to deliver the baby, then only control the blood pressure, then we can give them on steroids or depending on their conditions, on the platelets.
So how do you select diuretics as antihypertensive in a patient? I'm talking diuretics as antihypertensive
so
in a patient with CKD, and when do you switch?
Yeah, so usually, sir, diuretics as antihypertensive, at that stage, most of the patients don't come to me. By the time they come to me, they are already in TKG stage 4 and the EGFR is less than 30.
We'll talk as a physician aspect of stage 3 or 4.
So if it is 3 or 4, usually we go for the thiazide-like diuretics like chlorthalidone or hydrochlorothiazide. That is what usually we give. But again, in an elderly population, be careful about hyponatremia whenever you are giving hydrochlorothiazide. The thing is, if the GFR is less than 30, you want to give a diuretic, prefer loop diuretics. The thiazide diuretics are unlikely to act. If you want to give a thiazide-like diuretic, many times it is metalazone, which comes by the name of Zytanix. The only thing you need to be careful about is in patients with significant renal dysfunction, the diuretic dosage needs to be proper. So you cannot be giving the patient loop diuretic like furosemide of 10 mg or 20 mg or a torsemide of 10 mg or 20 mg to a patient with EGFR of less than 30. It's not going to work. They will need much higher doses. So the doses which needs to be given is furosemide of 40 and above or torsemide of 20 and above. Only when you give at that doses, the patient will have any effect. Otherwise, the patient will not have any effect. Usually, again, loop diuretics is more to decongest rather than for BP reduction per se. You have other effective medications which you can use.
So suppose I'm increasing diuretic, whether it will have a negative impact on the GFR. So many of the nephrologists says, why are you giving diuretics? Diuretics is the things that will increase the creatinine.
Yeah, so that is true, sir. So it comes down to the, it's a balance. So if the patient is having significant volume overload, you will have to give loop diuretics at the end of the day. That will result in fall in GGFR. If you don't want to give loop diuretics, you will have to take the patient for ultrafiltration. Now that is much more difficult to do. So the thing we'll have to tell the patient is again comes to diet control and fluid restriction. So
many of the times as a cardiologist, when we give diuretics, because we have more volume congestions, we want to increase RNE. Because many bit of RNE comes with 200 mg. Because it is very difficult for us to reach 200 mg with a heart failure of EF of 25. So whenever we want to escalate, the creatinine jumps. So when we send to nephrologists, they say this drug is producing the problem, this diuretic is the producing the problem.
True.
But we don't have any data to reduce the volume. So that phase, doctor, patient will say, sir, unga maatrana kidney damage agudante.
No.
These are things we see as a cardiologist.
Yeah, I think we as nephrologists should be a bit more careful in communicating what we see to the patient. So I usually tell the patient that if you are volume overload, this drug would be necessary, and when you take this drug, the chances of your creatinine going up is there. So how you prevent is that you bring the patient to euvolemia and then ask them to stick to the sodium restriction and fluid restriction properly, so that we are able to stop the diuretics. Otherwise, the patient is going to go into recurrent pulmonary edema, and then we'll have to give more and more diuretics, and more EGFR fall is going to be there.
I think there is only 9 minutes where we can stop, or another 4 questions is there, whether we want to continue or stop. Finish. Okay. So despite last question, despite multiple antihypertensive therapies, many patients fails to have a BP control. In your opinion, what are the most commonly overlooked reversible cause of resistant hypertension? So Manikandan, you can pay attention, give us some insights on resistant hypertension, commonest cause. Already told by our nephrology colleague.
I think all points have been discussed by our nephrologist. First, we have to see whether there is pseudo-resistant hypertension, whether there is any error in recording and measuring the BP, like that, any interaction with medications, like that we have to see. And after ruling out all these things, if the patient is having resistant hypertension, we have to look for the secondary causes, the endocrine causes, whether the common causes hyperaldosteronism, CON syndrome. So you have to measure the plasma aldosterone to renin ratio.
Many of our patients say, whenever I come to your clinic, only my BP is high. How you are going to handle
that? Is white coat hypertension.
How you are going to exclude white coat hypertension? What is your recommendation of home monitoring of BP?
Yeah, home monitoring BP can be done, and ambulatory BP monitoring also can be done.
Do you advocate regularly for it? Because ambulatory BP monitoring is very difficult. So it's do you advocate home monitoring of BP for all your resistant hypertension patients?
Yeah, if the patient is very anxious and patient is having high resting heart rate, then usually we suspect this white coat hypertension, and I will ask them to see the BP. That too, we should properly instruct them. She should not be taking any coffee prior to the measuring the BP. He should should be ideally he should be very calm, and then we should measure the BP.
So resistant hypertension, if you want to exclude white coat hypertension, you can advocate home monitoring BP. But before that, You have to educate the patient how you have to measure the BPs. As told by, you should not consume coffee or any other drinks. You have to sit regularly. You have to cuff size should be normal. You should not talk. So much of things you can educate the individuals when you want to do assess hematocrit BPs. For time constraint, I'm jumping to the next topic. Are there any recent guidance or updates, clinical trials that have changed your practice in treating geriatric hypertension? What are your first line of medications?
So we do have the recent STEP trial and the SPRINT trial, which says intensive BP control is reducing the CV risk and mortality as well as stroke risk.
Do you accept SPRINT trial target?
No. I mean, practically it is not possible. So we will end up with more of complications rather than maintaining. So when patient has a CV risk and the patient is fit, robust, independent individual, then you fix up that target of accepting the STEP or SPRINT trial. Otherwise, frail individuals, you fix up your target.
What is the first line of medication?
Yeah, I will prefer thiazide or thiazide-like diuretic. Then I will choose a calcium channel blocker, maybe a long-acting one. So indapamide has a very good role in management of.
How many times patients have developed hyponatremia on diuretic therapies?
If you go for a very low dose, most of them we don't encounter, sir. So only when we go for loop diuretics, we have those kind of problems, issues.
What is your protocol for fetal surveillance in women with gestational hypertension or pre-eclampsia?
We start the surveillance throughout pregnancy, sir. Then we plan the delivery before 37-38 weeks. If it's a mild pre-eclampsia, we ask them to come around 28 weeks every week till our planned delivery. We do a growth scan. It will be done at 28, 32 and 36 weeks. We monitor their growth. We check their blood Doppler as well as the Leica and ask women to maintain a daily fetal movement counts and all the lab parameters.
As a physician, when you refer a case to us to BP control, they'll ask, in the BP the first things that mother will say,
BP baby the first mother.
They will say, how we have to tell to them. So this will not have a problem.
BP control panna we prevent the preterm delivery and also the chances of IUGR fetal growth restriction and chance for NICU admission. So good BP control can protect mother from eclampsia, which is the most commonest cause of maternal mortality in second most commonest cause after the PPH, sir. So it's must.
Okay. So can a non-steroidal MRA be added as AC ARB to optimize BP as well as protein excision if renal parameters are marginally raised?
So definitely add non-steroidal mineralocorticoid receptor antagonist we had already talked about. So the one thing which we have is finerenone. Actually finerenone is never used by a nephrologist for BP control part of it. It's almost always for the renoprotective effect to decrease the proteinuria. But there is a molecule in pipeline. So there's a molecule called as esaxerenone which is actually it is approved in Japan. So it's still not available in India. We are expecting to get it by this year end or the starting of the next year. So esaxerenone is a non-steroidal mineralocorticoid receptor antagonist which has very good data with regard to resistant hypertension management. So Eris is the company which is planning to bring about the molecule. If it comes, then we'll have a non-steroidal mineralocorticoid receptor antagonist which is useful in treating patients with resistant hypertension as well. But as of now, finerenone is predominantly used for the renoprotective effect rather than for blood pressure control.
The esaxerenone is approved by US FDA or not? Because esaxerenone was a drug that came first in 2019, if I'm right.
Yes.
But finerenone came later.
So
finerenone has approved by US FDA. Esaxerenone has not been approved by US FDA.
Because most of the studies of esaxerenone from Japan, it has approval in Japan and it is available in Japan. It is somewhat similar to cilnidipine. Cilnidipine is also not US FDA approved, but still it's widely available in the market and most of the data is again from Japan. So the reason why it is not US FDA approved is not because of lack of clinical data or some side effects. It is because the Japanese, they have not even filed for FDA approval because it involves lots of cost and all those things. So again, esaxerenone, the data, there is some Indian data which actually Eris is doing a study. We had a recent collaboration, so I know about this molecule. They are planning to bring it by this year end, and most of the data for esaxerenone is with regard to hypertension management rather than nephroprotection. Finerenone is being used for nephroprotection rather than for hypertension management.
Esaxerenone is compared with the aldactone and epilenone, is not compared with the finerenone, even though it's non-steroidal.
So sir was talking about eplerenone and spironolactone. So they are much cheaper. So if the patient is not able to afford finerenone, many times we will be able to give those molecules. The only thing is chance of hyperkalemia are higher.
Okay, thank you all for the visit. And we are coming to the conclusions. Hypertension is not just a number, it's a strong predictor of premature cardiovascular events. The biggest challenge is no longer the lack of medication. We have a good number of medications. The gap is awareness as well as diagnosis and treatment. Every BP measurement is the gateway to prevent heart attack, heart failure, CKD and stroke. Achieve the target BP goal, achieve the target outcomes. No stroke, no heart attack. Let the disease be silent killer, but our response should be never be silent. Thank you very much for the patient listening.
Ladies and gentlemen, that brings us to the end of our morning sessions. On behalf of the organizing committee, I extend my sincere thanks to all our respected chairpersons and speakers for sharing their valuable knowledge and insights, and to all our delegates for your participation. We will now take a quick short break for lunch. Yes, 30 minutes. Kindly reassemble in the hall in another 30 minutes as we resume for our afternoon sessions. Thank you. Have a great lunch. Thank you. IAC Chief Coordinator, NEET PG Dental Pulse Academy Coordinator and Chairperson of this session, and Dr. N. Kannan, Chandra Diabetes Care Center, Consultant Physician and Diabetologist, Chennai, and Chairperson of this session, to introduce the next distinguished speakers. Over to you, sir. Thank you. Yes, please put your hands together and give a warm welcome to both of them. Thank you.
Hello. Good afternoon, friends. Welcome to post-lunch session. Now we have a very interesting topic on anaphylaxis. Friends, anaphylaxis is the emergency in clinical medicine where hesitation becomes fatal. So early recognition and early action is very important. For this to elude, we have our very enthusiastic and eminent speaker, Professor Dr. Venkatakrishnan. Sir is a professor of medicine from Sri Ramachandra Medical College. He is MD General Medicine from GR Medical College. He is a FRCP from Glasgow, fellowship in the College of Physicians. Over to you, Venkatakrishnan.
So thanks DCCON, Natarajan and his team, Dhanamitran sir, for the opportunity given. So post-lunch is always a tough session to take. The first is you have a postprandial nap, you feel like sleeping, but this is a good topic. Maybe the organizer thought anaphylaxis is a very important topic. If you miss the boat, the patient dies. It can be near fatal. That is what is. So you may survive at sometimes, but usually it is anaphylaxis, it's fatal. So I just touch upon what is anaphylaxis and what we should learn as a clinical person. So I will not touch a pure theory, but a few aspects of anaphylaxis for a clinical knowledge you should know. How is it different? Anaphylaxis can present as a mild one in a very rare clinical presentation. So we will discuss on that. If left untreated, it is near fatal. I told you, it progresses rapidly. The most important thing is it causes shock and airway obstruction. That is why it is very tough to handle. So what triggers is most common is foods, followed by medications, insect bites. Patients will come, wasp bite, bee bite, or they will come and ask what is to be done. Latex exposure. The last one is there is no clear trigger identified. You don't have a clear trigger identified. So what happens in the first phase is, with the initial contact with the allergen, the pointer is not working, no issues. So you have a pointer which is working, this one is working. Yes. So with the initial contact with the allergen, what happens is, there is an activation of various cells which mediates to IgE. IgE antibodies release the major culprit is mast cell. Through IgE mediation, there is a mast cell activation. So this one, why I put is, initially it may go as a mild reaction, but there is a subsequent contact with the same allergen, it goes for a severe allergy where histamine and other inflammatory mediators are released. The second slide is, what are the mediators? So if you know the mediators, why I should know the mediators is, definitely histamine, as I told you. The target is, the treatment is antihistamines, specific antihistamines to target. Cytokines, chemokines, all from the stimulus and mast cell activation. Cytokine chemokines is taken care of by anti-inflammatory steroids, and when the patient goes for a shock, you have a specific molecule for anaphylaxis. Then is eicosanoids, through leukocytes and macrophages. There is a protein degradation, phagocytosis, bacterial killing. If there is a good adaptive immune response in a few patients, that's what I told you, they may have a initial episode as a mild allergy, which goes unnoticed. So pathophysiology, it affects major system. This is must know. The most important thing is respiratory. Upper respiratory, there can be angioedema. So initial aspect, what happens is, the patient has puffiness of the eyelids or edema of the lips. That is the warning sign, the first warning sign. You should be doubly cautious if the patient has angioedema. Stridor occurs later. All this is because of histamine. Histamine along with leukotrienes, cystinyl leukotrienes. Leukotrienes causes severe bronchoconstriction. So severe bronchoconstriction causing significant hypoxia. Again, histamine can affect the digestive system. That is why when the patient has an allergy along with the GI symptom, you should be again careful. So you should not say because he had some food that because of that he is having gastritis. This GI symptoms in a patient with other contributing factors could be due to histamine. The next important point. Again, platelet activating factor along with leukotrienes with histamine. What causes next phase is hypotension, tachycardia, vasodilation, increased vascular permeability and syncope. So initial manifestation, as we told, is angioedema, urticaria, flushing. We learn with the case scenario. So this is important. What happens with the upper respiratory, which ultimately results in hypotension, tachycardia, vasodilation. So what are the modulators of? So if you ask me, the patient may ask, will I get a reaction? Very tough to predict. But if there is a family history, or there is one episode of anaphylaxis, post anaphylaxis, we can always work up the patient whether he is prone for further episodes. That's what we are going to discuss in this slide. What does it say is hereditary alpha tryptosemia. So any anaphylaxis, we do our angioedema 2 investigation. We do a C1 esterase inhibitor and tryptase levels. If tryptase levels are significantly elevated, the patient is at risk for further episodes of anaphylaxis, they should be on a long-term antihistamine and steroids as necessary. HLA-DR prediction, nothing we cannot predict. This platelet activator function level and can predict future onset of anaphylaxis. So anyway, this AC inhibitor, you should bear in mind, the only drug that can cause angioedema even after 5 years. So any patient, Telma we are giving, most of the patients are diabetic and hypertensive or on telmisartan or enalapril in government setup. Now government setup is giving telmisartan for most of the patients. ACE or ARB, he says that I am taking ARB ACE for last 2 years. Now I am having edema of the lips, and this is a idiosyncratic reaction, not dose related. It can occur any point of therapy. One episode of angioedema, you should stop ARBs. You should not tell that he is taking for 2 years, now only he is developing. You should, it's a clinical acumen that you should stop. It can occur at any point of the therapy. So others, NSAIDs we know, beta blockers, a few beta blockers can cause. So types of anaphylaxis, all we think is it is only immune mediated. It can be non-immune mediated. That's what is the learning for us. So what does it say is, we know, everybody knows Ig mediated anaphylaxis due to histamine. I am not going to full core theory aspects. Common theory is, you can see what are the, usually eggs, milk and shellfish, nuts, peanuts. Now we are all fond of peanut butter. Not we are fond of, we are all grown up. All the adolescent and children and young individuals, they are fond of peanut butter. So we are seeing reactions to peanut butter recent times. Various, it could be due to various factors. Others we know, penicillin, insect bites. Non-IgE mediated, this should be, you should know what is this. Other parts of the immune system, that is IgG antibodies or the complements, can be activated. So in this, antihistamines may not have a significant role if it is non-IgE mediated anaphylaxis. So non-immunological, there is something you may, if it's always immunological we feel, what does it do is, the immune system is not involved. It directly irritates mast cells and basophils, causing them to burst and release only histamine. There is no other immunological reaction. If this is the anaphylaxis, that is why a few patients within 1 hour, 2 hours it subsides with a simple antihistamine. So these are the patients where the immune system is not involved, only histamine release is involved. So this is usually with opioid or NSAIDs, extreme cold, heat or vibration, heavy exercise can rarely induce anaphylaxis, non-immunological anaphylaxis. Idiopathic anaphylaxis. What happens is, severe anaphylactic episodes are there, but you test for everything is negative. No trigger is identified, only by exclusion you can say it is a idiopathic anaphylaxis. The other is, this thing you should know is the phase of anaphylaxis. It is uniphasic reaction, biphasic. This biphasic reaction you should know. Somebody comes with anaphylaxis to the emergency, you should say, I am going home sir, nalla aidichi. You should observe the patient, ideally for 6 hours or 12 hours. If you feel the reaction is severe, at least 12 hours we observe, or you document at his request or against medical advice I am going. Otherwise, he may come with a severe reaction as the biphasic reaction. Initial, after 2 hours, it subsides. After 2 hours, the patient has a new trigger is there. It causes a severe anaphylaxis. That has to be borne in mind. Protracted is very rare in specific therapies. There is protracted anaphylaxis is seen with medications. So we don't see only in a tertiary care setup we see. But in a primary setup, be careful about this biphasic reaction. Observation is very important. To summarize what we learned from all immunology, pathway of anaphylaxis is type 1 or IgE or non-IgE. We have discussed that. Cytokine release, a mixed IgE, non-IgE plus cytokine release, only complement release. So why we should know this is, if this 2 and 3 and complement is involved, definitely steroids should be given. But clinically, initial phases, we always give a short course of steroids when we don't have an idea what is the exact reaction. So initial phases we don't know. So tryptase and all, it takes time. It takes at least 3 days for the values to come. And IL-6, IL-1 beta and all, we don't do. Histamine levels we don't monitor. So what is done is tryptase, as I told you, and C1 esterase inhibitor levels. So this is the case scenario. Classical scenario what we see in practice is a 24-year-old male with no food allergies is at a restaurant eating a Thai curry. Now all Chinese foods, all foods have become famous. So everybody prefers only non-Indian foods. So within 5 minutes, 15 minutes of eating, he feels a choking sensation. So no definite skin rash, heart rate is tachycardia is there, BP is high, in the higher range, lungs clear. So what should be the next step? So reassurance, you give a thrust on the back, we call it cafe coronary. There is upper airway obstruction because of food impaction. For that you give a thrust on the back. You give injection adrenaline, you give a hydrocortisone or fexofenadine, Allegra. So what should be the ideal one for this patient? So you think it is anaphylaxis? It's not anaphylaxis. It's only cafe coronary. That's what you want to say. So very important. This slide is an important slide. What happens 10 minutes past injection? These are the early signs. If you miss early signs, so you can miss the patient also. That's what you should know. What happens is a tingling sensation in the mouth and lips, generalized pruritus, followed by rapid onset of widespread urticaria and erythema across his chest and face. There will be erythema in the chest and face. Some patients can have eyelid edema and lip edema. 15 to 20 minutes post injection, what happens is he experiences upper airway obstruction. So any choking after a Thai curry, all these Chinese foods contain what? Either they contain some glutamate related substances or peanut butter or various other substances which can induce anaphylaxis. Seafoods. This is followed by severe wheeze and shortness of breath. 30 minutes post injection, the patient goes for a hypoxia, severe hypoxia, hypotension. That's what in 30 minutes you may lose the patient. So we have only half an hour. And the patient has early signs, choking, better start treatment. So ideal treatment will be, so don't hesitate, give adrenaline. That is the only life-saving medication in anaphylaxis. So hydrocortisone, definitely. Along with that, you always give, be safe. Fexofenadine is a supportive treatment. It's not for acute management, emergency management. It is definitely needed for histamine release. So assess the patient, should always auscultate the throat, trachea. You clear stridor visible, that is inspiratory wheeze. During inspiration there is a harsh sound, that is stridor. So all other findings I am not going to discuss. The patient goes for a profound hypotension, tachycardia and tachypnea. Clinical signs, initial clinical signs are stridor. That should be identified. As I told you, epinephrine intramuscular, 1 in 1000 dilution, 0.3 mg is the drug of choice. Immediately into the anterolateral aspect of the middle third of the thigh. It should be injected in the thigh, vastus lateralis, not in any other position site. So any Anybody wants to tell me, is there a role of endotracheal adrenaline? Yes. Yes. If the patient has shock, profound hypotension and hypoxia, you intubate the patient. In those settings, you have a hypotension, IM, vascular perfusion is not predictable. So, you give a IM along with a endotracheal adrenaline as a life-saving procedure, because hypotension, absorption of medication, you cannot predict. So, that is very important. Positioning is also important. Any anaphylaxis, the positioning is, you should never, it should be sitting abruptly during anaphylaxis can never happen, should never be done, can cause fatal cardiovascular collapse. It's always a recumbent position with his leg elevated to optimize venous return. That's the best position. So, airway, high flow oxygen via a non-breather mask is applied, circulatory support, 2 IV lines, large bore IV lines should be established, and at least 1 liter of saline to be initially rushed to maintain the perfusion. So, you follow up the patient. So, this with this we have an idea, we have done. Response to epinephrine within 5 minutes of IM epinephrine, the patient's airway stridor decreases. That is what I told you. If the patient is in shock, IM epinephrine, if it is not acting within 5 minutes, the patient has to improve. That is also a clinical sign. So, bronchospasm eases and BP stabilizes. A second dose is usually not required. If it is not improving, endotracheal. That is the best one. Secondary therapy is once stabilized, antihistamines and corticosteroids given to help mitigate the risk of a late phase reaction. That is why biphasic response will be there. After, there may have a biphasic response after 2 hours, 2 to 12 hours. Observation. So, 6 hours mandatory observation. Now, in this setup, always tell them you have to stay overnight at least 12 hours. I have to observe you. If a second reaction occurs, it is your call. It is at your risk, you leave. You should be very clear. So, I think I summarized anaphylaxis. What are the pathophysiology of anaphylaxis? What are the clinical manifestations? How to treat, which is a must-know emergency for any private practitioners, be from a primary setup to a tertiary setup, whoever it is, we should know how to manage anaphylaxis. Any questions I will be willing to answer. We have 4 more slides on this. Why I put these slides is, not all allergies are anaphylaxis. First you should know. There is a difference between angioedema and anaphylaxis. What is the difference is, it is only a localized swelling, no urticaria, no hypotension, no systemic involvement. As I told you, ACE inhibitors are the culprit, usual culprit if the patient is on ACE inhibitor or ARBs. The thing is, hypotension with multisystem is anaphylaxis, isolated swelling without shock is angioedema. Why you should know angioedema is, one episode of angioedema can be a secondary reaction which can go for a severe reaction, could be anaphylaxis, the next episode. You should identify the culprit and stop. The second slide is, this is what is classical angioedema. You get lipedema and edema of the eyelids. This will be the manifestation. If only is localized, this localized, it's always easy. You give antihistamines. If it's a severe one, you can always give a short course of steroids. This is not anaphylaxis. This is a classic urticaria, hives we call it, raised lesions. Along with this, if the patient has choking, it is anaphylaxis. Diffuse rash along with choking is anaphylaxis. This is the last one. This is also a drug reaction. Why we should know what are the drug reaction? One more slide is there. Why you should know this is erythema multiforme. It is called target lesions. You can see there is a dot inside. Target lesions, usually in the palms, soles, it is seen. The last one is, this is Steven-Johnson. So, drug reaction should be there. Not all drug reactions are anaphylaxis. Anaphylaxis has a specific so mucus involvement, you can see diffuse mucus involvement, skin involvement is there. This is Stevens-Johnson. Why you should know is this can progress to anaphylaxis. It's the next drug reaction if it is there, if at all it is there. One immune mediation can worsen the next episode of immune reaction. Thank you DCCON for the opportunity. I will be willing to answer any questions.
Well,
Yes.
So,
Yes.
Dr. Venkatesan sir, we have the questions at the final of the
All right,
session.
okay,
Yeah,
thank you. என்ன மேடம்? I'll tell you மேடம். நான் சொல்றேன் உங்களுக்கு.
So at the end of the session, we will be ending the question session. Now we are entering into the next topic. It's again a very interesting topic. Before that, we are mesmerized with our good orator, Venkatesan sir. As expected, it was not theoretical, with a very clear case-based scenario of thigh curry. So how you are going to manage each and every step of anaphylaxis. And another interesting topic we are going to discuss, urinary incontinence. Everyone is able to see the patients of urinary incontinence. The problem is, the patient with urinary incontinence, we know how it is going to be suffering for them. But how we are going to approach the patient with urinary incontinence? Many causes may be there. It can be hyperactive bladder, atonic bladder, automatic bladder, or even BPH, benign hypertrophic prostate, pressing the urinary bladder. So many causes are there. So Dr. Madhisegaran Tangarasa sir, so no need of introduction of him. Sir is a nephrologist at INO, urologist, kidney transplant and robotic surgeon at INO hospital. So sir is going to enlighten us on how to approach a patient with urinary incontinence, types and management. It is going to be a very interesting topic because many general practitioners are not able to manage the patient with urinary incontinence. They are doing the different treatment, but actual treatment should be different. So that will be enlightened by our urologist sir. Back to you, sir.
Thank you so much. Warm welcome to everybody, and my sincere thanks and gratitude to the D Club, Dr. Dhanamithran, the founder president, Dr. Nadarajan and Dr. Parandaman for inviting me here. I'm very grateful for this. I am Dr. Madhi. I'm one of the consultants with INO Chennai, and I look majorly into the functional urology aspect of urology. With respect to urinary incontinence, as medical practitioners, we would all have come across urinary incontinence, either in our own families or the patients or our relatives or friends, and this is one of the most common conditions we come across, yet most of the policies, most of the especially most of the programs kind of neglect it. The patients also feel very delicate to come up and tell that they have been suffering from such a issue. So it's been under-reported health condition, and it is also a big burden in developing part of the world. So as we discussed, urinary incontinence, we all know, it's involuntary leakage of urine. There are certain types that we should know before we manage the patients. In this slide, in this talk, we would touch about the types and how the patients present, and how as primary physicians we can manage these conditions, and at what point we may ask for help from the concerned specialist, be it a urologist, urogynecologist or gynecologist. So we would look into it. With respect to the prevalence in India, it's more common in women. We know that 2:1 ratio, and the incidence or the prevalence is around 12.5% in reproductive age group, and goes up to 45 to 50% in women who's more than 40. And the most common type of incontinence that we come across in practice would be stress urinary incontinence. We would very briefly look into the types of incontinence. And the major risk factors that we come across are childbirth and parity. Higher the parity and vaginal deliveries, the risk increases substantially. And chronic conditions such as diabetes, constipation, recurrent urinary tract infections are also associated with such conditions. Obesity, the global pandemic that we come across, is one of the most common causes for urinary tract infection, urinary incontinence. and obviously the lifestyle modifications that we are going to look into, they play a major role. So now coming to the clinical type of urinary incontinence. So there are, in our part of the world, we basically follow two major guidelines. One is European Association of Urology guidelines, and the other one is International Continence Society, ICS guidelines. So these two guidelines majorly stress on stress urinary incontinence, urge urinary incontinence, and mixed urinary incontinence. There are other two things that I would like to touch upon. One is overflow incontinence, and last but not the least is functional urinary incontinence. So the stress urinary incontinence is one where when a patient comes with a complaint saying that I leak when I have anything to do which increases my abdominal pressure, such as cough, sneeze, or laughing, or just bending down and picking up anything which increases the abdominal pressure. So that's stress urinary incontinence. And when somebody is coming and telling that, doctor, I have this urgency to pass urine, but I can't control it, and before I reach the hospital, before I reach the toilet, I tend to leak. This would be urge urinary incontinence. And there's one component where they have both. They have the urge component as well as the stress component. That's called mixed urinary incontinence. These are the three major things, major types that we come across. But beyond that, there are two other things that we look into it. So if you look at the patient's words, what sort of words they use, one is, doctor, when I leak when I cough, sneeze, or exercise, and urge, I cannot get to the toilet at the time. So that's two things we discussed. This functional and overflow is something where this simple sentence that I never feel empty and I constantly dribble urine is not doing justice to this condition. Overflow incontinence is something where I would put like a bucket of water where the water gets full, the bucket gets filled, and then it leaks. So this is classical of overflow incontinence, where the patient goes into retention. Generally these patients are elderly patients or patients who has this urinary blockade, be it prostate or be it stricture or be it neurogenic problems for many months or years, where they are used to do this blockade. Then all that they feel is a vague discomfort in their abdomen. They don't have an acute pain which is very similar, which is seen commonly in stone block. They'll just say that I have some discomfort, but I pass urine. Basically they'll be on diapers and they will wet the diapers. Every 20 minutes or 30 minutes they just leak 30 ml to 50 ml. So this is overflow urinary incontinence. This is one of the most dangerous type of incontinence, because practically they are obstructed, and the back pressure changes will not allow the urine to produce more urine, and they allow acute kidney injury in these conditions. Functional urinary incontinence is a condition where if the patient is a geriatric patient, an elderly gentleman or a woman, where they have the urge to pass urine, they can control it, but before they reach the restroom, because of that physical limitations or physical ability, they will not be able to reach the toilet in time, and they pass urine. This overflow incontinence and functional urinary incontinence are something that we just have to deal with it majorly with especially functional urinary incontinence with lifestyle modification, and the caretaker policy has to be changed. Overflow urinary incontinence has to be evaluated properly. So with this, we get into the first interaction, where we ask these 6 essential questions. One, what triggers the leakage? That's the most important question that we'll ask when somebody comes to us with incontinence. Obviously, is it a cause leak, or whether there's an overwhelming urge to go there. The second one is, what is the severity and the frequency? How often they have to go through this trouble, and what is the major thing that affects the quality of life? That's very important. What is the voiding pattern? Whether it is more common in the day or whether more common in the night. And obviously everywhere we have to ask about the point of urgency. If it's the urgency thing that's causing the trouble, or without urgency, when they cough and sneeze they leak. That's the voiding pattern. And the other important question that we all urologists and urogynecologists ask is, how are you emptying the bladder? do you feel that you're emptying completely, or you feel that you're blocked? Is there a sense of incomplete emptying? This is usually associated with long-standing trouble. They do not complain of pain or major discomfort, but they just say that, doctor, I feel that there is always something inside. I'm not able to completely empty it. So that's the bladder emptying question. And obviously associated symptoms, whether they have burning, micturition. UTI can obviously cause repeated frequency and urgency, and sometimes a leak. And if they have hematuria, or if they have signs and symptoms of urinary tract infection, then that has to be evaluated thoroughly. And last but not the least, relevant medical conditions has to be assessed, be it an obstetric condition or a gynecological condition. If it is an elderly gentleman, we have to always look into whether he's got an obstructed prostate, whether they are suffering from neurological issues or chronic debilitating conditions, and diabetes. And if they have any symptoms of spinal cord compressions, I'm just telling about even something which is very common, like severe disc bulge, which is not obviously giving them trouble, but giving them difficulty with voiding. Excuse me. Sorry? Okay. So once these basic evaluations, the examinations are done, then we have to think about the medication that patient may be on. So if the patient is having any form of incontinence, or be it urinary issues, we'll always have to ask about the intake of diuretics, because we all know that it increases urinary production, and probably the patient feels too full too often, and then they have to go to empty the bladder. And the most common bladder irritants, that's coffee, alcohol, these are two common things. And whether the patient is on nighttime sedatives for their sleep, because these people generally these people will not have nocturia. They classically say that I take tablets, I sleep really well, I don't have this issue. But when they wake up in the morning, they will have this weird bladder fullness. They will not be able to empty early in the morning. It's classically called as hesitancy. They will just go stand there for 5 to 10 minutes. They will not be able to empty it normally. That is with regards to the sedatives. And anticholinergics. So anticholinergics, be it in any form, it can impair the bladder contractility. So these people will have difficulty in passing urine, so they can go into retention, and this overflow incontinence is very common in these people. And then cholinesterase inhibitors can worsen urge incontinence. And alpha blockers, I'm not very convinced about this point, but still I would want to put it, because alpha blocker can relax the bladder neck, but the sphincter complex is a skeletal muscle. Alpha blockers generally do not act on the sphincter complex, the sphincter per se, but as the whole sphincter complex, some patients, especially women, they may have a little bit of stress urinary incontinence. But it's not something to be really worried about, but still this point has to be kept in mind. And AC inhibitors, as a physician, you know it much better. It can cause cough, and it can worsen stress urinary incontinence. These are the most common medications or things that can kind of mess with the patient's urinary functions. So once the patient's there, we asked all these questions, we checked the review, and then basic evaluation would be a general assessment of how obese they are, how is the mobility, what is the cognitive ability of the patient. And then when we look at a patient who's got incontinence, always we look for a palpable bladder. Is the patient having a full bladder and leaking, just like an overflow incontinence, or she's just leaking because, or she or he is leaking because of urge or stress urinary incontinence. So the abdominal examination is very important. It also points to any other intra-abdominal pathologies. Pelvic examination for women and digital rectal examination for men is a very, very important thing here, because a man can have an enlarged, very hard prostate, or he may have chronic constipation with a severe fecal impaction, which will also block the urine pathway. So with respect to pelvic examination for women, we have to look for pelvic organ prolapse, be it uterocele or rectocele. We just have to see whether any prolapse is there, because this prolapse will mess with the angulation of the bladder and the urethra. This will worsen the stress urinary incontinence. And this is cough stress test. Generally, when we do a physical examination on a woman and we see when she coughs, she's spurting urine out, that is a gold standard sign that she's got stress urinary incontinence. Now the point here is, we have to understand that many women may have mixed urinary incontinence, where they may have stress urinary incontinence but an underlying urge urinary incontinence also. So before we get into proper treatment option, we have to rule out whether she is having a combination of these both incontinences. And neurological, simple gait and perineal sensation would check the integrity of the nerve roots that we really bother about with respect to urinary incontinence as well as the fecal continence mechanism. And the primary investigations, so we've asked the questions that we wanted to ask. We examined the patient, we checked their drug reviews, and then what investigations first we can ask as the primary physicians when a patient comes with urinary incontinence. So that's going to be urine routine and urine culture. If we think the patient is having a urinary tract infection, these two would point out to it. And we have to have a baseline assessment of what is the current renal functions. Obviously, your blood sugars and HbA1c, how much they are retaining. So that can be done in two ways. One, if we do not have an ultrasound, if the patient is accepting for procedure, what we can do is we can ask the patient to pass the urine in the commode in the clinic, and we can insert a small feeding tube or a small sized catheter to check how much urine is still remaining. We don't need a fancy uroflow, we don't need a ultrasound for it. We can check that. But if the patient is a bit uncomfortable with it, obviously the best thing is ultrasound of the bladder to look for post-void residue. And avoiding dairy is something which is very, very useful when we refer the patient to a urologist or urogynecologist, because it will give a snapshot of what the patient is going through. So generally avoiding dairy is it's a clinical sheet where they enter how much and what sort of drinks they take, be it tea, coffee or water, and what is the amount and what is the time duration that they take, and how often they use the restroom. And it is generally asked for 3 days before the start of any treatment, and then every visit we ask them to come up with a 3-day bladder diary, so that we can compare what was before and what medication had an effect, and what is the current status. So what she takes and how often she passes urine, and if they are leaking, then we have to add how many episodes of leak and what caused the leak. It is just for 3 days. We can tell them, okay, Friday, Saturday, Sunday, please do it for me and come and see me after a couple of days. We could just request them. Most of the patients oblige. Surprisingly, most of the patients oblige. And if there is a leak, then we can ask how many pads are you using. If they are using an adult diaper, then we can ask, okay, fine, you can just come up with the number of pads. So these are the details which will be invaluable when we treat the patient. And obviously renal ultrasound would be better to look for any anatomical abnormality that we're looking at. These are the primary investigations we are going to ask when a patient is going to come up with such complaints. Now, there is this universal first line management, be it stress urinary incontinence, or urge urinary incontinence or mixed incontinence, then we have to look at a set of things. So that is, first and foremost, as their primary physician, we have to explain what they may go through. Most of the women, it takes lots and lots of courage to come up to a doctor and then tell doctor, I'm leaking. It's very embarrassing to anybody. So when they come up, first thing we say is, okay, don't worry, we are there. And this is very common in Indian women or any women of any age. So we will look into it. That's the first thing. And if the patient is bit on the healthy side, then we tell them, okay, would you consider going for a diet or exercise, basically weight loss. And most of these patients, especially somebody with overflow incontinence, may have also, or somebody with pelvic floor dysfunction may also have associated constipation. That is something that we have to ask, and if needed, we have to correct it very promptly. And the lifestyle modifications, the coffee and tea, most of the time, if there's a young men or women, so what I generally say is, that's my understanding is, when they're working in IT or any stressful job, they get up from their work desk to go to have a tea or coffee, basically because they wanted a break from the work. And most of them do not care whether when they go out for the break with the friends, whether they take tea or coffee. Even if they take milk or Boost, Horlicks, they're okay with it. They just want to get out. So we just tell them that why can't we just cut this down and see. So this is universal lesson. Any type of urinary incontinence, we are going to do it. And obviously the fluid timing. So this is more common when a patient is having nighttime difficulty with incontinence. We tell them to take early dinner, finish all their tablets by 7:30, 8 o'clock, pass urine at least 2 or 3 times, at least a couple of times before they go to sleep, and then they can go. So this fluid timing with respect to even the bladder diary, as well as what is avoiding timing, this modulation will help them a much better thing. Obviously bladder diary we discussed, and this is one of the least common or the most commonly misused physiotherapy. We all tell them we have to do pelvic floor muscle training, PFMT, but it's very difficult to assess whether the patient is following what we are trying to tell. If I'm going to have this finger and then tell them, okay, fold your thumb, she can do it and we can see it. Fold your little finger, we can see it. But if we tell them, okay, you tighten your pelvic floor, which she also doesn't know what is it, and we also can't see what she's doing. So this is one area where we tell, we share YouTube videos, we tell, okay, go see the physiotherapist, or tell our physiotherapist or our technicians to help them. But most of the time we tend to fail in assessing whether they have understood it or whether they're doing it properly. So that place has to be given more importance. Pelvic floor muscle training is of utmost importance for any form of urinary incontinence, and we have to give an ample time for it. 3 to 6 months of a well trained, well properly coordinated pelvic floor muscle training has to be done. And obviously we go and review the medicines as well as comorbid conditions. This is for everything. And now coming to the most common type, that is stress urinary incontinence. The first line management is obviously the conservative thing, where we go for weight reduction, PFMT for at least 3 months, provided somebody is overseeing it. It is a bit difficult. So we have pelvic floor muscle training teams in various cities, physiotherapists who are dedicated for pelvic floor physiotherapy, where they use biofeedback. In the sense, they use it's not as effective as the ECG electrodes, but they use some electrodes, skin electrodes, place that in the perineum near the vagina and the anal, the external anal thing, and they record it. They tell them, okay, now you compress it, you relax it. It is not very, very specific, but that is the best thing that we can get. The next best thing is having a needle electrode, which is very uncomfortable for the patient. So pelvic floor physiotherapy with biofeedback is something that we should all start suggesting our patients. And the other one is we have to look into if the patient is coughing, just look into the other problems, coughing, constipation. We make sure that we try and reduce any sudden increase in abdominal pressure. And this vaginal estrogen supplement is just to increase the tissue coaptation. In the continence mechanism, beyond the bladder neck and the sphincter complex, the urethral mucosa coapts, it just closes, and it has got a certain percentage of its importance in the continence mechanism. So after post-menopause, the dryness and shrinkage of these things will also have an effect. So for what it was worth, that vaginal estrogen can also be used for these patients. And pessaries, I'm not an expert on it, a urogynecologist would be the best, and I have not used pessary. If such conditions come, I refer my patients to urologist or gynecologist or urogynecologist. So this is the first line management of stress urinary incontinence. Now, if we understand that we have a proper diagnosis with stress urinary incontinence, we given all the medicines and all the pelvic floor training, and we made sure that they are okay. I mean, they're following everything, still they leak. Then comes the surgical management. It is done by the urogynecologist as well as the urologist. So there are things that we look in. First is the mid-urethral slings. And there are three things that you look into: mid-urethral sling, Bursch, Colpo suspension, autologous facial slings. That is first one. Let me just get into the details very briefly into these things. Then bulking agents, and last but not the least, artificial sphincters, be it for males or for women. We can use these, we can just go step by step. Now coming to this urethral slings, I just have a small video which probably will give a better idea. So this trans-obturator tape, this is commonly called as TOT, trans-obturator tape. There's also trans-vaginal tape. This animation has been borrowed from a lot of websites and YouTube's. I give credit where it is due. Here, what happens is that they make a small incision on the groin, and a tape is introduced from. There are a lot of ways to do it, but this is one common way where they introduce a tape through the perivaginal tissues on both the sides. We just keep it like a hammock. நம்ம பீச்சில் வந்து ரெண்டு தென்னை மரத்து நடுவில் கட்டுற ஒரு ஹேமக் மாதிரி, it just lifts it up, so it maintains the angulation over there. So across the globe, there is, especially in the developing countries, they don't want plastic inside their body. So such kind of people can go for autologous slings, where the rectus sheath is taken 10 centimeter by 2 centimeter, and then it is used as a thing. And Bursch Colpo suspension, it's out of vogue now because it is an intra-abdominal surgery where they use sutures to lift up the vaginal vault, but it is not used now because mid-urethral slings are much better. And for mild cases, we can use urethral bulking agents, where we put a camera through the urine pathway and just inject bulking agents. These are nothing but cross-linked polyacrylamides, where we put on all the sides so that the urethra, especially urethral mucosa, coapts, so that they don't leak much. So these are the common things that they can use. But if nothing is working, or if the patient has got some severe neurological difficulty, this is a male model. This is a common model called, this device is called AMS 800, Boston Scientific, where they, so I can't see the thing. So the cuff is put across the bulbar urethra, and there is a pump, and which activates. When they put it and activate the pump, for 2 minutes the sphincter relaxes, where the patient can void, and after that, after 2 minutes, automatically it restores the pressure. So this is what it is. Now that's for the stress urinary incontinence. Urge urinary incontinence is basically a medical management, where we do all the primary things that we spoke about, and then we go for we go for all this physiotherapy, urgency suppression techniques, reducing bladder irritants and all this. And coming to the medication, so these are common medications that we use. Anti-muscarinics, sulfasalazine and tolterodine is most commonly used in adults, and oxybutynin in pediatric patients, and trospium. Trospium is a quaternary amine. It has very little blood-brain barrier crossing, so that they do not have the cognitive difficulties. So, and the other one most commonly used is mirabegron. Vebegron is better than mirabegron, but it is not introduced in India yet. And obviously vaginal estrogen. So these are the basic things that we treat for urge incontinence. But if the patient, again, if the patient is not responding despite of lifestyle modifications and medications, then there are the other couple of things that we can do. Tibial nerve stimulation, intravesical botulinum. So botulinum toxin, we all know that Botox is used for all this dermatological condition as well as when muscle spasm. It can also be used for overactive bladder. There's a very small video for that. So intravesical Botox injection, where we take Botox and we give 100 units of Botox in 20 different places. So what it does is it kind of reduces the overactivity of the patient. So Botox, as we all know, the effect lasts from 6 months to 18 months, the average being 9 months. So now here, if the patient, we split 5 on the lateral wall, right, 5 on the lateral wall on the right, 5 on the posterior wall, 5 on the dome. This is what we give, and generally the outcomes are good, but also depends on the severity. If the medicines are not working, we can keep it as an additive. But we also have to understand that if the patient goes for hypotonicity, then that will also recover in 8 to 9 months.
Release. Dysfunction of the sensory and motor pathways alters the checks and...
So that is sacral neuromodulation. So sacral neuromodulation is basically a device where we keep a tin lead in the S2, S3, S4 foramen, which it modulates. To put it in a very simple perspective, it's like the fan's regulator. If you want the fan to run a bit fast, we can just keep it a bit faster, and if you want to reduce the speed, you can reduce it. So sacral neuromodulation modulates the signal from the bladder to the spinal cord and the brain, and in such way it reduces the overactive signals. It works wonderfully for OAB in neurogenic elements, especially multiple sclerosis and Parkinson's and all this, which is not responding to conventional medicines. And when it comes to mixed urinary incontinence, we have to clearly sit and speak with the patient which bothers you the most, whether it is the cough and the leak part, or whether you have to rush to the restroom but you still leak this part. So we have to see, and then we have to treat which bothers the patient most. All right, so this, I'll finish with this slide, just 2 minutes. When this is one of my favorite slides. What is the urodynamics? When a lot of general practitioners, gynecologists, and other specialists ask, why do you need a urodynamics? So you have an ultrasound. I've done an ultrasound. I know what is a prostate size. I have a CT. I have an MRI. I have all these things. So why I need a ultrasound? So urodynamics. So this is the thing I always tell. Let me tell a story. In this situation, it is 2 stories. So this is one sumo wrestler. If I ask a question to the honored members, so they will say, who is going to win? Obviously, the fat guy is going to win. But if I ask these 2 people to play a game of chess, who is going to win? So that is anybody's game. The kid can win, he can win. Likewise, this is the first part. So we don't know what is the functional ability. We know what is the physical ability. We don't know what is the functional ability. Let's say there's a bladder, there's a prostate. Whether the bladder is compressing as it's supposed to be, we don't know. So that is first. The second one is, let's imagine we are sitting in a village and we are sitting, suddenly the water stops. So the first common thing that we'll go and do is, we go to the motor room to see whether there is electricity or whether the motor is functioning properly. And if it is functioning properly, we'll go back to the pipes and check whether the water is flowing unblocked. That's the same thing that we do. When the urine stops, we have to go back and see whether the bladder is functioning properly. If the bladder is functioning properly, we have to see whether the sphincter and the urethra are functioning okay. So this is one thing that will give you numerous data for treating whether it is urge urinary incontinence, overactive bladder, underactive bladder, she's leaking because of the urge component, whether she's leaking because she's full, she's not able to compress. All the details will be here. So, so with respect to the investigations, when we have a stress urinary incontinence, urge urinary incontinence, mixed urinary incontinence, we kind of do the lifestyle modification and approach them with the proper medicines, and if it's not working, these are the surgical options that we can choose. Thank you so much for the opportunity. I hope that it was useful for everybody. Thank you so much, sir.
Thank you, sir. Thank you.
I'm sorry, sir. I didn't know that it would go this long.
Yeah, it was very useful for the audience.
Thank you. Thank you.
It was very exhaustive session, as we mentioned.
I understand.
It started with the symptoms and how to approach the patient, and then how to treat.
Yes, sir.
The main thing, one of the message which will be for the general public whom we treat, 5 C's we tell: the decrease carbonated beverages, decrease caffeine, decrease cortisol, stress you
Yes,
mentioned,
sir.
74%.
That is very vast, sir. I couldn't touch on everything.
Decrease cortisol, decrease caffeine, and decrease calorie, especially for overweight. So calorie intake. We tell that 5 C's will be taught regarding the urinary incontinence. Question and session we will discuss after the other speaker ends.
Sure, sir.
So it was a wonderful presentation, sir.
Thank you, sir. Thank you, sir.
So our next topic is going to be on abdominal pain. So the session itself is very interesting. First we started with anaphylaxis. All these 3 topics are which we commonly see in clinic, but we will not be able to approach properly. So that's what we are discussing. So now we'll introduce the speaker, Dr. Vishnu Abhishek Raju, cardiologist, senior consultant, gastroenterologist. Sir is from Apollo Grims, and Sir has completed his MD Internal Medicine in Salem, Kasturibai Medical College. Anyway, it is being displayed. And again, Sir is going to speak on a very interesting topic which we see day to day in clinical practice. Sir is going to discuss on abdominal pain. So where we have differential diagnosis. So the main thing is we have to be knowing which abdominal pain we are going to treat. That is very, very interesting. I think that Sir will be alluding on the differential diagnosis of abdominal pain and how to approach the acute as well as chronic abdominal pain. Back to you, sir. The medical gastroenterologist, sir.
Thank the organizers for the opportunity. Let me see, we can talk about only the approach. I'm supposed to finish off in a short time. So let's keep it more practical, and if and when anybody has any interesting doubt or anything about the newer things, you can always interrupt me. I'll try to keep it very clinical and simple. So this is the overview. If there is an unstable patient, there is no time for evaluating. Do a point of care emergency ultrasound and treat. Otherwise, if the patient has all the stability, then go for history, physicals, radiological diagnosis, labs, and then comes the clinical acumen to properly diagnose an abdominal pain case. History, you can organize the type of pain based on location, whether it is acute or chronic, and the type of pain. If a pain is very sudden, say the patient comes to you, very sudden onset pain, it is most often coming in these 3 categories. Either it is vascular insufficiency, a vessel is blocked or something, or a vessel has ruptured, or there is an obstruction or perforation, either obstruction of a viscus or a perforation of viscus. All these things present very suddenly. Subacute can be either an infection or an inflammation. A slow TB abdomen, an inflammatory bowel disease can present with a very small ring subacute pain. A chronic thing can actually be a cancer, a tumor, or again a vascular insufficiency, chronic mesenteric ischemia. And again, functional pain can also be going on for months together. This is how we can characterize the pain. As I was saying, when the patient is writhing in pain, very severe pain, they may not give you any history. So when the patient is in severe pain, the approach is always give the painkiller first, make the patient pain free, only then we can proceed at all. So that was the first slide. Sorry. So as I said, unstable patient, always do the point of care ultrasound as an emergency. Then a stable patient, do the rest. Location, acute versus chronic, and type of pain. If it is sudden, vascular, obstruction or perforation. Chronic means either infection, inflammation or tumor, and it can also be functional pain. And any subacute pain is usually kind of infection or inflammation. So when we talk about pain, divide the abdomen into 9 quadrants, we say. Basically all the pain when the patient present to you, it's either in the 4 quadrants, and when they tell the pain, it's either in the epigastrium, around the umbilicus or hypogastrium. Now why this epigastric pain around the umbilicus or hypogastric is important is almost all the pain will localize in either one of these things based on the visceral origin. No visceral pain will exactly come on the point. For example, a gallbladder pain is not going to present to you in the right upper quadrant all the time. Likewise, an appendicitis pain is also not going to present to you in the right lower quadrant all the time. A peptic ulcer not in the left upper quadrant all the time. It is based on the visceral supply. So epigastric pain will be arising from any of the organs arising from the foregut. A periumbilical pain will be from any of the organs arising from the midgut, and hypogastric pain, a suprapubic pain, will be any of the organs arising from the hindgut. If you know what are the organs arising from the foregut, midgut or hindgut, based on the sympathetic nerve supply, we can tell the origin of pain. Look at that diagram. A foregut, say liver, gallbladder, pancreas, stomach, spleen, everything arises from the foregut. It is supplied by greatest splanchnic nerve T5 to T9. So obviously any inflammation which is arising from these viscera, the visceral pain will be felt in the epigastrium. If small bowel below the level of ampulla of Vater, jejunum, ileum, appendix, cecum, ascending colon, right 1/3 of transverse colon, these are all midgut. Any of these visceral pain will be felt around the umbilical region, not exactly here and there localizing. Beyond the transverse colon, everything is in the hindgut. Now, when the visceral pain has its pathology spreading around, coming to the serosa, touching the parietal peritoneum, that's when you can localize the pain. So that's why an appendix which is felt in the umbilical region, the pain felt in the umbilical region, as the appendix inflames, touches the parietal peritoneum, that's when the pain shifts from the periumbilical region to the right lower quadrant. So never get confused about the organ of origin. And a transverse colon pain is not going to present in the epigastrium, it is going to only be presenting in the hypogastric region. So a sympathetic supply of the hindgut is T11 to L2 nerve. So wherever that nerve is supplying, there only you can feel the pain. And what about the vagus nerve or the parasympathetic? Parasympathetics are not the pain nerves, parasympathetics are the reaction nerves. When the patient has pain, the vagus nerve reacts in the form of tachycardia, sweating, BP, low drop in the BP, rise in the BP and all those stuff. Now, based on the quadrant of pain, 9 quadrant, you can put various pathologies on that. An epigastric pain can be a peptic ulcer disease or pancreatitis, which is the most common. A right upper quadrant pain which is progressive can be cholecystitis, can be gallstone cholangitis and all those things. A left upper quadrant usually is a splenic injury or a pyelonephritis and stuff. A periumbilical pain can be anything, especially abdominal aorta aneurysm is very, very important, and gastroenteritis or a perforation of viscus is very important. And a kidney pain usually comes in the flanks. A right lower quadrant pain can be typhlitis or appendicitis or ovarian torsion, and a left lower quadrant can again be a ovarian torsion. Any hypogastric pain can be a fibroid pain or a uterine pathology. Now, are these the only organs? Based on this, can we just say that, okay, this pain is coming from this organ? Unfortunately, we cannot do that because we have referral of pain. For example, a peptic ulcer pain or a pancreatitis pain can be felt in the periumbilical region or either of the flanks again. That is the confusing part. An appendicitis pain usually is felt in the periumbilical and goes to a right iliac fossa. Any pelvic pain, for example a torsion, a fibroid, all those things can be felt on either side of the flanks, right iliac fossa or left iliac fossa. And a diverticulitis, if you feel like a sigmoid diverticulitis is there in the left iliac fossa, that's where sigmoid colon is there, we may be wrong because the pain may actually be felt very much top on the left upper quadrant. That sometimes confuses us. So we should be aware of where the pain can get referred. Example, a cardiac pain can be, or say an MI or a pneumonia can be referred to the epigastrium, right? Likewise, we have a lot of patients with peptic ulcer disease and esophagitis having arm pain, jaw pain and shoulder pain. And gallbladder pain can be the scapula and shoulder. An acute abdomen is usually a couple of weeks pain. It is usually days or hours old, and we should not forget about a chronically persisting pain suddenly having acute exacerbation. So there can actually be a malignancy or something sitting which can present to us with an acute exacerbation. Immediate medical attention is required to differentiate between surgical or non-surgical. Our job sitting in the clinic or an outpatient department or an emergency triage room is to say whether that patient requires an emergency surgery or can be managed conservatively and whether we can keep on going for evaluation. These are the possible causes of sudden onset severe abdominal pain one should never forget. Aortic dissection, high mortality, every hour the mortality exponentially increases, we should never miss. Intra-abdominal hemorrhage, whenever the patient has intra-abdominal hemorrhage and you ask the patient to take a deep breath, there will be a shoulder pain, okay? And ischemia of a hollow organ, acute mesenteric ischemia, that is again a medical emergency. Obstruction of either of the viscus, either a hollow viscus like a ureter or a bile duct, again is an emergency. Perforation of hollow viscus, they also present very sudden. Rupture of an aorta. So all these things coming under 3 categories: obstruction, perforation, vascular problem. These three things are the causes of sudden onset abdominal pain, which always requires emergency medical attention. We should never miss. A chronic abdominal pain smolders over years and months. It's not life-threatening. Outpatient workup can be slowly done based on the localization and characterization. So what is the difference between a visceral pain and a parietal pain? We all know that when the pain is very vague, no? When the patient is not able to exactly tell, and that's usually a visceral pain. What causes a visceral pain? Visceral pain originates from the inside of the gut. Either the mucosa or the visceral peritoneum is inflamed. The parietal peritoneum or the fat area is not inflamed. And usually the nerve fibers which carry the pains are the unmyelinated C type of fibers. So localization is very, very, very poor. The patient will not be able to tell. It's a vague pain, diffuse and dull pain. The sensation is also somewhat dull aching. It won't be sharp stabbing or something. And the triggers are generally some inflammation, say for example peptic ulcer disease, gastritis, patient is taking some drugs, chemical induced. Those are the usual triggers. And patient's behavior is also somewhat restless. They won't be able to tell you what it is, so they'll keep on getting up and down, sitting, standing and all those things. So they'll keep on be writhing in the pain. They won't be able to localize. Whereas shift to parietal pain, the somatic pain, the nerves which are carrying the pains are myelinated A-type, delta-type fibers. The patient will be absolutely still because any movement, any type of movement will exactly trigger the pain. Peritonitis, it will trigger because the parietal peritoneum is being inflamed. That is the origin. The abdominal lining is being touched upon. So that's when the patient lies still. The sensation also very sharp, stabbing. The patient will be exactly able to give you the finger pointing sign. This is where the pain is. So that's how the trigger is always an infection, inflammation, tumor or irritation, whatever it is. And the patient's behavior is also lying still. And the character of based on the character, we can tell where the pain is. If the patient is lying still, peritonitis. If the patient is writhing, it can either be a biliary colic, intestinal obstruction or a renal colic. Whenever the patient takes a fatty meal, a biryani and all those things, puffs and all those things and comes and tell you after 2 hours I am having severe pain, it could be a biliary colic. Eating actually relieves the pain in duodenal ulcer. Remember, when there is a patient having duodenal ulcer, eating actually kind of shuts the area between stomach and the duodenum. So the ulcer is not irritated by any sort of acid. So there is a temporary pain relief for 2 hours. Eating worsens the pain in multiple reasons. Gastric ulcer, mesenteric ischemia, pancreatitis and all those things. So that's what we call the cytophobia, fear of seeing the food at all. It's called cytophobia. Examination wise, if the patient has a rigid abdomen, guarding and all those things, immediately go for a point of care ultrasound, no waste of time. If required, an ultrasound is not very good, go for emergency CT. If the vitals are unstable, again call in the surgeon immediately. If the vitals are stable, patient has no tachycardia, the patient is not having severe pain, sit and take a proper history and examine. Whether you want to know the patient's abdominal pain is from the abdomen wall or from inside, the important sign is Carnot sign. Okay, ask the patient to lift the head up. If the abdomen wall tightens and then you press the abdomen, if the pain still persists or worsens, it means the pathology is arising outside the abdominal organs. It's from the abdominal wall. If that is positive Carnot sign. If the Carnot sign is negative, like the patient tightens the abdomen and the pain goes away on your probing, it means the origin of pain is inside the abdominal wall. The abdominal wall is protecting the organs. Okay, that's Carnot sign. For example, in this clinical study, a patient presents to you with an acute abdomen pain around the umbilicus, then it goes to the right iliac fossa. The patient is sweating a lot. On examination, the patient has got tachycardia, fever, and rebound tenderness and all those things. Then you go and see what are the signs, other signs you are seeing. McBurney's tenderness positive, rousing sign positive, obturator signs positive, psoas sign positive. Then you go and do the lab, suspecting acute appendicitis and having some other DDs in mind all the time, always having some DDs in mind like Meckel's diverticulitis, cecal diverticulitis, kidney stones, ovarian torsion and all those things. Then you go and keep the patient in NBM, start IV fluids, give painkillers, send it for imaging either CT or ultrasound, you clinch the diagnosis. But always whether to go through that pathway, everything depends on your history and physical examination. That will never be gone. So this is McBurney's point. From the anterior superior iliac spine, right 1/3, medial 2/3. That area if we press, that is McBurney's tenderness. Most common signs seen in acute appendicitis. What other signs are seen? Always clinical exam should never be forgotten. This is rousing sign. See, left iliac fossa you keep the pressure and appendix gets the pain. Why? The transmission of the gas into the colonic contents transmits the pressure to the appendix, pain arises. So left iliac fossa pressure, pain is elicited in the right iliac fossa. That is rousing sign. Anything else you can say? Obturator sign. Flex the right leg, internally rotate the knee and put the leg outwards. Obturator muscle is stretched. A retrocecal appendix will be, an inflamed retrocecal appendix will be irritated and pain will be worsening in obturator sign. In psoas sign, put the patient left lateral, flex, hyperextend the hips like this. that will extend the psoas and it will compress upon the inflamed retrocecal appendix, pain will be worsening. In a patient where you don't have abdominal signs, McBurney's point tenderness is not there, still you feel appendicitis because of retrocecal appendicitis, you do those two signs like obturator or psoas, you will be able to pick up an appendicitis. What is Dunphy's sign? Ask the patient to cough. While coughing, if the patient feels a pain in the right iliac fossa, again, acute appendicitis. This is Aaron's sign. Press on right iliac fossa, feel the pain on the epigastric region, then again, it's an acute appendicitis. It's called an Aaron's sign. It's usually seen in chronic appendicitis. Okay? And this is Bloomberg's sign. Bloomberg's sign is seen in so many conditions, not only appendicitis, like if you tap on the patient's abdomen or give a firm compression and take your hands off release. That's called rebound tenderness. What does that tell us? It means there is an inflamed viscous, an inflamed viscera which is touching the parietal peritoneum. We are compressing the visceral organ and releasing the parietal peritoneum. The disturbance on the parietal peritoneum gives a sharp pain. That is rebound tenderness. It can be seen in pancreatitis also. It can be seen in appendix, ovarian torsion, anywhere. It means that's a significant pathology. Whenever there is a rebound tenderness, patient has got a severe problem lying inside the abdomen. Do not ignore. Do an imaging, either ultrasound or a CT. This is cholecystitis sign. This is how originally Murphy's described it. This is the exact picture. Patient is asked to sit. Murphy stood behind the patient, hooked the fingers below the right costal margin, asked the patient to take a deep breath. If the patient is not able to take a deep breath, if there is a catch in the breath, that means there is an inflamed gallbladder which is hitting the finger. That is typical for cholecystitis. Now remember, in spite of a negative Murphy sign, a cholecystitis can still not be ruled out. It's always requiring imaging and further clinical signs. Okay? This sign around an ecchymotic patch around the umbilicus is called Cullen's sign, and around the flanks it's called Gray Turner sign. Where do you see this? You see this Cullen's sign and Gray Turner sign if there is an intraperitoneal visceral hemorrhage or a retroperitoneal hemorrhage, most commonly seen in a severe acute pancreatitis. Of course, there are other areas also where you can see like a trauma, ruptured ectopic pregnancy, ruptured abdominal aorta aneurysm and all those things. Now, if you see a Cullen sign and a Gray Turner sign because of hemorrhage, look for other signs also which can happen in pancreatitis. Say, for example, there is always a visceral fat inflammation in pancreatitis. Okay, visceral paniculitis we call. So you can get all the pancreatic paniculitis on the arms. You can have this Fox sign in the inguinal ligament, and the scrotum. Everything can go for ecchymosis called Bryant's sign. So these are the other signs which you can see in pancreatitis. So based on the examination, you are given one choice. Now you go to the emergency room and the ER guys will ask you, doctor, which test do you want? You want an ultrasound or you want a CT abdomen? Emergency point of care ultrasound abdomen, where you think is a focused pathology, you can still ask for it because an ultrasound abdomen gives you a very quick diagnosis, and if there are no cholecystitis or appendicitis, you can actually send the patient home. It has been shown to be very, very useful. But if the ultrasound machine is not good and if you don't trust it, then you can shift to a CT abdomen, probably a contrast CT abdomen all the time. Ask the patient to get an ABG done. ABG value itself will give you a creatinine value. If the creatinine is normal, always getting a contrast CT abdomen gives much more added value than giving a plain CT abdomen. If you suspect a viscous perforation or an obstruction, do not give oral contrast. Always keep the patient NBM if there is a suspicion of even mesenteric ischemia or perforation, because we do not know when the patient is going to go for surgery. Also, anything which is put in the mouth can actually worsen the pathology. So always keep a patient NBM. These are X-ray signs. Many a times we are reliant on X-ray abdomen which is ordered in a clinic. We always do not send the patient for ultrasound. We always have a next to some X-ray will be available. So always it's better to know some X-ray signs, named signs, so that you can diagnose all these emergencies very easily. The first thing is Wriggler sign. I don't have a pointer. Okay. Yeah, this is a Wriggler sign. Generally, you see gas shadows inside the bowel, correct? If you see gas shadows on either side of the bowel, outlining the bowel wall, that's called a Wriggler sign. Where do you see it? It's a case of perforation. This is pneumoperitoneum, an X-ray abdomen taken in a supine view. That's called a Wriggler sign. Now here, that's called a thumb imprint sign. It's like almost like a kainata madri. Some thumb is taken and it's kept on that bowel wall. This is seen in ischemia. This is seen in bowel ischemia. This is a sigmoid volvulus, bent inner tube sign or a coffee bean appearance. When you have a patient with severe abdominal pain who has not passed stools, you order an X-ray abdomen, you see such a huge dilated colonic thing which is bent like this, like a coffee bean, that is a sigmoid volvulus. This again, it's an emergency, but it can be dealt with immediately by just doing a PR or putting a deep flatus tube or inserting a sigmoidoscopy, and decompression also can immediately relieve the pain. What is this sign? When you saw the regular sign, it is X-ray abdomen, supine view. This is X-ray abdomen, erect view. This is showing a crescent sign, air under the diaphragm, bilaterally. So that's a pneumoperitoneum, perforation of a viscus. Now this is perforation of a viscus, like say duodenum, ileum and all those things. Jejunum, ileum, all those things. What if there is a duodenal perforation? Will a duodenal perforation present like this? No. Duodenum is a retroperitoneal organ, the second part. So where you can see the air shadows will be seen around the kidneys. If you see a kidney outline in an X-ray abdomen, that means that's a retroperitoneal perforation, duodenal perforation. What is this sign? This is, you can see the large bowel shadow. This is small bowel, small bowel. What is the difference between small bowel and large bowel? A large bowel will have a hostile folds like this, picket fence appearance. A small bowel, the valvulae convolutus are stacked like this, stacked coin appearance. So in this one, this is the stacked coin appearance, whereas this is a picket fence appearance. This shadow is a large bowel, this underneath is a small bowel. And you can see that the large bowel is cut off. That is called colon cut off sign, most commonly seen in acute pancreatitis. It can also be seen in diverticulitis also. Why? Because the colon is not allowing any further peristaltic movement beyond this point. The gases has stopped there. It's an acute stop in the peristalsis. That's usually seen in pancreatitis. Now what is this sign? You can see multiple air fluid levels, correct? Whenever we see multiple air fluid levels, immediately in an erect X-ray abdomen, we say it's an obstruction. What I want you to notice, in case if this multiple air fluids levels are not seen, you have to concentrate on this small things. Can you see the small things? Small. That's called string of beads appearance, or a pearl necklace madri irko. String of bead appearance is also small bowel obstruction. Any small bowel obstruction, you know what to do? Call the surgeon, right? Ultrasound abdomen. We don't have to learn ultrasound abdomen all the time, but in case, God forbid, we need to diagnose at least two conditions, an acute appendicitis, a cholecystitis. An appendix is like this, a tubular organ with a muscle around, and the fat is all inflamed. Any fat, when we call inflamed, what do you call inflammation as? A white layer is a fat, and when it is hyperechogenic, it's called fat standing and inflammation. And that is the appendicular lumen, this is C curve. This is a gallbladder, okay? You see this structure light beyond which no shadows are passing through. An ultrasound passes the shadows. It touches this area beyond which it's all black. This is called acoustic shadow, and it is cast by a stone. A gallbladder has a stone, and there is pericolic collection. If you measure this wall thickness, it will be more than 4 mm. That's a classical case of acute cholecystitis. Even if you don't know, somebody comes and produces an ultrasound abdomen, reports to you, sir, gallbladder stone, whether we should operate or not. See whether cholecystitis is there or not. Whether there is pericolic inflammation and collection, no means no. Don't send the patient rushing for surgery, always get a second opinion. And what are the labs? Once we identified all this imaging, we still have not identified what the diagnosis is. Probably are going to send it for either a triple phase contrast CT abdomen with oral contrast and rectal contrast, or an MRI abdomen. Beyond which, that's all like which is better, MRI is better, CT is better. Actually speaking, it depends on the center where you are practicing. If your radiologist is not trained in MRI, he will do a complementary CT along with an MRI also. I think many of you have undergone that. You will send it for an MRI abdomen, they will do a complementary CT just because they are not able to exactly tell what the pathology is in the MRI. But MRI abdomen is actually good. And these are the labs. Why should we do all CBC, PCV? In an abdominal pain because of dehydration, if the hematocrit goes up, the pain worsens, it will lead to complications. Okay? That means it's a severe case. And if the C-reactive protein is elevated, it means there is inflammation. Amylase, lipase. Will you do both amylase, lipase for an acute abdomen? Say the patient presents to you with 2 hours of pain. Amylase or lipase? Amylase rises as early as 2 hours, peaks by 12 hours. Okay? Whereas a lipase will rise by 12 hours, peaks by 3 days, and it comes down by 10 days. So if the patient is short of money, do amylase first. If the patient has come to you after 1 day of pain, do amylase and lipase both. Whereas if the patient comes very early, money is less, just do one test, means only amylase, because lipase will not go up in that condition. Also, one more specific thing is, amylase is more for gallstone, lipase is more for alcoholic pancreatitis. Lactate, why should we need lactate? In a case of mesenteric ischemia, the lactate goes up. Either you can get a venous lactate or an ABG. When you see this lactate level very high, it means the patient is suffering from ischemia inside the body, very sick. Better admit the patient, keep the patient NBM, start IV fluids, call in the surgeon, and arrange for further higher imaging or either for emergency laparoscopy. Creatinine is very important always because CKD patient suddenly can present to you with an acute abdomen because of exacerbation. So creatinine is the reason for doing that is that not only because we have to do an imaging like a CT, that is one of the reasons. LFT, whenever there is an acute hepatic necrosis, say toxin, poison intake, anything, any for that matter, can also present with acute abdomen. So always do an LFT as well. CKMB and troponin, why am I looking for cardiac markers? You will not believe in my OP, many of the elderly patients coming with some sort of abdominal pain, the first thing I do is not ultrasound abdomen, please get a ECG, CKMB and troponin. First rule out an MI, acute coronary syndrome, only then evaluate for an abdomen because heart takes the precedent, not the abdomen. And beta HCG in a young female coming to you, because why? It can be a ruptured ectopic pregnancy, so be careful. So these are the special considerations. Very young patient, no? How much time I have? 8 minutes. Okay. Very young patient, appendicitis or trauma and secondary to abuse, all those things they can present with pain. And pelvic inflammatory disease, Meckel's diverticulitis, cystitis, enteritis, IBD, these are all seen in very young patients. And when a woman presents with a chronic abdominal pain, never forget about endometriosis because that's sort of a debilitating sort of illness. Very old can present. Say an elderly patient can actually come to your OP and sit and silently, but actually can be harboring a very severe problem like an obstruction or a perforation because they will tell also less, the signs are also very less. You don't have such a great immune power in a very elderly patient to mount such an immune response so that they will be writhing in pain or some sort of serious signs will be there in the body. So always take them very seriously. Women, pregnancy test, beta HCG, pelvic exam, and point of care ultrasound, pelvic scan, all those things are essential. Why? A ruptured ectopic, ovarian torsion, pelvic inflammatory disease are all common. This is what you have to keep in mind for women. Elderly, as I told, the signs are less. Heart takes the precedence. Pneumonia and MI can present as abdominal pain. Aortic dissection to be ruled out. Now, what about chronic abdominal pain? One thing which you want to know is a chronic mesenteric ischemia can present as a smoldering form of abdominal pain. A good quality, high perfusion, triple phase CT will pick up the ischemic findings like thumb imprinting sign, hypoperfusion, mesenteric fat standing, creepy mesentery and all those stuff. So, high index of suspicion is important. When do you suspect this kind of mesenteric ischemia? Postprandial pain. Immediately after eating, up to 2 hours, the patient will be feeling the pain. They'll have cytophobia. They won't feel like eating at all. The weight would have lost. There will be sometimes nausea and diarrhea also. The diagnosis depends on higher imaging and treatment option depends on blood thinners, medications. Rarely we send the patient for angioplasty or reconstruction of vessels. What about metabolic causes of pain? Sickle cell, the last 2 slides. So we can, whoever is feeling sleepy can, last 2 slides. Metabolic causes of pain is sickle cell crisis, diabetic ketoacidosis and porphyrias can present to us with severe abdominal pain. I have seen very less cases of porphyria in my life. I don't see here much often, only 2-3 cases I have seen. And diabetic ketoacidosis presenting to us as pain is the most common cause of pain which we see in OP. Any elderly, high uncontrolled sugars, the ketone buildup will present with severe abdominal pain. Sickle cell crisis, every test you do, everything will be negative. And even the hemoglobin sometimes won't give you such a big clue, but the crisis is so severe, only on the 2nd or 3rd day we even pick up the case that it is a sickle cell crisis. So do not miss it. Try to look for the Menzer's index, try to look at the subtle signs of hematological things, try to get a good perfusion CT and see for splenic infarcts, all those things. After all these things, there is something called where there is no diagnosis at all. You will write like either IBS or functional pain or somatoform disorder. It could be because that we are not addressing certain kind. This is the last line. Anterior abdominal wall nerve entrapment syndrome. The cutaneous nerve getting entrapped in an abdominal wall can present to you with a very sharp pain. The patient will tell, "Inge valichite irukudana ella scanner negative irukku, this pain. And you give some painkillers, it will go away." For them, what we do is we give a tab block. Transverse abdominis block with an anesthetist, we give a lignocaine block, the pain will go away because we are blocking that nerve and it will go away. When you are blocking a parietal wall nerve and it goes away, that's an anterior abdominal wall nerve entrapment syndrome. That is one diagnosis. Another common diagnosis we can come across is abdominal migraine. Especially in children it's common, but I'm telling you in adults also it's quite common. Patients who are not sleeping well, not taking care of their lifestyle well, they do have this nausea, vomiting, abdominal pain. When you see them, they appear pale sometimes. It will be a very severe colicky pain, then it goes away. Then it won't come for a certain time. Then when they have exams or when they are going to have some interview or when they are going through some personal stress with husband or wife, then again they will have this severe pain with vomiting and everything, then they will come back to you. You put them on propranolol for almost 3 months, in those 3 months the pain will not be there at all. That is abdominal migraine for you. All the tests also will become negative because this is because of the vasospasm and intestinal spasm.
And usually it's the stress, dietary factors, sleep, motion sickness, and bright lights like a phobia, phonophobia, and photophobia will be there for this. So this is my gist about an abdominal pain, which I could tell you in less than 30 minutes. Open for discussion if you have any doubts. I still have 4 minutes, I think.
Thank you, Dr. Vishnu, for the wonderful and elegant talk and greater clinical insights on pain abdomen. So we begin the schedule, Vishnu, and we are time constrained, close the session. Okay. Thank you. Over to host.
With that, we have come to the end of the third session for today. I thank all the chairpersons and the speakers for their insightful and interesting presentations. Now we move on to the final session of today's conference. So to introduce the final set of speakers, I now call upon Professor Dr. Venkata Krishnan, Professor of Medicine, Srihar, Chennai, Senior Consultant Physician and Diabetologist, SIMS Hospital, Chennai, and Dr. J. Ganesh Muruganandam, MD, Consultant Physician and Diabetologist, Nalam Diabetes Center and GG Hospital, Chennai. Please put your hands together and welcome the chairpersons so that they could introduce the speakers. Over to you, sirs.
Good evening, dear D-Club members. So this session would be done by Dr. D. Suresh Kumar, sir, MD, FNB, Infectious Disease. Welcome you, sir. We give a big hand for him. Thank you, sir. And our secretary, sir, will be honoring the speaker. He's a senior consultant in infectious disease, Apollo Hospitals, co-founder of Best of the IDs, 28 years of experience, so much of award and accolades, 40 papers to his name. Over to you, sir.
Thank you, sir. I sincerely thank the organizers for giving this opportunity, and particularly all the chairpersons I know very well, and I know the organizers also well for giving this opportunity. They asked to talk about both HIV, hepatitis B, and dog bite, all in 45 minutes there. This is very tough job, and the last part, so I talk my initial part, that is HIV, then followed by dog bite, hepatitis B we can answer, because my previous speaker also wrote about abdominal pain there. So this is my alma mater, I can call. This is where my HIV I learned there. So this is called the Government Hospital of Thoracic Medicines. Everybody who worked in the thoracic medicine, Tambaram, they know this is a famous ward called ward number 28, where in 2004 when I learned my HIV, all beds were flooding with HIV cases. Each bed is occupied by 3 patients. Almost all opportunistic infections, I learned my medicine, because previously people used to say, when you know syphilis, you know the medicines. Then people came and, AIDS, you know the medicines. Now COVID, we know medicines. The changing happening there. So in 2004, when I learned the medicine through this HIV AIDS Centurium, so this is my disclosure here. I'll begin because this is a 4 o'clock. I know which one is befit. I want to put, because this is a DC club, I want to put whether managing diabetes is easy or whether managing HIV is easy. Which one you consider? How many say diabetes? Leave the COVID part. COVID is gone. How many say that managing diabetes is easiest thing? Nobody? All up. Pre-prandial. Some tea, coffee needed. How many say HIV is easy? I can say HIV is easiest one. The diabetes keep on, you have got all semaglutides and companies are withdrawing it. A lot of issues is going around there. That's none of the company molecule is withdrawing here. So it's easiest to manage. I'll show why it's easiest to manage compared to diabetes here. So even though more people affected, but off late number of people coming down. People are coming down less. So COVID is not over, but COVID still we are seeing cases right now. So my objective is when to suspect HIV in your practice, how to confirm the diagnosis here, what to start. I'll try to summarize and way forward. I'm going to put only case-based only there, because this is the last presentations. I know I don't want to bore with the theory right now. Again, I want people to interact, because I want to put it in a show, but unfortunately it was not happening. I shown here 4 cases here. Can you suspect which one is probable? Because HIV needs confirmations. We can't say this patient is HIV, whatever knowledge. The famous person in the Government Hospital of Thoracic Medicine, he say put the tongue out. This is a typical HIV tongue, Tambaram tongue they call, and they put HIV. That's a era gone. But we need to prove the HIV. Clinically, we can suspect, we need to prove it. This is a 26-year-old female, married for 4 years, planning for a pregnancy. Pap smear showed some abnormality. Can you think this person has got HIV positive? How many say possible? Nobody. 65 female, non-Hodgkin's lymphoma, no response to 6 cycles of chemotherapy, hysterectomy 20 years back. Can you think HIV here? Okay, yes, some son. 28-year-old male from Salem, sales executive, fever, sore throat, cervical node of only 1 week durations. Just 1 week. Because of Salem. 30-year-old male, no comorbidity, just herpes zoster. 1 episode. So, which one is all of the above? Usually in MCQs, all of the above, none of the above, always tempted. All of the above? Yes, okay. Okay, we'll come back. Previous history, when a person has got risk behavior, sexual behavior or risk behavior, we think the person has got HIV. Now the concept is slowly changing. These are all the indications. For example, recurrent bacterial infections, unexplained weight loss, infertility, unexplained lymphadenopathy, non-Hodgkin's lymphoma, CA cervix and CA lung. These are all AIDS-defining malignancy. Particularly non-Hodgkin's lymphoma, non-responding to 6 cycles of chemotherapy, we need to think. In fact, the person's husband was got very little fight. When the oncologist didn't know about non-Hodgkin's lymphoma, started chemotherapy. No response with 6 chemotherapy. 7th chemotherapy, he got some suspicions, he asked for it. Then he suddenly turned positive. The husband became too rude to the consultant. Who asked to do this test? I came for non-Hodgkin's lymphoma. Why you did the HIV test? This person didn't do any sexual activity. She underwent hysterectomy 20 years back and she got transfused with the blood that streamed or not, we do not know. That's why she got it probably. But the husband got rude. That's a problem we are encountering. Infectious mononucleosis, chronic hepatitis, fever of unknown origin, always think HIV. This is most important thing. Then how will you do the test? Anybody knows Pulli Raja ke H Surma, this campaign? So people who practiced in 2000, 2004, this is a famous campaign, Pulli Raja ke H Surma. So that's what, people who got, people who know a lot of sexual behavior or extramarital contacts, they will ask the thing, HIV will come or not. But previously we used to send the center called VCTC Center, Voluntary Testing and Counseling Center, now become Integrated Counseling and Testing Center. How many private hospitals got ICTC or VCTC Center? Any corporates? I don't think so. In my hospitals we don't have it. Then how are we going to do the test for HIV? That is most important thing. So this paper we wrote couple of years, not couple of years, couple of decades back. So what we did, this is in government Stanley hospitals, I did it. What I did is when a person comes to the hospital for some reason, because most of the patients got admitted, for some reasons, what we did is we are given an option to the patients. I do all the tests for what is required for you. In addition, I will do a HIV for you. If you are willing for it, if I give you an option to you, yes. That's called opting in. The person says, I don't want to do the test. Opt out means I don't want to do, we don't do the test. So opting in means we do the test. Out of 192 patients we did, people are opting in for the test. 4 were tested positive. They don't have any knowledge about HIV previously. So 4 new cases we find out by giving an opting out test to the patients. So that means the surgical package, people the surgeon wants to do, that gives a lot of HIV positivity. They can identify a lot of patients. That is similar to opting in or opting out. There is no need for ICTC. You just give the option whether you want to go for a test or not. If they go for a test, yes, we can do it. That's most important thing. That is option available right now. So that picks up almost 4 cases picked up and 4 patients puts on treatment. Why we want to test? Previously there is no treatment. When I started my practice in 2003, 2004, there is no treatment available. Only people used to use some Siddha treatment. Then came ART medicines. All my first 250 patients, the CD4 count was 0. Absolutely 0. We started almost all the opportunistic infections, cryptococcal meningitis, toxoplasma, everything we have seen, because after starting ART, all immune reconstitutions happen. But right now, 4 cases, if we start putting on ART, the risk of transmission to other people can cut down. That is the point of doing HIV testing. Because people do the HIV test and they said, I don't want to treat, go any other hospitals. Right now, good treatment is available, you can manage. We got almost 20 to 25,000 patients in our hospitals. We do CABG, we do bypass, we do replacements, we do transplants also. This is what we did for HIV patients. There is no stigma. In my patients comes to my OP, almost 20-25 patients sitting in our OP, 3 or 4 is HIV positive. Who is HIV positive, who is HIV negative? Even my secretary doesn't know. They can see, they can go out. That's what they're doing it in our hospital there. Okay, this is infertility. I told infertility is one of the indications for doing HIV test. This is a 41-year-old male and 36-year-old female from a respected family being investigated for infertility. After attending the lecture, the gynecologist went and did the HIV test for the persons. So what test you want to do for these patients? What test you want to do? How many say HIV ELISA is good? Otherwise, I got a rapid CAR test. I got a rapid CAR test in my clinic. HIV CMIA, clinical chemiluminescence assay. What do you want to do? Or Western blot, that's a confirmatory, straight away hit, or all of the above. So this is a test right now. So they did a test, I do not know, but HIV is negative. So sitting in the back, believe my words or believe the chairman's words, The HIV is non-reactive, all are non-reactive, sorry. So what are going to do now? Clear for infertility? All were negative. Okay? Clearance? Any, are you happy? Are you happy? Or you want to ask for a risk behavior? Or you want to clear for infertility? How many says choice one? Clear for infertility? Negative. Call the lab. I will call the lab. Why the call the lab? This is a problem. Within a month later, July 2017, test done, negative. August 2017, within a month later, all tests is positive by means of ELISA, by means of chemiluminescence assay, by means of rapid test. Whether a person got acute HIV within a month. Why I was not suspicious? This is why the problem. So what is the method? They did nothing. They said HIV. Antigen method, antibody method, rapid test, nothing is there. So that's why I said call the lab. That is why the very important thing is we need to do the test in a good quality lab. If you don't do in a good quality lab, this is going to happen to you. So the person did in July, but came back on August, all three is positive, all three is positive. So what are you going to do now? Postpone the infertility or postpone the plan for child? How many say this couple doesn't require child? In our populations of 20,000 odd patients, 500 odd couples are there, husband positive, wife negative, wife positive, husband negative. They have conceived, they delivered, none of the child has got HIV. So we prevented the HIV transmission, that's fine. So can you call this is an acute retroviral syndrome? In our practice, acute retroviral syndrome is very difficult to diagnose unless we got a strong suspicion. The case what I put, Salem, the person is a sales representative, staying away from the family, maybe doing the risk behavior. He got fever and cervical node. Possible acute retroviral syndrome, we need to think based upon the history. That is why in medicine, history taking is most important thing. The Salem history, travel history, staying away from the family, all give the clue. So don't say the person is living in Chennai. I want where he is living, whether with family or not, this is more important for me. This is what we need to do. But acute retroviral syndrome, the problem is HIV ELISA will not be negative. Only we need to do the viral load testing, but here the HIV testing is positive. So something is fishy. I'll come back to this case a bit later part of it. So acute retroviral syndrome, you need to have a strong suspicion. Unless you got a strong suspicion, very difficult to diagnose. Antibody is not going to help out. If you think acute HIV, do the HIV viral load. So this is a logic behind it. HIV viral load will go up, then go down immediately. That point of time, we can able to pick it up. Antibody will take some time to form, so don't do antibody to make a diagnosis of acute retroviral syndrome. So this is acute HIV, typical fever, person has got some cervical node, weakness, tiredness, typical acute viral fever. Any acute viral fever, if risk behavior is there, put your money on acute HIV. Similarly, mononucleosis-like illness, HIV is one of the differential diagnoses we can offer. So this person now what will you do? We know the person has got, the test is positive. So what will you do now? Whether you want to repeat the test in your lab or you want straight away want to treat the person. Viral load and CD4 count, look for other viruses too, or repeat the test at government hospitals. Whether you want to rely our lab, because the person, it's not our lab, this is also outside lab. So what are you going to do now? Repeat the test at government hospitals or confirm with Western blot. Confirm with the Western blot. A lot of noises I'm hearing. So those who wanted Western blot, can you interpret the Western blot? Western blot, I read out there for people sitting in the back because of the poor quality of the slide. So HP P31 is positive and person has got GP 160 is positive. Two antigens are positive. What do you call? The person has got HIV positive? Yes? That's a bit difficult to interpret the test. I voluntarily cut the paper till this part. I'll give back the back. So we need to have two envelope antigen, GP for GP1, person should have GP 160 and GP 120, both should be positive. Here GP 160 alone is positive. Similarly, two envelope antigen along with one protein antigen. It's a bit difficult to sort it out there. It's a bit difficult. Now I just given the thing, HIV is indeterminate. This is a full report. Whether this person has got HIV or HIV not there. So the bottom line why I am presenting this case, when the person tested positive for HIV, don't jump and say you got HIV. A lot of surgeons burn the finger. When they did the ELISA positive, the family come and fight with them. How come you tell I got HIV positive patients? So we need to always think it can. False positives can happen. So the problem is whatever lab, whatever hospitals, false positives can happen, keep in mind. So always a differential diagnosis of false positive, keep in mind. And HIV Western blot is an outdated test, we don't do it. It creates more confusion, providing solution to me there. where I use for Western blot to differentiate HIV1 and HIV2. Previously I do it, but nowadays I stopped doing HIV Western blot. That's what guidelines also. This is latest CDC guidelines. No mention about to do the Western blot. They need to do a good quality lab, ELISA or CMLA, chemiluminescence assay. If it is positive, we can figure out 1 or 2 by latest assays. The latest assays is called both antigen and antibody assay. We can able to differentiate it's positive or not. So the story not hence here. So the story repeated here. This is in Apollo. We did the test. The microbiology lab put equivocal. So the HIV positive means lot of other conditions. HTLV1 can cause the similar presentations. Sometimes for unknown reasons it remained. This person remained almost 6 months. We repeatedly tested. It remained equivocal. But if I did the viral load is not detected, not on ART. So this person has got false positive HIV. We finally cleared the person for infertility workup and finally conceived. They got child. The child is not infected. Every 6 months is doing still equivocal. So some patients are there equivocal still continuing on. So HIV is not that easy. Particularly interpreting test is most difficult part. Always tell if it is positive, try to confirm with other methods like viral load, or we need to check the ID-NAT method. ID-NAT is a qualitative method. Viral load is a quantitative method. Keep doing it. That's most important. Now the second part of HIV is, first part is a diagnostic part. I told Western blot is an outdated test. Do ELISA or CMLA. If it is positive, pre-test possibility is high, you can say. If you want to confirm with the viral load. That's the point I'm taught you now. The second part now is when to suspect opportunistic infection. This is HIV positive, confirm, no doubt about it. So what is ART here? What is opportunistic infection here? My chairperson hit the nail. PCP there. So why he said PCP? When the person has got typical ground glass opacity, more of perihilar involvement, peripheral sparing, HIV patients. What is the clue here? I want to know the CD4 count. And the CD4 count is less than 200, opportunistic infections are more. So to approach an opportunistic infections, we need to know the CD4 count. Viral load is very difficult to say. CD4 count. So if the person has got this one presentations, I need to know what is the CD4. If the CD4 count is more than 200, I can't put my diagnosis of PCP here. I put the diagnosis of the pulmonary edema or something else, I need to put it, not the PCP here. Since the patient has got CD4 count of less than 200, I need to put my diagnosis. That's why I put start code trimoxazole to the CD4 count. That's most important thing. So for opportunistic infection, CD4 count is very vital. That's the point I'm making here. So we need to know the stage of the patients. For example, when the person has got more CD4 count, no symptoms, usually after the HIV infections, one episode of viral, then they go for asymptomatic phase for 5 to 6 years. Sometimes it can go up to 7 years, sometimes go up to 2 years. That asymptomatic phase is very difficult. Then simpler symptoms, for example, oral candidiasis, some skin lesions, herpes zoster, this is called category B. Category C means age-defining illnesses, esophageal candidiasis. For a US person, pulmonary TB itself, age-defining. For India, it is extrapulmonary tuberculosis. I need to think about it. So this is what we need to do, the classification system. I'll show a couple of pictures. What is the diagnosis here? Anybody? I know it's a pre-prandial, pre-coffee time, I know. So the dictum is, sir, you need to ask what is the CD4 count. If the CD4 count is more than 200, this is molluscum contagiosum. The CD4 count is less than 200, cryptococcosis is possible. So all depends upon the CD4 count. It's not jumping. This is easiest one there. Herpes zoster. So when a person is a young individual without comorbid, for example, the person is less than 45 years, not a diabetic, not on immunosuppression. One of the case I put 30-year-old herpes zoster. Why the 30-year-old person get herpes zoster? So if the person has got herpes zoster, think about HIV. If the person has got multidermal herpes zoster, we need to think about it. Less than 45, no comorbid, herpes zoster, please ask HIV. That's one of the defining conditions. This is a wart, genital wart we can have. These are all called stage B or CDC-B stage there. These are all mild infections, papular pleuritic eruptions. This is out. This is oral candidiasis, typical. We can put the diagnosis immediately. If the person ask any steroids inhaler or any diabetic poorly controlled, we need to ask for HIV also. So this is a wasting. I never see this type of cases now. We are seeing the other end of spectrum, people are obese now. We are not seeing the wasting. The spectrum is completely changed now. And these are all the typical age-defining conditions. Toxoplasma, then person has got diarrhea means isospora, cyclospora, cryptosporidium. These are all the things I need to think about it. This is a beautiful isospora we can able to see, and toxoplasma and PCP I can show the thing. So these are all age-defining conditions. So once you make a diagnosis of HIV, the next step is what opportunistic infection is going to patient is suffer. That's most important thing. Don't jump. I saw a patient 1 week back. The CD4 count is 10. The person has got very high viral load. Immediately the person referred to me, doctor, can you start the ART? Can you start the ART? I said, ART not in a hurry. HIV is not going to kill the patients. Opportunistic infection is going to kill the patients. Without identifying the opportunistic infection, if you start ART, that kills. That's what happened to me in 2004. That point of time, for me, there is no ART. The person's CD4 count is 0. I can't wait. So I started ART. After starting ART, the people lose their vision. So many CME retinitis. We lost the life because of the cryptococcal iris. We lost the person CME. Almost all the opportunistic infections immediately jump back. That is why we said opportunistic infection, treat first. Don't jump and start ART immediately. Particularly if you think something on the brain, give some time. Treat the disease. Person recover, you can give the ART. That's most important thing. So these are all the basic workup we need to do. On CBC, on renal function test is more important. Viral load counting and CD4 counting. Look for other HIV. For example, hepatitis B, hepatitis C, syphilis, RPR, TPHA, and TB screening also mandatory nowadays. So the principle in HIV medicine, opportunistic infection is a killer. HIV is not a killer. So we need to treat the opportunistic infection first, then only touch the HIV. We can wait. Unless the CD4 count is 2. That's why the consultant who referred to me keep on jumping, sir, why don't we start one more opportunistic infection? Yes, at least 2 weeks of opportunistic infections, I justify to start antibiotic. So these are all the medicines. People worried, you said diabetes is easy to treat, HIV has got so many medicines. Why you said this is easiest thing to do. Don't get confused about these things. So we need to know, combine 3 different mechanisms. 3 different mechanisms I need to combine. So the 3 different mechanisms turn to be only one pill. It contained 2 NRTIs, tenofovir alphenamide, emtricitabine, along with dolutegravir. That's called integrase stand inhibitor. So we need to combine 2 antiviral depending upon the different sites, but all combined and come as a single pill. When I started my practice, I used to give 12 to 20 pills a day, but now it's only one pill. What is the cost of the pill? Hardly 30 rupees a day. Hardly 30 rupees a day. So per month it's 900 rupees. Once in 6 months. It's not a diabetes. Every month you need to check. You need to give insulin. Nothing. This is once in 6 months to once in a year test, along with 1 tablet a day. That is 900 rupees. Which one is easy to treat? HIV? It's easy to treat there. So don't get confused. This is what we need to do right now. So this is a combination we use. 1 NC, integrate stand inhibitor, along with 2 NRTIs. One is called bictegravir. We can use bictegravir or use dolutegravir, along with tenofovir with emtricitabine. All comes as a single pill. All comes as a single pill. That's more important. So the target, we need to reduce the viral load to be less than detected. That's most important thing. That's what we need to do. And CD4 count, we need to improve more than 200. Till the CD4 count crosses more than 200, cotrimoxazole prophylaxis is required. When the CD4 count is less than 50, we need to provide MAC, Mycobacterium avium cellular complex prophylaxis also needed. So this is most important thing. Can you solve this puzzle at 4:30 in the evening there? Housekeeping staff, after sustaining a needle stick injury, he came back to you and saying that the room where I clean and where I sustained the needle stick injury, the doctors are discussing HIV. He overheard your talks. The housekeeping staff is a smart guy. He said the doctors are discussing HIV, but the person declared dead and the person's body is removed also. He sustained a needle stick injury and bring the needle. This is a needle. When I cleaning the room, I got stuck. What will you do now? And you do the test, turn to be HIV positive. He bring the needle and he says, I got needle stick injury. The doctors were discussing. I was cleaning the room. I was overhearing HIV. I do not know what they're discussing, but they're talking about HIV. What will you do for this person? Counsel him or provide HIV care free of care throughout his stay in your hospitals. HIV one prophylaxis is tested positive, sir. He immediately came back and the nurse, ICN got panic and did the test. They turned positive. When he claimed the needle stick injury, that day is positive. So the bottom line is, again, chairpersons are nailing it. So when a person sustains needle stick injury, the first thing you need to do the baseline test. The baseline test indicates the person's past infection, because right now the incubation period is cut down. Even with the advanced test, it's 14 days. Even if you do ID-NAT, nucleic acid amplification test, 7 days. This person is smart enough, he is known HIV positive, he want to gain benefit from the hospitals, immediately he says, I sustain needle. That is why all the hospital staff sustain needle stick injury, they need to come and report. If they are not reporting, the blame is on them. Suppose the person reports, I do the baseline test, it is positive, I said, already positive. This is not going to be an incubation period short. It relieved. The ICN was panicked. The infection control nurse was panicked. Said the person turned positive. What we need to do? I said, do the baseline test. Baseline is positive. The person is positive. 4 weeks later, that is more important. 4 weeks later is more important. This is common scenario. These people won't sleep there. They go to Pattaya, do something and come back. Sir, this is 16th day, this is 38th day, this is 40th day. Google says HIV is still positive on 68th day. Google says 180 days also positive. They won't sleep you. Ideally, psychiatric counseling is needed for this type of people, but this is a huge market. So this type of people, post-exposure prophylaxis up to 72 days. So we need to know what is the risk. The source is positive, the risk is maximum. When the source is unknown, the risk is minimum. So we need to know what sort of source. Anal sex has got maximum risk compared to vaginal. The person who's doing a receptive sex has got more chance of picking up HIV. Receptive partner is more vulnerable compared to insertive partner. These things we need to remember. One fellow who did oral sex keep on coming and asking me, sir, this is 180 day, this is 160 day, he's keep on counting it there. That's chronic there. So we need to know blood transfusion maximum risk. Sexual risk is only 0.03. I can say 1 in 300 cases, chances of picking HIV is there. Not every case of needle stick injury, every case of sexual exposure are going to pick it up. And we need to know the timeline. 72 hours is a golden time. We start post-exposure prophylaxis, it will prevent you. Unless if you start late, it will not work you. What drug? The same drug. The same tenofovir alphenamide, emtricitabine along with dolutegravir you can give. The person taking the same medications, the viral load is not under control, I need to change the medications. The source person is not taking any medication, this is an ideal drug, we can use it. So this is what we need to know. The person is pregnant, for example, the nurse has got needle stick injury, they got panic. They are breastfeeding mothers also. The nurse may be a breastfeeding mother. So at that point of time, we try to avoid breastfeeding till we sort out the 4 weeks time. Ask them to take the medications, avoid the breastfeeding. That's most important thing. And similarly for a male partner, young people, they need to avoid sex or they need to use condom during the time. So this is what most important. Right now, this is other patients, 28-year-old male, ART and good control. So they want to conceive. I told my 500 people, HIV positive, all conceived. That time there is no pre-exposure prophylaxis also. All conceived with good congenital control. So U is equal to U. Undetected is equal to untransmitted. When the viral load is not detected, they can conceive. Because viral load detected, the chances of transmission to the fetus is high. When the viral load is not detected, they are not going to transmit the disease to the fetus. So don't say the person, I want to go for in vitro fertilization, so I want to wash your semen. Nothing, we are doing it. If your viral load is under control, you can go and conceive. Nowadays, we given options. Take pre-exposure prophylaxis. The wife negative, ask her to take the medications what same husband is taking. The husband is till the conception. Conceive is over, we can stop the medications. That's what we can do. 1 dose of tenofovir alphenamide will not affect the child. So that's what. Now pre-exposure prophylaxis in US is available. Long-acting injectable agents that works for 6 months. If you give 1 injection that protects you for 6 months, they can, in between time, they can pregnancy, they can have it also. People frequently going to Pattaya also, they take the injections. If you are a surgeon, you are going to sustain more needle stick injury, you can also take this pre-exposure prophylaxis, going to be launched in India soon there. This is a long-acting injectable agent. 1 shot will work for 6 months as a prophylaxis. Treatment, we do not know exactly how many months it will work. This is called the pre-exposure prophylaxis. People who got vulnerable behavior, yes, we can take it. This is a hot topic for next DCCON. I can talk about what pre-exposure prophylaxis we can provide. PEP is always difficult. Failure can happen post-exposure prophylaxis. Pre-exposure prophylaxis is a way forward. That's most important for you there. So this is another interesting stuff. 27-year-old male getting married next week. He got secondary syphilis, he got HIV. After the engagement is over, marriage is next week. What will you do now? Sorry, sir? Pre-test. But what is about whether you call the girl and say, cancel the marriage? Yes. Call off the wedding. What happened to this case? Initially, they called off the wedding. Then finally, they again remarried. And they have a child also without notice, without any transmission to the child. But later the child is born, they got divorced. That's other issue there. So that's a problem there. So this is ethical questions we can't difficult to solve. but we can say this is a very difficult ethical questions. The person should give the pros and cons. I give the family, both the family I invited, told the pros and cons. Initially they cancelled the marriage. Later they went again, some other new date they got and they got married. They got child also. After a child is born, again some issues, they got divorced. So previously, when the examiner asked the last question, to tell the answer, tell whether you are going to pass this exam or not exam, usually Dr. Paranaman will give a clue to you there. Say whether you are going to pass these exams or not. Asking the last question, what is the prognosis of rabies? Or what is the prognosis of these 4 diseases? If you ask, people say, my prognosis in exam is gone. I need to go and study for the next exams. That's what we need to do. This is 1981. But we are living in 2000 onwards, not 2004 onwards. Now this is a chronic manageable disease. Hypertension, diabetes, that's what people say, doctor, how long I live? One beautiful paper in Lancet answered the thing. The average age of the diagnosis of HIV is 30 years. If you start ART, they live 37 years. 30 plus 37 is 67 years. Average life expectancy is 63. So he lives more than the ordinary life expectancy. That's what we used to say. Your life is same. Not even one day will go down, provided you take the ART medications. So normal life expectancy, counsel the patients well. That's most important. Is there any cure? So far, 7 people have got cured, but how they got cured? They got blood cancer, they got chemotherapy, radiotherapy, they got a donor, the donor has got a mutation, that mutations prevented the HIV coming back. So to get cure of HIV, get blood cancer, get chemotherapy, radiotherapy, get a donor, the donor should have mutations. So that's why they're working on it, but unfortunately they got the principle, so they started the phase 1 trial soon, maybe in another 5 to 7 years. For example, HCV has got a cure. HIV has got a cure shortly in another 5 to 7 years. It's possible. Right now, a lot of research is going on. Possible there. So whatever I told, we wrote in a book called what is a step 1, what is a step 2, what are the things we need to do. This is called the ID algorithm. All the steps we have written, simplified your job. So this is a book there called ID algorithms. You can get it right now. What is a step 1, step 2, step 3? Not only for HIV, for all cases. Hepatitis B, same thing there. Only we need to give immunoglobulin for the post-exposure prophylaxis. HIV post-exposure prophylaxis with the tablets. This is HIV, we can give it there. So if you know HIV, whether your patient is going back with the same car, you can earn money there. That's what I'm telling it. Thanks for the wonderful opportunity. I take a couple of questions there before starting the other presentation.
Thank you very much, sir, for a wonderful presentation.
Thank you,
I think a lot of new points, and what all points are forgotten over years also you have cleared. And just by telling that you have got an injectable pre-exposure prophylaxis, which lasts for 6 years. This is really a new point, because we previously used to give only tablets. And of course, he was told about so many things like, you know,
which one, ma'am, sir, come again? If the wife is negative, they can, till the conceive, they can take the medications. Once the conception is conceived, pregnancy is confirmed, they can stop. But the lady can stop. The husband need to continue. After that, they need to go for a protected sex with the condom there. Till the conception, they can. But after the conception happen, why they need to go for unprotected sex? Even though it's safe, undetected is equal to untransmitted, but risk is 99.99, 0.001 is there. The person has to be continued. The person negative can stop the medications, because fetus can theoretically, but practically don't. Theoretically, yes.
So regarding the transmission, needle prick is more transmittive, or the sexual transmission is faster? Because 1.03 you said for a sexual transmission. For needle prick is 0.1.
Anal receptive sex is more risky compared to the needle stick injury. Particularly in the needle stick injury, I'll ask one question: who is most? The needle stick injury is more common with surgeons compared to physicians. But who is going to get HIV, surgeon or physician?
Physician. But surgeon always does the test before surgery.
The two things is there. So the point is, the surgeon always uses glove. They use a personal protective equipment. 1. 2, the surgeon uses a solid needle. The solid needle won't stuck. Whatever suturing needle is a solid needle. The physician uses a hollow bore needle, injecting needle, and the physician never uses glove for giving injections or something there. So the physician, even though getting needle stick injury is less, but the chances of picking HIV is more. Surgeon, the chances of needle stick injury is more, but picking HIV is less because of the glove, because of the solid needle. So this is a principle we need to know. Regarding your question, sir, anal receptive sex is more risky, then anal insertive sex, then vaginal receptive sex, vaginal, then only needle stick injury, sir.
Yes, yes.
I have never seen a needle stick injury positive patients, but couple of healthcare workers, they're positive. We really do not know some needle stick injury or not. But in my practice, after giving a post-exposure prophylaxis, none of them get transmitted the infection to me there. But after positive, they come back to me. How they got it, we do not know. But after the needle stick injury, they reported to us, given a post-exposure prophylaxis, none of them transmitted it. None of them got disease there.
Yes. So one of the point what you learned today is that whenever patient comes to fever, look for the cervical node. If it is positive, look just for HIV. Because acute viral syndrome, HIV syndrome may be detected by that. We can do a viral load, not the ELISA or of anti-serology test. That's a wonderful point. And also you told about the whenever you see suspect HIV, and in addition to the serology, you do always CD4 count. That will help you to whether opportunity infections are prone or not. So wonderful presentation, sir. Now we will go for the next presentation.
Finish it, sir.
Next, yes.
Thank you for that. Yeah, slides.
Sir, continue, sir. The next one.
I'll finish it, sir.
Dog bite.
Because last speaker is there, so I want to finish a little early. Can you have the slides, please? So this is a bite there. So I'm biting at 4:30 in the evening, I know. So I don't bite, so don't worry, you can sit here. This is a yearning of an ID doctor. The least yearning specialty is infectious diseases. We try to solve the problem, we don't make money. The person who make the money, like I hope no orthopedic surgeon is sitting here. So they make money by putting a lot of implants, but we solve the problem of implant-related infections and we don't make money there. So this is not, they asked to specifically talk about the dog bite, but a couple of principles I want to teach you. This person has went to Marina Beach for a walk, horse bitten her. That small kid managing the horse asked to bring for the horse for a ride. The lady said, but before that the horse bitten the lady. What will you do? Whether ARV is needed for a horse bite? How many say yes? Horse bite needs. A lot of people are active. That's good sign there. Very good. So yes. So India is common. Why we are talking this? Rabies is India. If you see any map, India is always red. Number of death, number of parts, almost except Goa, most of the places in India, the rabid dogs are surrounding, and every street has got 4 to 5 dogs, and every dog will chase you if you go by two-wheeler or by walk. Sometimes they're chasing right now. I'll come back. That's why we are discussing right now. So leave this part. So why I am discussing this is a reason. Last 1 week itself, all medical specialists, one of the general medicine specialists called me, my maid is bitten by a stray dog in the face. Can I give the rig in the face? How many say rig? Rabies immunoglobulin can be given in the face. Okay. This is an hematologist who is walking in a park. One dog came close to him, but he is not sure whether it's bitten, licked him, nothing. So whether we give prophylaxis to him? Okay. Because this is a hematologist. GP, I have consumed the milk of a cow that was bitten by a rabid dog that came to later. The cow died after 3 days or 4 days. He has taken the milk from the cow. It's a boiled milk. We want to give, but the animal was died of rabies. Cow. Intensivist, I intubated a patient with altered mental status. Lot of secretion is pouring around. Now the patient was diagnosed as rabies. I intubated, splash happened, I was not wearing a mask. This is an emergency intubation. Human to human transmission. So this is why we are discussing today how to possible there. So the Marina Beach case you already answered, yes, except few animals. For example, rat bite, squirrel bite, birds, human, most of the human, I'll come back to the human part little later of it. So except these 4 things, human bite does not require rabies, rat bite, squirrel bite, and if it is a bat. In India, bats are not transmitting. US is a different scenario. In India, bat will not transmit the rabies to me there. Bat will transmit Nipah, but bat won't transmit rabies in India. So these animals don't expect ARV. You can give TT, but don't expect ARV. So this is another thing there. This lady has got a pet of cat. The cat keep on biting her. This is a bite. What will you do now? She's playing with the cat. This is a provoking the cat. Just playing is a provoking. What do you mean by provoking? Anybody can define what is provoking? This is a definition. Walking past the dog is a provoking. You just walk past the dog, that's a provoking to the dog. So it's very difficult to say what is provoking, what is non-provoking. It's a bit difficult. So don't ask this type of history. You can ask the history, but what history we need to know. Similarly, people say my dog is a pet is a vaccinated. The dog is a vaccinated. So the animal is vaccinated. How far you are going to believe the vaccination is going to help you out? For example, so many people taken hepatitis B vaccinations. How many of you produce antibody? Similarly, during time of COVID, everybody taken the vaccinations. After vaccinations, how many of you got COVID? So the vaccination has got limitations. Not all vaccination is going to protect. I am not telling. This is an Indian rabies guidelines. Vaccinated, non-vaccinated. don't believe. Provoked, unprovoked, not believe, because Indian dogs are unpredictable. That's what they're telling by Indian guidelines. I'm not telling. Indian dogs are unpredictable. So this is one of the railway staff. So she's coming back from her office. Similar bite. The dog is roaming in the general, most of the public sector hospitals and offices, dogs were there. So the dog is keep on biting so many people there, and she is a victim this time. So what are you going to do now? Because the dog is keep on biting the people. Same dog. Just leave it. Take vaccinations, don't take it there. Whether we need to observe the dog, what is the principle? Usually the animal has got incubation period. People always confuse with the incubation period and the disease. The dog might have an incubation period of either 0 day to 3 months or something there. But once the dogs start behaving abnormally, the dog won't be alive more than 7 days. That's why we need to observe the animal. So once the dog manifests the symptoms of rabies, behaving abnormally, biting other people, catching the hair or something, behaving abnormally, that point of time, the dog and cat, this rule apply. 7 to 10 days, we need to observe the animal. If the animal is alive, the chances of rabies in the animal is 99.9. Medicine, it's not black and white, it is always gray. 99.97%, the animal is not having rabies. That's most important clue to me there. So observing the animal. So what questions I need to know for a rabies case? Whether the animal is a stay one or pet one. Stay one, very difficult to track. Pet one, easy to track. I need to observe the animal for 7 to 10 days. Whether the animal is a dog, cat, rat, that's what I need to know. If I know the need, I need to give the prophylaxis or not. So the first part in history taking is over. So this is one of the Swiggy delivery boy. He is bitten by a small puppy. Scratched it there. What are you going to do now? Only scratched by puppy, very small puppy, hardly 10 to 15 days. Chances of getting rabies is there? So we can't say whether it's a puppy or whether it's a big dog or not. Whatever animal, it's a dog means dog. Whether it's a puppy or kitten or something, I don't mind that. So the dog is a dog. Whether the immunity, mother has got infections, mother has got vaccination, transmitted the immunity to the puppy or kitten, we do not know. So animal is animal. We need to know the category of wound. This belongs to category 2 there. Even though category 1, the skin is intact. Even though there is no bleeding, but the bite mark or scratch mark is there. People say this is a scratch. Nail only scratched it. Why? When the rabid animal behave abnormally, the saliva pours on the nail. So if the animal scratches, risk of transmission is there. Don't say bite and scratch. Bite and scratch has got no meaning. Both can transmit the rabies viruses because the animal behaves abnormally, saliva pours on the nail, it scratches means it can transmit the disease to you. A cow was bitten. Usually the gastric acid will kill the rabies virus. The chances of surviving is bit low. So don't say cow's milk I've eaten, meat I've taken, whatever milk or meat, whatever things, usually. For example, the butcher has got a risk. For example, he can expose to the blood or he expose the secretions. But other person, the risk is nothing. Milk, because most of the time we boil the milk one. Second thing, we consume through the gastric acid will take care of it. So the risk is very nothing. Unless the person handling the butcher job type of things, the risk is there. So this is a person already completed the vaccinations 3 years back or 5 years back. Again bitten by the dog. What will you do now? You give vaccinations or immunoglobulin? The most of the emergency people call, I want to give immunoglobulin. This is a significant bite. They want to suture also. But the previous vaccinations, one time the person is vaccinated, no need for immunoglobulin. The person never vaccinated, immunoglobulin. Particularly, if you want to give at the site where you are going to suture, definitely you need to give it there. The next question is, suturing can be done or not done. Whether this wound is need to suture or not. Rabies bitten dog. The ear is gone, the scalp is open, whether you want to suture. If needed, yes, we can suture, but don't put a tight sutures, loose sutures. Put an immunoglobulin to the person not vaccinated previously before giving the sutures. So rabies immunoglobulin, you can suture it, but not a tight one. You can do a loose sutures we can do because we need to stop the bleeding. We want to protect some, for example, one other case I'm going to show in a later part of it, you can see this one. Then people always say, I have taken, this is what we need to do. Whether the animal is a stay animal or pet animal, whether it's a dog, cat or rat. The third thing is what category of wound, category 1, category 2, category 3. Category 1, there's no need if you are able to observe the animal. Category 2, ideally we give the vaccinations, observe the animal for 7 days. Category 3, never vaccinated, give immunoglobulin along with the vaccinations and if possible observe the animal. This is a simple logic we can do. Lot of guidelines, this is the guidelines from WHO have taken there. You can see. So what category? Category 1 means intact skin. This is category 3. Again, this is a young female child bitten by a stray dog. The dog catch hold of the child for a face and drag it for 2 feet. Not 2 feet, 2 meters. So the child was bitten not only in the face, scalp. For a female child, if you leave alone, scar will happen. So we need to do the thing. That point of time, the CM was involved. This is a real case from Kanchipuram. They shifted under our care because of this one. We provided care there. This is long time back. So this is category 2. This is category 3. All bite. For example, wild animal straight away category 3. Whether it's a monkey or whether some wild animal, put category 3 bite. So this is what we need to do right now. So this is a scalp also. Coming from school, how many want to suture? I told suture, if needed, you can do suture as per the Indian guidelines. But put immunoglobulin, loose sutures, not a tight sutures. WHO guidelines says yes. Usually say no, but if the bleeding or cosmetic reasons, yes. For a small wound, don't suture. If it is a cosmetic reasons or bleeding, yes, you can suture it, if needed. So the railway staff, what are going to do now? So she received 1 dose of intradermal. In railway hospital, they given intradermal. But right now she doesn't want to go to railway because waiting in a queue, taking a lot of time. She want to come back. You are not comfortable in giving intradermal. Can you switch over to intramuscular? First dose intradermal, second dose intramuscular? Practical one. How many says yes? Because I can't run the show. How many says intradermal, intramuscular? If needed, yes, we can change over. There is no differences between intradermal and intramuscular. Intradermal, why? Government sector, it saves a lot of vaccinations. 0.1 ml is required. With 1 ml vial, we can give for 10 people. For intramuscular, intradermal has got good immunity also. But we need to have train. We need to have skill. Without train, without skill, don't try intradermal. If you got a good skill, you are trained there, yes, we can give. Otherwise, intramuscular is a good thing. But intramuscular, we need to give more volume. So costly is there compared to intradermal. But the efficacy wise, it won't change. If you are not comfortable, give intramuscular, you can change over it. So this is a paper changing then intradermal to intramuscular. There is no major differences. Can we change? Yes, we can change. That's what guideline says. Then when to give, people want to know whether monoclonal antibody or immunoglobulin. Government hospitals, equine immunoglobulin. Equine immunoglobulin, they use it. Both equine and human immunoglobulin are effective. But what is the difference? Equine immunoglobulin, anaphylaxis is possible. So observe the person who has received it. But what is the differences between monoclonal antibody and immunoglobulin? Both are same. In fact, monoclonal antibody, the titers are much higher, but the cost is also a bit low compared to human immunoglobulin. Human immunoglobulin, 1 vial of 300 units is costing around almost like a 1 person of a 60 kilogram man. If you want to give immunoglobulin, it costs around 15,000 to 20,000. This is much cheaper. Is there any data? This is one of the big RCT in northern India. They showed monoclonal antibody. The titers are much higher. So monoclonal antibody is accepted now, not necessarily immunoglobulin. You can give antibodies. Monoclonal antibody can be tried. And this is one of the person, unfortunate person. Problem is he's a shop owner. What happened in front of his shop? One of the dog chased bitten a small school child there. So he chased the dog and he killed the dog. During the attack, the dog couple of times he fallen over the child. But the child went to the government hospital, taken the immunoglobulin vaccination, the child survived. This fellow thought, while chasing the dog, I fall in the ground and sustained some injury, and he never gone to the hospitals. But couple of times the dog never passed over him and scratched also him. He thought it is because of the abrasion he sustained in the chasing event. He doesn't take anything there. Unfortunately, 2 to 3 weeks, typical hydrophobia, he landed. The hydrophobia landed. He became very anxious. He became sort of depressed also. Why I got this disease? Because the child I saved it, but I am not able to save myself. So what happened in the depression? He started biting the staff nurses. So what will he do? I said human to human bite is not possible. This is a rabid hydrophobic man going to die in a couple of days. He started bitten a nurse. What will he do now? The intubated anesthetist, I am asking about it. This is a bitten by a rabid man. What will you do? Definitely I need to give the prophylaxis. So exceptions are there. So don't say always it's not possible. It need to be done. That means it need to be done. That's what we given. Immediately my housekeeping came. I went and cleaned the room. I also got exposure. We said no. So don't think that bitten, intubated people theoretically is possible. Rational is if the virus chances of getting in is possible, yes, we need to give. Otherwise it's not possible there. This is MMWR. We need to do the risk assessment. People intubated, people bitten by a rabid persons, yes, chances are there. In the street fight, school fight, children bite each other. Don't give rabies prophylaxis. Only TT is enough there. So that's what more enough. So obese person getting married next month. He wanted to know all vaccinations. Can pre-exposure vaccinations, rabies included? Who all take the rabies vaccination? So people are working for a Swiggy, Zomato, people are working in IT industry, coming late night with a two-wheeler, take the vaccination. All veterinary doctors, they take the vaccinations before joining it. All US person traveling India, they need to take the vaccinations before coming to India. Why? All Indian states contain dogs, all Indian temples contain monkeys. So they need to take the vaccinations before coming to India. This is the recommendations of the US CDC. So if you think the risk of bitten by a dog is very high, take the pre-exposure so that immunoglobulin is not required. PEP is always problematic because immunoglobulin costs everything. Pre-exposure, continuous risk. For example, the person working in the veterinary industry, yes, people are constantly exposed to the bite, they need to take it. So pre-exposure prophylaxis is required. The same algorithm book contains step 1, step 2, step 3 is also available for you. This is called WART approach. What sort of animal I'm dealing with it, what sort of bite it has got, whether we need to give the wound care everybody. Antibiotics for cat bite is more required. Rabies is selected individual. Rat, human, squirrel not needed. TT for everybody. Antibiotics. So these are all things available in my book. There are antibiotic books also. People are worried about it. So we come with a similar type of cases. Case-based learning on August 8th. The event is going to happen. Not August 8th, August 15th. We are going to keep in Chennai. This is an hybrid event. If you want to learn all case-based learning, please attend this conference. Thanks for the wonderful opportunity. Thank you, sir. I finished it.
Thank you very much, sir, for a very vivid, elaborate presentation on both the topics. Made it very easier for us. We are, lot of us had, practical doubts. So, any questions from the audience? Yeah.
Actually, the most important doubts you cleared was that the human bite, rat bite, bat bite, you need not give rabies. That's a really, really tough answer to the patient. Suppose this is bitten by a rat. So that's the point is cleared. And the vaccinated dog, unvaccinated, no difference. You have to vaccinate. That's the point. And all wild animals are grade 3. Grade 3 bites, category 3. So we need to aggressively treat. And of course, equine immunoglobulin anaphylaxis is common, but than the monoclonal antibody. So you prefer monoclonal antibody. So these are the take-home message for the treating physicians day-to-day life. Thank you very much, sir, for a brilliant presentation.
One more time, I want to reinforce: bat bite in India, it's not no. US, even if you found bat in your bed, they give the prophylaxis. India is a different scenario. Nipah is transmitted, but rabies is so far not transmitted.
Thank you, sir. Thank you very much, sir.
For the final talk of the day, so I would like to call upon Dr. G. Ravichandran, sir, MD/DD, dermatology, is a senior consultant Apollo Hospitals and Apollo Cancer Institute, studied from prestigious MMC and Stanley. And he has so much awards and accolades to his name. Professor A.S. Thambaya's centenary celebration oration he has done. And Professor Patrick Yosidian oration also he has performed. Welcome you, sir. Over to you. Thank you.
Very good evening to one and all. Thank you, chairpersons and the organizers. It's late evening. I think I'll. My department is very interesting because it's like radiology. It's an image-based specialty. It's a child's play for most of us to play the football match nowadays. Okay, I'll just quickly go through. Everybody knows about all these 3 diseases. I thought probably I will give you what is the best to be chosen to that patient, the recent updates. That should be the goal of this talk today. Next slide. Sorry. Yeah. The melanin protects us in many, many ways. But if it doesn't function, it gets destroyed. You get vitiligo. The depigmented patches, all of us know. And we have the different types are there. So I've been doing work for the last 30-35 years on this topic. It's one of the topic we dermatologists must definitely do a good job because it involves impact of life, the quality of life, the girls who doesn't get married, and so many issues starts building up. So this is called the vitiligo. We divide them into segmental and the non-segmental vitiligo. There are different types, as you can see in the photographs there. It's a very interesting one. Do we have an answer? Yes. So we can bring back the color there. How? We are going to see that today. There is no, you don't need a biopsy or you don't need anything else. There may be some family history. The girl to get married comes there, the mother says, will it go to the family? It is like that. So there is a autosomal dominant inheritance, but it's a very rare penetrance is there. So we have these topical treatments available. All of us use everything. All these years with partial results, with good results, and we have the steroids, tacrolimus was a big boon for us. Then we have the steroids, of course, steroid phobia is there. Whenever you treat a child with vitiligo, the mother says, no doctor, don't give me topical steroid or oral steroids. And it's a difficult, long drawn problem. Of course, we are able to fix this when it comes very, very early. But the best option now we see is JAK inhibitors. I think most of the specialties use JAK inhibitors. It's a wonderful novel molecule which is very effective in most of the autoimmune disorder, whether it's rheumatoid arthritis or psoriatic arthritis or ulcerative colitis or Crohn's disease. So this is how we do it, and I've been using a lot of JAK inhibitors. I'll show you the results. Okay, if it doesn't respond, we do surgical. So I'm trained in surgical dermatology for so many years. My favorite is I started with vitiligo surgery, but of late I've started doing non-cultured epidermal melanocyte cell transplantation, including culture melanocytes. So this is regenerative medicine is awesome now in every specialty. Regenerative medicine is upcoming so well. So I thought probably I'll give a small tinge. I'm not going to techniques and videographs, which I do it for my postgraduates, but I'm going to tell you the pre and post picture. Then you will believe that there is an answer. Doctor's children may have vitiligo, colleagues may have vitiligo, our children may get. So when you do that, please approach to a correct consultant and do it there. So oral tofacitinib, excellent molecule. We've been using pulse therapy for steroids those days, mini pulse, then the pulse therapy. I think all have been gone away by advent of oral tofacitinib. Tofa. Tofa is a wonderful molecule, but it has to be carefully used. Okay, we all know that. It's given for non-segmental vitiligo. 5 milligram twice daily is the ideal dose. 6 to 12 months dosage. We have set guidelines to do that. We need to do CBC, LFT, depending upon the younger individual. Very young girl came from Bangladesh, Dhaka, a 15-year-old girl with a difficult vitiligo, and this is after 6 months of a tofacitinib 5 milligram twice daily. She did extremely well. What I have observation is that even after stopping, cutting all the pigments back, the pigments gets retained. Probably it's an immune change. It is not a difficult disease to treat. I'm really surprised about this young boy. The mother used to come and cry in front of me, what best I can do. Nothing else, just a 5 milligram OD started with a 5 milligram BD. Within 6 months he did extremely well. The repigmentation is very uniform and smooth, not like phototherapy, we get follicular pigmentation. This is tuberculosis test is, Suresh Kumar was there anyway. We always send them to ID consultant for starting before any therapy. TB quantiferon is a must for all these people. Hepatitis C profile, hepatitis B, particularly in adults. We have to make sure that everything. And the side effects are very, very less, very, very safe. But low platelets, headache, opportunistic infection, viral infections are very, very common when you do the dosage. And herpes zoster reactivation, mild elevation of lipids, particularly if the patient have an hyperlipidemia. So that is why we do a baseline test for patients who are middle-aged or younger individuals. Women planning pregnancy and lactation. So we see lots of young girls, women getting married. How can I can't give tofacitinib. Live vaccination, concomitant use of COP inhibitors. This is a girl came all the way from Bangladesh, Dhaka. From the age of 15 till the age of 25, she had a segmental vitiligo. They tried everywhere, Singapore, everywhere, and she saw my profile and came. I never spoke. At the same day, I put her in the theatre in Apollo Cosmetic Surgery Center. I did a non-cultured melanocyte skin grafting. The post-operative picture is 2 months after that. The uniform, smooth color matching, we got a very good results. It's very selective. We have to choose the patient stable, segmental, focal vitiligo, including lip vitiligo, including fingertip vitiligos, can be easily covered, and it's permanent. This is the topic which we have to be very careful. We see around 4 million people involved with psoriasis. I have my colleagues of doctors with psoriasis. Arthritis is very, very common in the long run conditions. Cripple, it can cripple a patient. It can cripple everybody. So you have to be very clear in identifying the psoriasis. The patient comes and tells, doctor, I have psoriasis. Today morning I saw 3 patients with extensive psoriasis. Taken all the drugs, what will I do? Getting married, getting divorced, So this is a quality of life and very, very important that this is arises from complex interaction between genetic susceptibility, there's a genetic play, immune reactivation. After COVID, we saw so many of them with vitiligo and psoriasis, keratinocyte dysfunction, angiogenesis, stress is there, environmental stress is there. These are the factors which really unfold psoriasis. It's a chronic papilloma. We all know that silvery white scales with hospital sign positive. It's all there, but it can be now this is a systemic disease. So it's associated with other comorbid. Don't just ignore if your children or somebody comes with a psoriasis, small 1 or 2 plaque or scalp psoriasis. It's a systemic disease from day one because it is associated with obesity, non-alcoholic fatty liver disease, hyperlipidemia, diabetes, coronary artery disease. Moderate to severe psoriasis in middle, I lost 2 patients with cardiac arrest. MI. So be careful, screen them. I get with severe psoriasis, I get a cardiology evaluation for most of them 45, 50, 60. So be careful. It's not that just to apply some topicals, emollients or liquid paraffin. You have to be very clear. And arthritis, you have to be very clear. Particularly if nail psoriasis are involved, if there is an enthesopathy, definitely the patients will go for a crippling arthritis of the finger joints. So becomes very difficult if you have to initiate treatment very well. Of course, these are very classical findings. Extensive lesions are there. Scalp psoriasis, very, very difficult. I had few bureaucrats, doctor, I am not going to the court or wearing a black coat, doctor, every scales are there in my back. So much impact. It causes in a different style. The child doesn't go to school. The mother is crying because she can't walk in the kitchen if they have a palmoplantar psoriasis. Scalp psoriasis, arthropathic nail, 20 nail dystrophy. I had 2 patients last week. All the nails got destroyed. What will you do? Methotrexate. Anyway, I'll come to the topic of therapy. Yes, topical therapy. For mild lesions, you give topical steroids, vitamin D3 analog like calcipotriol, calcineurin inhibitor, particularly for flexural. Groin itch, 90% is fungal infection, tinea cruris. 10% is seborrheic dermatitis and psoriasis. Very, very important that we got to give flexural, so we can't give steroids because we see lots of patients who are using a topical steroid with antifungal combination in the groin lesion, coming the atrophic thin scar tissue, we even cannot do an angio there, cardiologist. So make sure that never use a topical steroid on the body fold areas, face, eyelids and children at all. Newer topicals are yet to come. The Tapaniraf is just being getting launched this month in India, but I don't know about the efficacy. Okay, this is the drug of choice. Hope you don't get psoriasis. If anyone develops psoriasis, please start as a naive therapy. Not wait till try this, try that. No. One day it's very mild, few plaques. After 6 months, it's going to be very severe, extensive lesions. So biologics are the in thing across India, across the world. We colleagues and myself, everyone is using extensive use of biologics. It's a very safe drug. It is the best drug. Affordability has come very, very well. You can talk to the stockist rate is very 1/3 of the price is given by the stockist. So that is why whenever biologics say it's 20,000, 25,000, 50,000, no. The stockist rate, if you can manage to give the rate, I think it's best available. And we have the, so many conditions are available. I will tell you how to give you. Phototherapy was there, narrowband EVB. I have a patient who bought phototherapy in the home, gone away. Methotrexate still holds very, very good. It's a poor man biologic. It's excellent drug. Excellent, but you have to be very careful. Check the liver, check the complete blood counts, and make sure that patient doesn't have any kind of malignancy in the past. Regular follow-up. We give 7 to 5.10 milligram per kilogram per week, along with folic acid supplementation. Once in 3 months, we have to assess them for periodical blood counts. Cyclosporin is a wonderful drug for difficult psoriasis to manage. 100 milligram to 200 milligram, 2 to 3 milligram per kilogram body weight for 4 to 6 months as a crisis buster. Psoriasis clears magic. Today morning I started a patient on 100 milligram BD. So we have to tide over the, you can't straight away afford a biologic. So, but once you start control the disease, clear the disease, we have to change to some other thing. Because methotrexate, particularly biologics therapy, reduces the inflammation in every part of the body. Whether it's the liver, it is the joint, it is the heart. The coronary arteries go for inflammation. That is why patients are prone to develop coronary artery disease. We have to control the inflammation by using these biologics. We have plenty of biologics. I think most of the colleagues must be using biologics in theirs across specialty. We started with Remacade. I'll show you a patient's photograph with Remacade. I admitted in Apollo hospitals. He received 6 doses of Remacade. He had a painful plaque psoriasis. Did extremely well. That was 15, 18 years ago. He is still, to my patient, he is still using a biologics. He is still using a newer biologics because of secondary failure, therapy failure. Enbrel is very much available. Etanercept, easy injection. We get it for few thousands now. You can start on the patient. Adalimumab, every orthopedic, every rheumatologist uses adalimumab. Excellent drug, quite safe. I have never seen a reactivation of tuberculosis in adalimumab therapy. It's more useful for joint involvement, psoriasis with joint therapy. 40 milligrams subcutaneous once in 2 weeks for 3 to 6 months, subsequently once a month. But if you stop and restart, there is a secondary failure, antibodies develop against adalimumab. So then we need to go for a newer biological, secukinumab, ucikunimab. Okay, these are the maps which are very ucikunimab is very effective, secukinumab is very effective, and they are all very costly, but they say that according to Western literature, it's a lifelong therapy. Psoriasis remains lifelong. When it is going to flare up, we do not know. We have to maintain. If the patients cannot afford, if there are no side effects, patients can be rotated to apremilast. It's one of the best drugs. 50% of patients do very well. It is a PD4 small molecule. We give 10 milligram for first week, 20 milligram for the next week, 30 milligram subsequently BD for as long as they can do. In US, if the patient doesn't come under category of biologics therapy, they switch over to apremilast. So it's excellent. I have seen only the nausea, vomiting, diarrhea is the most common symptom with abdominal pain. So this is a wonderful drug. So we have to be very clear. It affects, all these TNF, all these biologics work by changing the immune system, particularly against the T cells, against the TNF inflammatory IL-23, IL-17, IL-16, 23A. So all these things have to be taken into account. This is how it goes very well. Ucikunimab targets, it's all there in the textbook. It's not that. How and when and where to use this, it's a master of art. So we have learned from my patients. I've been using around 50, 60 patients are on biologics now with me for the last few years, and all of them are very happy. If the failure occurs, we have to give. Young girl to be married, young man to be married, please, first time visit comes to you with generalized psoriasis, I straight away start. I don't wait for rotational therapy and all. Biologics are going to stay, and it is going to be the future in India. Most of the centers across India, even my colleagues are using biologics left and right. Yes, it is given in subcutaneous form. Those days intravenous. Subcutaneous is all biologics are given subcutaneous. I asked my stockist fellow to deliver to the patient. The patient we teach, he takes the injection like insulin. So easy. It's not a very problematic one. Reassure them. It's very clear injections. Very effective, and secondary failures it occurs, switch over to newer biologics. Possible side effects, very rare. I have never seen except one reactivation of old latent tuberculosis. Make sure the patients do not have. Okay, this is how we cost factor is the only concern. I think India is the best country to get biologics. My patients carry it, abroad patients carry it from ice pack to other countries like Dubai, Malaysia, Singapore, even United States. So that's so effective here. This is my patient from last 20 years I've been following him. I started with Remacade, and now he is on tredelimumab, IL-23 he is taking. So this is how the plaque, painful psoriasis. He is like my brother. He says, "Doctor, I'm living because of you." But he's a rich man. He takes the injection, calls the stockist, he injects himself. He clears so beautifully well. And now, last month, he called me that, "Sir, doctor, I have no patches at all." So what we are going to achieve? We are going to achieve a complete clearance of psoriatic lesions. Ixekizumab does the capillary, it's called. Capillary does the job from Eli Lilly. So it's a very wonderful drug. If the severity is there, we have to hesitate. We should not hesitate. We have to start. So this patient did extremely well, including the nail psoriasis became very, very well, and that is one. That psoriasis, vitiligo, hair disorder, I don't know. When a patient comes, I don't know what's going to happen to the patient or to me. It's walking on a thorny foot. Nothing can be done. So we talk about hair cycle, we talk about anagen, catagen, all beauty parlors are spread across India, Chennai. You see every place, they go there for hair styling, hair keratin treatment. Everything is possible now, but they lose hair. What are the reasons for the hair loss? There are many, many losses are there. And before that, I will tell you, okay, we have the definition is there. This is the commonest one, telogen effluvium. Post-COVID, all the women lost, men lost hair. We don't know the reason for that. The drugs, fever, post-dengue, post-delivery, post-chikungunya, myocardial infarction, traumatic surgery, pregnancy, accidents, very common. Then crash dieting. Nowadays the fancy is crash dieting. All can lose hair. It is called telogen effluvium. There is no treatment needed. If any associated hypothyroidism, anemia or deficiency is there, vitamin D, you correct it, but it settles on its own reassurance. If you start giving minoxidil, it will worsen more. The patient, doctor, why did you give me? So we don't give minoxidil in telogen effluvium. So this is of course the lady, she did extremely well after that. This is of course lupus erythematosus anti-cancer drug. This is one. I just wanted to, this is the most important topical, alopecia areata. I have two doctor colleagues of mine developed highest stress. An orthopedic surgeon, IT rate, very, very sad. So they get small patches, and then it is, we have the different types are there. We have the totalis, universalis, uffiasis, steroids, sensitizer, puvat, all this, minoxidil, everything. But what is the latest treatment? Latest treatment. See, this guy completely lost all the hair. Alopecia totalis. See his hair? The father is crying. So this is the boon again, JAK inhibitors. Tofacitinib. I think most of you must be using tofacitinib. Can you raise your hands who are all using tofacitinib? Yes, I am happy. So it's a good drug. It's a wonderful non-steroid drug. But see, this girl, all they again came from Bangladesh. 5 years of alopecia totalis, lost everything. I didn't know tofacitinib was launched here in India. So I gave her 5 milligram to start with, subsequently BD, and this is after 6 months after therapy. They asked me to come to Dhaka. Maybe I'll be received like a king. Okay, so Trofast changes excellent overview for vitiligo, psoriasis, or alopecia areata. Any inflammatory T-cell mediated disease, tofacitinib T for T. Those days we used to use tacrolimus for T. All T cells in the dermis, you give tacrolimus. Now we see tofacitinib for all T-cell mediated disease, and we have the, all of us are bald. I think there is no other choice. And we start at the age of 16. The father is totally bald with a different pattern. You start them quickly, start them on minoxidil with finasteride till the age of 20, 25. Because of that time the androgenic influence is there. They do the typical, very alpha inhibitors can be given. Finasteride can be given. Carefully, I don't give dutasteride. Finasteride can be given orally if it's advancing alopecia, because it's a very difficult. The boys, the young men doesn't go to work. They get depression, become depressive psychosis. So they didn't get married, they get divorced. So many issues, psychosocial impact. Oral minoxidil is the latest drug. I stopped using topical minoxidil. Messy, difficult to apply, 2 to 3 years. Who will buy and apply? Scaling, irritation, hypotension. If we give for women, they get hirsutism, overgrowth of hairs in the facial hairs. So gone are the days. The oral minoxidil is available for across many companies. We give it for women too. It's not that middle-aged women, perimenopausal, we have to give oral minoxidil. We have the Ludwig pattern, the Hamilton-Bailey classifications are available. 1.25 we start, then increase it to 5 BD for 6 months to 12 months. You can continue as long as the patient wants hair. Hypotension, there are side effects are there, but quite safe. Make sure that the patients are not hypertensive. They have to monitor, check vitals. This is, of course, I spoke to my friend today morning. We do a lot of hair transplantation, Apollo Cosmetic, along with Dr. Ramachandran. excellent, we have to select the patient and gives an excellent result. Androgenic, this boy will definitely do very, very well with minoxidil and finasteride combination. And of course, the bitemporal, we have to plan for hair transplantation around follicular unit extraction. Excellent procedure, OPD procedure, so 5 to 6 hours we can definitely do. When the father gets bald, the son is likely to get bald. So pick them early. The school child, never ignore the children that, okay, pa, I'm losing hair. No. If the father and uncle, the grandfather is bald, it's a genetic transmission. Please be more active. And female also come and cry. They said, what is this? They get really, really depressed. And we have to give topical minoxidil, can be given 5%. And along with oral minoxidil is the choice of drug. Of course, this is the hair, one of the biggest industry in the world, biggest aesthetic center. My Professor Tambaya used to say, a man, you will be on top of the world when you put hair on the bald scalp and remove the girl's chin hair. So we have laser hair reduction and hair transplantation. So this is the kind of scenario. Small hair keratin treatment, women doctors are there, so they contain lots of issues. We talk about minoxidil, of course, next time maybe invite, I will give a rapid fire of dermatological conditions for 1 hour. This very practical issue in our topic. And hair keratin, I have seen young girls going there spending huge money for hairstyles, acute kidney injury. If you can check the Google, you will get to know that hair keratin treatments can result in acute kidney injury. Please be aware, any nephrologists are here, they will definitely recognize. I was called to see acute kidney injury. They couldn't find out the cause, but I picked up because very young, beautiful girl with excellent, I asked her, did you go for hair keratin treatment? I asked her, did you pay 25,000 or 50,000? What thing you're talking, doctor? But that was the story, right? So make sure, scenario you have to, because we learned all these years, we've been taught by our professors, seen patients. It's interesting that the topic is skin is the largest organ in the body. What your mind do not know, your eyes cannot see. Thank you.
Three topics, 30 minutes. That's a huge task, sir. And you could be able to cover so many things, new points, especially drugs like TOFA. I think very much exhaustive, sir. Within 30 minutes, I think we got a lot of information on 3 huge topics, practical points. Over to Parandaman, sir. Thank you.
Sir, actually, it's a wonderful presentation. We have learned a lot of practical tips for practice. But what we observed, any autoimmune disorders, the triggered by the infection. Infection triggers the autoimmune antigen, antibody production. So if anything, especially if a T lymphocytes in the skin is more long-lived than T lymphocytes in the other part of the body. If that is the case, the point of giving antigenic treatment like antifungal, antibiotic, anti-chemo, like protozoal, will it help in accelerating the disease, worsening?
As you correctly see, infections can trigger psoriasis or
Yes.
any inflammatory skin disorders.
Okay.
Those days when we see children with gutted psoriasis, my professor always send them to tonsillectomy, streptococcal triggering factor in childhood psoriasis, gutted psoriasis. Okay. So they don't migrate to classical psoriasis. Infections can trigger any inflammatory condition, as we seen in COVID or viral or bacterial, sepsis induced. It's possible.
Yes, sir. What antibiotic you choose in those situations, like skin disorders?
We prefer macrolides to begin with, then cephalosporins, and then anything we can give, sir, depending upon the culture and sensitivity. Staphylococcus is a little risky in certain size, particularly in pediatric population. Staphylococcus in neonates or newborns, Staphylococcus scalded skin syndrome from the umbilical sepsis or otitis media or bullous impetigo. We've been called to see emergency in the children's hospital. Still we are getting. So it's emergency situation. We have an emergency dermatology. Maybe next time I can address that. We have drug reactions. Most important. I think I'll ask Narra somebody. Drug reactions is the most important for all of us. I have one patient with an Hodgkin's lymphoma, antibiotic-induced Steven-Johnson toxic epidermal necrolysis. 2 months ago, we lost a patient in our hospital with facial trigeminal carbamazepine-induced toxic epidermal necrolysis. Awareness is important. Early recognition is very, very important. Generally, it's difficult for the other consultant to recognize a skin rash. Never, please, if you suspect, the patient comes and tells you, please monitor drug eruptions. I would like to address you one day, maybe in the next chance meeting is given. Thank you so much.
Thank you very much, sir. We will give a big round of applause for the presenter, which wonderfully has enlightened us about the dermatology condition. Thank you very much, sir.
Thank you, thank you.
Yes.
All, thank you so much.
We will conclude this CME and our conference. Thank you.
Ladies and gentlemen, with that we come to the conclusion of the DCON 2026 annual conference. It's pretty amazing that how we ended this conference like with an interesting topic, hair and hair related issues. I don't think we ever find a solution for hair related issues, but it was pretty interesting. And I would like to extend my heartfelt thanks to all our distinguished faculty, chairpersons, speakers, and every member of the organizing committee whose efforts have made today's conference a beautiful success. And to present the vote of thanks, I now present Mr. Jai Kumar, Doctor. Over to you, sir.
Good evening to one and all present here. We just finished an excellent conference. I would like to express my sincere gratitude to all our speakers and chairpersons. A special thanks to our D Club President, Dr. D. Dhanamithran sir, our organizing secretary, Dr. A. Natarajan sir, and organizing chairman, Professor Dr. P. Parandaman sir, for the immense contribution in organizing this wonderful conference. I also extend my thanks to our organizing joint secretary, Dr. U. Mohan sir, and our D Club treasurer, Dr. Sarath Babu sir. My appreciation and thanks to our scientific committee, Dr. Kannan sir, Dr. Jayganesh sir, and Dr. Arvind Babu sir. I also thank our reception committee, Dr. Kamal Kannan sir, Ram Kumar sir, and Vetrivel sir. Also a special thanks to our senior D Club members, Dr. Murugan sir, Dr. Arumuli sir, and also our new physiology professor, Dr. Sendil Kumar sir. Furthermore, I thank the event management and the AV team for the seamless execution and the hotel staff for the excellent food and hospitality. Our heartfelt thanks to the sponsors for the valuable contribution and support. Most importantly, I thank you all the delegates who attended the conference and made it a grand success. So finally, I warmly invite you all to our upcoming D Mantra conference, which focus on diabetes in the November 2026. Thank you all doctors. Have a wonderful evening and a great weekend ahead.
Thank you, sir. That was really sweet. And I personally enjoyed today's conference and I found some information quite intriguing. So thank you for including me to be a part of this as well. And I sincerely thank all of the doctors for your service. Thank you so much. Have a great day. Thank you.